plenary session reviewing progress. For that, we have our esteemed chairpersons, Professor Dr. Hemant Kumar Kar and Dr. Hariram Kumar sir. I welcome them to kindly join us on the stage and start the session. So Dr. Kar is very well known for his works in leprosy, and he is currently the emeritus professor in AIIMS Hospital. Now, Hariram Kumar sir is esteemed and one of the senior most dermatologists of Patna, Bihar. So I request both of them to kindly start the session.
Good morning to everybody. This is the first session of the first day of the conference, Lepcon 26. The first batsman is Professor Bhushan Kumar. He is the guru of leprosy for each and everybody. It's a privilege for us to invite our guru to as an open batsman for this conference. Sir doesn't need any distinction. He is the double FRCP. I can say he has a unique distinction. He was the president of all three associations, IADVL, STI, AIDS, and leprosy. And that uniqueness is bestowed on him because you can imagine how much is popular in this country and internationally also. His contribution in leprosy is immense. He was the editor of our IL leprosy, textbook of leprosy, and also international textbook of STI also. So he is pioneer in the both field of dermatology, leprosy, and STI. With these few words, I invite Professor Bhushan Kumar. He will speak on the most important topic, neuritis. Very, very difficult neural leprosy. Very, very difficult. We face each and everybody is facing the problem of management of neuritis. Sir.
Thank you very much, chairpersons, and thank you for the honor which has been endowed on me by the organizers. I'm enjoying my visit to this place after about 2 decades. Dr. Jha organized one conference here long back. Thank you for all the kind words. The opening person has a responsibility as well, in addition to whatever honor has been conferred on me. Thank you for the kind words once again. So, this is something interesting in a way that it covers our area or our part of the world rather than, rather than most of the world for that matter. It is there, but probably we are involved in this process a little more. So, as we know that the old timers, they had classified leprosy without knowing much about the disease, that when it was only the neuropathy, they called it as the anesthetose, and when there were prominent inflated lesions, they call it as tuberculosis. Subsequently, everybody who had worked in India or was related to leprosy somewhere, they have talked about the sensory neuropathy, again indicating nerve involvement, and the sections showing some dark nuclei, again conveying that the neurons were involved in it. We start with Virchow. He said that compared to sensory disturbances, motor changes are less prominent, again indicating that neuropathy is important. So this is what has been said many times. Uh, According to the information maybe nicer mentioned about leprosy or the mycobacterium, but probably he was not aware of the little more about what has been actually credited to him. This may not be exactly true, but yes, his name is there that he has mentioned about the leprosy in this. So then the other people working here, Nur, Fait, Khanolkar, and some people from abroad, and Auntie et al., they have all said that nerves are the primary target of the leprosy, and the macules appear when the nerves in that involved area get dissolved, and then you get some lesions there. So this is what it is. And then of course Auntie lately said that because he did extensive studies in the BLP project related to that, and also the Center for Research about leprosy. Knowing all this, the International Leprosy Congress, they tried to somehow sub-classify or classify leprosy for purposes of understanding and for purposes that we know what we are talking about. So the nodular type or the lesions which were there, they were classified as lepromatous. Not every lesion or every nodule of leprosy is lepromatous, but only for their understanding or the terminology used at that time. And the neural N1, 2, 3, again about the extent of the disease. Then the Indian Association of Leprologists, they classified leprosy into 6 types, and of course the polyneuritic was one important group. So then Wade, Cochrane, and Devi, they all talked about the primary nerve involvement, subsequently leading to the development of the lesions. But now when we are talking about pure neuritic leprosy, so this means that we identify that there is a group which starts as nerve involvement and stays as pure neuritic form for a good length of time. Not everybody, not every patient will stay as neuritic leprosy, but some of them will develop subsequent skin lesions, and then of course their classification will change depending upon what are the clinical features of the skin involvement, but majority of the patients will stay as neuritic leprosy. So in the definition, we have to say that there is exclusive nerve involvement, nerve deficit, with or without nerve thickening or cutaneous lesions. That is the primary thing here. I can't, no, I think it's too far. Maybe it is not working. Sorry about that. So when we are talking about nerve involvement, it has to have the autonomic component as well, which will produce diminished sweating, dryness of the skin, and loss of appendages. Motor deficit will lead on to the weakness of the muscles, paresis, trophic ulcers, and all these deformities and contractures. Now about the prevalence, as we said that it is primarily the Asian continent, or we are the primary people who are involved in this. Large number of patients examined by Brown, and नहीं ये तो ठीक है मैं उसकी उधर कर रहा था ये तो ठीक है अच्छा इधर से करें ठीक ओके thank you. So this was one study, and there were long study undertaken over about 3 decades, and Brown said that yes, most of the lesions, most of the patients start with the neural type of or the neuroanesthetic type of presentation, and subsequently develop lesions of leprosy. Noordin found something like 80 patients and it came down to 8 patients per 1,000. Dongre, again, large number of patients, 5.5%, that was the incidence. Mahajan et al., 4.6. These are the various things which are various workers have given. And the last or the latest study from Chandigarh, Mala, Bhalla et al., and she said about 3.3%. But the figures in India have varied from 4.6 to 17.7%. Unfortunately or fortunately, more in southern India as compared to the western India. Then the pattern of nerve involvement. As we know that there can be a single nerve involved, more nerves involved, and it can be a symmetrical type of neuropathy. Most common is single nerve involvement, mononeuritic, and more nerves, mononeuritic multiplex. Subsequent studies found out that mononeuritic is the most common, followed by mononeuritic multiplex and symmetrical. Then when we try to confirm the diagnosis or the findings what we have, various studies from Antia and his group, McDougall, EFSA, latest study, and not the study, I would say, it's a case report, and Talwar et al., they again found out that most of the patients had a histopathology picture like that of TTBT type, and only rarely or uncommon it was to find the BLLL type of leprosy. Reactions in the nerve were very, very rare, and only case reports are there. I have mentioned this case report published this year only by EFSA et al. That the nerves showed type 2 reaction. Type 1 reaction, if we talk about reactions are very uncommon, but type 1 is a little more than what you see in type 2, And the other thing is, to support this, lepromine positivity is more indicating that it is more towards the borderline spectrum, borderline tuberculite type of spectrum, rather than the borderline lepromatous type of spectrum. And to further strengthen this, the AFB has been found in very few patients, and so again saying that the lepromatous type of or BLLL type of histopathology or the picture suggesting that is less common as compared to the TTBT type. These are the pictures showing nerve involvement and various types of granulomas. Then again saying the same thing, the Mitsuda, another component, has been added again to support that it is more with a good spectrum, with good immunity that the disease presents rather than the other thing. So these studies again indicate the same which I have just summarized. When we talk about what people have done from various nerves, let's say there is a suspected case of neuritic leprosy and they have done the biopsies, you see that from 67, 35, and this is one study which is important, that Jardim said followed 35 patients with suspected leprosy for 11 years, and nerve biopsy confirmed this in 1/3 of the patients. Various studies undertaking various kind of parameters, whatever is there in the mind of that scientist, to prove the point that it is again a borderline tuberculite of leprosy, Mitsuda positive, lepra bacilli are not usually seen, and the histopathology is more of BTT type of pathology. Now the diagnosis, again when we are talking about nerve involvement, so we have to assess the nerve functions with whatever means we have, otherwise there is no absolute criteria. The standard things which we do, that we have to reconfirm that there is no that there is no skin lesion, and we sometimes the studies by various people, including Sujay, that even the normal-looking skin can have initially, if you look for it, some non-specific changes. Some people have even shown that there is a classical pathology of a definitive kind of leprosy. Then the other thing is that when we are looking at the non-specific pathology, because lepra bacilli are not often demonstrated, so people have tried to look for LAM and PGL1 as serology, and then lately somebody had suggested that S100 staining can also be helpful. Not sure about it. PCR was the one which was suggested, and definitely you will hear more from Chaitanya when he talks about the diagnosis. So at the moment, probably PCR is the one, if you have the investigation available, which will give you the better, then of course, lepromine sensitivity indirectly, nothing very much about it. So this is just 1 minute I'll take that when we are talking about the nerve involvement, that one slide is missing here. You try to exclude let the neurologist exclude all the other diseases. When we are talking about the differentials, we look for the absence of sensations, dryness, fissuring, muscle weakness and all, and then you either do the muscle biopsy if it is possible from a sensory nerve, or you do FNSE, whatever. FNSE is definitely safer, but you may not hit the exact thing. If you find the bacilli or a classical pathology, then it's fine. Otherwise, only you have to go by the clinical parameters. Electrophysiology, HRUS may help, not always, but non-invasive procedures, that's why. Most of the patients, I'll just take 2 minutes, sorry about that. Most of the patients, as I stated earlier, will go through the disease process over years like that only, but about 10, 15, 20% of the patients will develop lesions, and they have developed when observed over a period of time after the institution of the anti-leprosy treatment, or people have developed reaction and then subsequently lesions have appeared. Sujay has good studies on that. Again, the same thing, which I said earlier, that the so-called involved anesthetic area, lesion or no lesion, it has to be investigated for histopathology as well as slit smear and whatever other supporting systems are available. This is just to say that nerve involvement is primary, and it will lead to various types of deformities. It will lead to various other complications if not treated early. So many studies that up to 60% of the patients will end up this. All patients need to be given treatment for full 1 year, nerve involved or more, and the patients have to be observed for more than 2 years at least to see if anything else develops or a reaction appears in the nerve. Relapses are uncommon but difficult to diagnose. This is interesting study which one of our chairpersons on the table is a co-author in this. The patient, after being treated for neuritic leprosy, relapsed with 4+ skin smear positivity and ENL reaction. Then about the conclusions, I need not say more, which I have already said, that PNL supports the hypothesis that all leprosy is neural in inception and all other forms emerge. Thank you very much for your attention.
Thank you. Thank you, Dr. Bhushan Kumarji, for your excellent detail about neural leprosy.
Fine? Thank you. Thank you very much. Thank you, everybody.
Our next speaker is Dr. Sandeep Chaitanya, early diagnosis in leprosy. Please, Dr. Sandeep Chaitanya.
Good morning. Sincere thanks to the chair and to the organizing team for inviting me to present here at the Lepcon 2026. All right, okay. I'll be talking today about the early diagnosis in leprosy. I haven't introduced an introductory slide, but I think they might have already shown that. I work as an assistant.
You don't need any introduction. You're a pioneer in doing the early diagnosis, lab diagnosis, University of Cambridge. Please carry on.
Go ahead. Right. Thank you, sir. Yeah. So before going into the talk, I thought of giving some sort of an explanation or a small definition around early diagnosis of leprosy, because that's been a topic which had its own controversies in different contexts, as most of us know, as how early is early and what is early in the context of leprosy. So I just set these few sentences here. Early diagnosis of leprosy is the timely identification of clinical leprosy or of subclinical Mycobacterium leprae or Mycobacterium lepromatosis infection in high-risk individuals before advanced disease, irreversible nerve damage, disability, or onward transmission occur, so that prompt treatment or prophylactic intervention can be initiated. So this is guided by a document like a target product profile that you're seeing on the top there. Which slides are not changing. And then different approaches, as we know, starting from field level detection involving just detecting the lesion, the sensory loss, followed by a smear collection examination, if histopathology is available, histopathological examination, coupled by clinical examination, which is quite important, it's still strongly practiced, and any other innovative or laboratory-based tools that are still, I would say, in development, which includes ultrasonography, serological tests or lateral flow assays, PCRs of different types, all resulting in a decision that would involve either an MDT or a post-exposure prophylaxis, or maybe none, so excluding a case of leprosy. While talking about diagnostics, I normally would like to mention this pathway. Any diagnostic development involves thinking about the use case. How relevant is a diagnostic for a particular use case in leprosy? So it involves developing target product profiles. It also involves developing a roadmap or a pathway towards developing a viable product that would have some value beyond just diagnosis and has got a potential to get into the market and translate it to different contexts and practices. The third important aspect is not to undermine what has already been invested in terms of time, research, science, and efforts to develop something by actually reviewing the existing technologies and aligning them with the TPPs, clinical and analytical validations, which several studies are already underway, then followed by regulatory submissions. I just want to take the opportunity to mention about the WHO's current protocol of doing an ERPD review in 45 days, and then implementation and scale up, which involves its own complications and intricacies. Below all this is a diagnostic strategy. Why would a clinician need to use your diagnostic, whatever you develop in the context, unless it suits a particular use case? Over the years, we have worked on developing these target product profiles, these guidelines as to what is needed in terms of either doing an early diagnosis or detecting infection in asymptomatic high-risk individuals that live with index cases of leprosy, or a target product profile that would set characteristics for a test that would help confirm a case of leprosy. We have also defined a pathway in consultation with several experts around the world. Some of you seated here were also involved in developing this roadmap, which WHO is picking up to publish soon. That being said, I just want to quickly mention, because not that we just talk here about a test to detect infection, but it's also a test to confirm diagnosis, because early cases of leprosy, as we know, have very minimal signs and symptoms. And in such cases, how would a confirmatory test would either confirm or exclude a case of leprosy? As we know, there are standard tests, slit skin smears, examinations, and histopathology accepted globally and currently recommended by WHO. And there are no other diagnostics currently recommended by WHO in the guidelines for routine use, but just wanted to mention these standard tests before we move forward. Then comes all these newer technologies, especially starting with molecular diagnostics, because that's my area of work for the last few years. As we know, there are several technologies in development, technologies in use already, because they were recommended in other diseases, and it's the decision of the clinician at times to depend on some of these technologies to decide their diagnosis. So the first one is the standard qPCR, which is being used in several labs to help clinicians confirm a case of leprosy, followed by more field compatible or point of care compatible technologies like TrueNat, BioMeme, and then some technologies that are in development like the RapidX, LAMP, CRISPR-Cas12a, and others. So these are some of the technologies. I have put them at a very high level because there are several other groups working on much miniaturized systems that could detect the disease in less than 3 minutes and things like that. But I don't want to go into those details because I think the large classes are still representative in this particular picture. And that being said, we should also have the products or lab reagents that are point of care or field compatible. For that, there are several technologies that are emerging. One is the master mixes being lyophilized. It's not a new concept, has been used in several other diseases, but we thought that at a point we should translate this to leprosy work, because if we have to support supply chain, if we have to take these products to the context, they need to be stable at different temperatures. They should have stability in terms of their activity and also in terms of their ease of use. So different groups again attempted to develop these lyophilized point-of-care compatible reagents, of which BioMeme and NEB, New England Biolabs, together started developing these multiplex molecular assays to detect Mycobacterium leprae. We have a TrueNat cartridge developed by the groups here, which is also highly specific for Mycobacterium leprae. A group from Brazil has also developed something called as AIIMS, a kit that efficiently picks up Mycobacterium leprae DNA in the clinical specimens. That being said, I also wanted to remind the groups of the TPP requirements, because as we develop these tests, as we do further research on identifying potential solutions, we should always keep in mind what is needed in terms of sensitivity, specificity requirements for each of the use cases that we define here. So there are two TPP requirements for early detection of infection in asymptomatic individuals. Definitely a test would require 81% sensitivity. People may ask, how do we derive at these numbers? It's a sort of an intense exercise, reviewing publications in the last 30 years with the help of experts from different organizations, including Gates Foundation, and some statisticians to come up with these values. These are still predictive values, but I would say that's something that's definitely needed. If you have a test in your hand, your test should perform at least at 81% sensitivity to be used in individuals with asymptomatic detecting infection in asymptomatic individuals. Same way, 99.5% specificity. If it is a confirmatory test, definitely 90% sensitivity and 99% specificity. I just looked at some of the technologies and where we are with in terms of screening asymptomatic contacts. A bit of an intense slide, but I'll quickly take through. For the PCRs, so far, PCRs could detect infection in asymptomatic contacts only at a range of 0.6 to 31%. And by multiplexing, that value has gone up to 40%. So if you screen 100 people, you should be able to detect with your qPCR to 40% of the individuals with M. leprae infection if we use some of these targets that are listed here. Same with RLEP lamp. These LODs are slowly improving when the false positivity has also gone down significantly. There was also a recent publication on the hi-fi lamp with saliva and swab samples where the LOD, the limit of detection, is up to 43 genome copies per reaction. For confirmatory diagnosis, qPCR has always performed exceptionally well, especially in multibacillary disease. 80 to 100%, now 100% nearly cases can be detected using PCR in multibacillary. In paucibacillary, 31 to 86%. There were recent reports showing around 86%. And the meta-analysis on the specificity has shown around 99.9, which is way fitting into the TPP requirements. Again, using the same type of gene targets that I was talking earlier, mainly the repetitive sequences in the genome of Mycobacterium leprae. Conventional PCR has been around 78 for MB, 31 for PB, and that's been the case in several studies. People almost stopped using them these days. Multiplex PCRs definitely enhance sensitivity because we are targeting multiple regions of the genome. So sensitivity has gone up quite high to almost 100% if it is confirmatory diagnosis, and if it is asymptomatic individuals, nearly 40%. There are some reports of digital droplet PCRs, but they're quite sort of not very common reports, so I just mentioned them here, both the FISH and the digital droplet PCR. Just wanted to quickly show this slide. This is the type of work we did over the past 6 years with support of Hope Rises International, American Leprosy Missions. Sample collection, DNA extraction using cartridge-based technology in 1 to 2 minutes, lyophilized molecular assays, and a PCR that works in the field, near field, without any power supply, a battery-operated BioMIM qPCR system. With a mobile phone app. We compared it with reagents from different companies, and we have seen the performance is quite comparable. And also the cutoff values that we have managed to draw across Leddy-Joplin classifications using this particular technology seems promising. We have gone almost till 40 CTs trying to negate even a dimer that exists within the tube. We recently started working with this particular technology. I'm sorry, the fonts were quite low. This was one of the Cambridge innovations again. It's a plasmonic PCR, which we tested in Hyderabad a couple of months ago with Dr. Sujay's laboratory. Doesn't require any DNA extraction. Take the slit skin scraping, straight away introduce the material into the PCR tube in the machine, and the machine runs on a battery for 10 minutes and gives you an amplification equivalent to a standard PCR. It's been tested widely. Technology readiness level according to the MHRD UK standards is 7, indicating that the device is ready for in vitro diagnostic use. We'll try to expand its use. The machine is just $1,000 and the test is less than $1. We're trying to understand the biology behind the disruption and other things. Once it's cleared out, we should be in a position to roll it out much more quickly globally. Just wanted to also mention about serology and rapid tests, as Professor Bhushan was mentioning earlier. There are several studies done and lots of effort that has gone into developing rapid tests, and I just wanted to mention where they stand now, especially with the work of Professor Annemiek Geluk in this area. A recent test, PGL1QUR Rapid, has managed to detect MB cases, because the first background check would normally be testing the population that are already MB or PB. What happened was that these antibodies were more detectable in the MB populations, as we mostly know, and not much in the PB populations. There was 95 sensitivity, 100% specificity, and 91 sensitivity, 99 specificity. Have also used these technologies in larger trials, clinical trials, supporting evidence on understanding the seroprevalence or seropositivity in the populations that they were studying. And with the test, they could also understand the change when a particular chemoprophylactic intervention was administered. Similarly, there were quite a good number of studies on understanding host transcriptomics and also defining biomarker signatures. Risk for LEP has managed to predict the onset of leprosy 4 to 61 months before clinical diagnosis with an AUC of 86.4. But I would say that when we take some of these technologies on board, we should be mindful about the context where the testing has been done, and reproducibility is very important for some of these studies. Similarly, lesion-based host markers could even differentiate multibacillary and postbacillary disease. Just wanted, notwithstanding, and recently we started a study with the support of LRI with Dr. Sujai's group, and tried to do an ultrasonography on the nerves using a handheld ultrasonography device, as you can see to the right there. The initial results showed quite a comparable performance with the standard ultrasonography device, and maybe Sujai would get the opportunity to talk more about it at some point. Quite a lot of other advancements are in place, but we don't know the use cases yet, especially the AI-based classification algorithms with 96.4 accuracy and 96.46 under the AUC. There are other biosensors that are coming up as well. All in all, I would say that there is no single technology that covers all early diagnostic needs in leprosy, and confirmation still requires multiple technologies and approaches. These slides might be shared with the team later. Capacity building and training is an integral component. We need to go to the labs, we need to understand how labs would be able to use the technologies if you introduce a diagnostic into context. And then there is also a need for a harmonized harmonized EQA procedure that would help harmonize laboratories to follow similar protocols, not trying to create any ambiguity in the approaches of detecting these diseases. Thank you very much, and I'm open to questions.
Thank you, Dr. Sandeep, Chaitanya. Very excellent presentation. It shows how much progress we have made in early diagnosis of leprosy. We clinicians really face problems how to diagnose the cases early lesions, particularly in the face and in children. We face problems. We are really looking for an early laboratory test, good test to confirm diagnosis. And this portable qPCR has done a lot of things. We have a great hope of portable qPCR, which you can take to the village in the community for diagnosis of early leprosy. Thank you so much, Sudhir. Thank you so much to the scientific committee inviting us to chair the session. Thank you so much.
Thank you, sir, for those meaningful and insightful talk, and thank you, sir, for chairing the session. Now I request you to kindly join the audience side for further session. We now move to the special session on post-exposure prophylaxis and single-dose rifampicin. May I invite our esteemed chairperson, Dr. Vishwamohan Katur, sir, President, TB Association of India, former Director General of ICMR and Secretary, Department of Health Research, Government of India, Dr. Sudhanshu Singh, sir, Senior Dermatologist in Patna, and Dr. Vikas Shankar, sir, Associate Professor, NMCH Patna, and Organizing Secretary of Lepcon 2026, to kindly take their seat on the dais.
Well, to keep the program on in time or on time or around time, I think, we'll just get on to the business. On behalf of each of us, we welcome you to this session. Post-exposure prophylaxis is not a new thing, actually. Right from the acid-dapsone days, rifampicin, and then we can, again, that it has been used as a part of the programs. And today we have two eminent speakers to talk on it. One representing the program. I think Dr. Gitte couldn't make it, so his colleague, Dr. Lisa, will make the first presentation. She will talk upon the experience of the PEP used in the NEDP program. Followed that, it will be followed by our, again, very senior colleague, Dr. Paul Sanderson. He'll again talk of the use of leprosy, PEP in preventing leprosy and interrupting transmission. Of course, this will be followed by a panel discussion to be moderated by Professor Narasimha Rao. So may I invite our first speaker, the program representative, Dr. Lisa. She is the ADG with the Central Leprosy Division, and Dr. Lily Gangmei, I think she has been there in the program for quite some time now, but not for very long. But I think one of very cordial colleagues, is a positive, constructive, and I think very objective also. So Dr. Lily.
Thank you, sir. Thank you. And good morning to everybody. And thank you very much for inviting for this forum. Good morning, everybody. I'm Dr. Lily Gangmei, ADG Central Division. I came in place of Dr. Gitte. And now I'll be speaking more on the National Leprosy Eradication Program implementation. So everybody knows about leprosy. Everybody is working more than I've been in this field. And the first thing is the cardinal sign. I just want to carry to the journey of the NLEP program a little bit before we come to the real PEP presentation. The clinical diagnosis is based on the 3 cardinal signs, which can be seen on the board. Cardinal sign, hypopigmentation and reddish skin. Next is involvement of the peripheral nerves as demonstrated by the thickening of the nerves and the loss of sensation. And the third is the demonstration of M. leprae. So this slide, it shows that the NLEP vision by 2027. We have four visions: zero leprosy case, zero transmission of leprosy, zero disability due to leprosy, and zero stigma and discrimination. And as per SDG target 3.3, by 2030, we should be ending the epidemics of the leprosy. So this slide is showing the status of the leprosy in our country. So now in this 3 slide, that is the beginning 1996, and now in 24-25, we have it's showing the shrinking of the coverage of the leprosy in the country. So this is just a trend of the leprosy cases. Most of you have seen all this graph. We have seen that it has back in 1983 and 84, and it has come down to 94 and 95, and we have achieved elimination in December 2005. And after that, we have continued to maintain the PR less than 1. And several initiatives which was taken after 2015 and 16. And among the new initiative, PEP is one of them. And this slide will show the trend of the NLEP indicators in India for the past 10 years. So we see that from 2014 onwards, the new leprosy case detection, it was around 1,25,785. It has come down, this is the last 2024-25 figure, which is 1,957,000. The percentage of child was 9.04, and now it has come down to 4.68. And G2D case, it was around 5794 in 2014 and 15, and now it has come down to 1893. So if we see the 10 years, the trend of the indicators in 10 years, we have seen a lot of improvement, and we are progressing towards IoT. This slide shows the disease burden. We have 15 states which contributes to 95% of the leprosy cases in India, and 8 states, which is 2.78%, and 13 states, which contributes around 0.3% of the national case. Out of the 15 states, we have 8 states which is contributing around 76.6%. So our focus is now on these 15 states, which is in a red color zone. So the major initiative which has been undertaken under NLP, the number one is the leprosy case detection. We have different type of leprosy case detection, and the first one is the leprosy case detection campaign, which is about a 14 days campaign where house case detection is carried out by a team of health volunteer, a male and a female volunteer, and this is being monitored at a different level of the states and also at the central level. And we have other programs also, Focus Leprosy Campaign, which is done as a follow-up of G2D. Now we have extended all this FLC for every new cases, then child case, and G2 case. This is a program which is focused in the low endemic areas. And we have special plans for hard-to-reach areas, and next is APSUS, which is a regular surveillance by ASHAs. ASHAs are the health volunteers, which is working under NHM, and they are the community workers for our program too. Next is the post-exposure prophylaxis. This is the topic of the thing, and it is eligible. It is administered to the eligible contacts of the index cases. The next is disability prevention and medical rehabilitation. Here we provide some welfare fund, which is provided for compensation of the loss of wages, amounting to 12,000. And besides this, we give MCR footwear, self-care kit, and assisted device. The third one is capacity building. We are focusing more on capacity building. So for our capacity building, we include all the manpower, all the cadre in our health department. We start with A&M, CHO. They are the one who's working at the field level, and we are training them. PMW, NMA, NMS, these are the workers of the NLP, and physiotherapists, lab technician, nurses, and medical officer. These are ongoing programs, and we are training them regularly. Next is Sparse Leprosy Awareness Campaign. Leprosy is one disease which is related with stigma and discrimination. So this is a 14-day program which is carried out in all the villages and community where different activities are carried out in school, including schools and at the level of the administration till the Gram Sabha. We have next is the convergence of the leprosy screening with the Rashtriya Bal Karyagram and Rashtriya Kishore Swasthya Karyagram for screening of the children of different ages. And besides this, we have integrated with the AIIMS, also Arogya Mandir. And in this CHO and the medical in some of the states it's medical officers. Otherwise, in rest of the country, the AIIMS are manned by CHOs. They are the one who is screening regularly. So in the newer things which we have been implemented is the National Strategic Plan and Roadmap 2023 and 27. This guideline was launched in 2023. Along with this, national guidelines for antimicrobial resistance for leprosy has also been released on the same day. We have a digital platform which is Nikush 2.0 for monitoring and supervision. And in 2025, we have, the ministry have issued a letter to the states for notification of leprosy. Until now, 14 states have notified leprosy as a notifiable disease. And lastly, I would like to tell that we have identified 121 high priority districts in the country. And these districts have PR more than one, that is a case of 1 per 10,000. So we have a special monitoring framework for this. A nodal officer has been designated to go and monitor these high priority districts. So the 121 high prevalence district, which I just mentioned, is this on this slide. Andhra Pradesh has 2 districts, Arunachal has 1, Assam has 2, Bihar has 14 districts, Chhattisgarh has 21 districts, Gujarat 7, Jharkhand 20, Madhya Pradesh 9, Maharashtra 17, Orissa 18, Telangana 2, West Bengal 4, Chandigarh 1, and Delhi 3. So these are the districts where we are focusing all our intervention in a very focused way. We have intensified all our programs in these areas. So this is the status of NLP indicators in 24-25. The total new case detected was 1,957,000. Prevalence rate is 0.57. Grade 2D disability is 1,893. Percentage of grade 2 disability among new cases 1.31. G2D per million is 1.43. And 4.68% of child case. So the PR is below 1, and our country has been maintaining PR less than 1 since 2005. However, this is at the national level. However, in the level of the subnational, we have 4 states, Chhattisgarh, Jharkhand, Chandigarh, Orissa, and Maharashtra. So Chandigarh is 1 UT, which is included here. So this slide also shows the various services which is being provided for the leprosy patients. So we have reconstructive surgeries, total 1,575 conducted through government and non-government hospitals. We have Spurs Leprosy Awareness Campaign, which covers in 5,39,465 villages. Distribution of microcellular rubber, that is MCR footwear for the leprosy affected patients. 1,14,661. Distribution of self-care kit, and we have the single SDR administration, single dose rifampicin as post-exposure prophylaxis, 15,40,168 eligible individuals. All these services along with the MDT are provided free of cost to persons affected by leprosy. So in 2025, we have revised, the ministry have revised the treatment regime. Earlier in PB leprosy, the blister contains only rifampicin and dapsone. Now it is 3 drugs. And in MB, we have 3 drugs, so it is uniform. It is only the duration which is changed. And another thing which I've revised was the classification of leprosy. We have noted that the number of, as Sir has also told in the previous session about the neurology cases, the number of neurology cases are increasing, and we have seen that they have to be reclassified because the response to PB was not enough. So there were some studies, and then later it was changed, and then skin lesion, it was only skin lesion and no nerve involvement, and bacilli is absent in paucibacillary, and multibacillary skin patches will be more than 5 and 1 or more nerve. Even 1 nerve is considered as MB now, so the treatment will continue for 1 year. And bacilli positive. This is the 2 revised class. This is the revised two things which have changed in 2025, classification and the treatment. And the latest was the notification of leprosy. Now 14 states have notified leprosy in the state. Coming to the post-exposure prophylaxis, this is targeting the people harboring the M. leprae during the incubation period to bring down the prevalence and to reduce the load. And this single dose rifampicin, it gave 57% protection for 2 years and 30% after 5 to 6 years. So it reduces the bacterial load with the use of the antimicrobial. It does not induce a lasting immunological protection. Coming to the last. So there's the step of administration. When a case of leprosy is introduced, medical officers will go and inform the multipurpose worker, and the multipurpose worker will initiate the step for giving the PEP. So the multipurpose worker will visit the patient with the local health volunteer, ASHA, who is called ASHA, and then they will list out the list of the household, close contact, and the screen for leprosy. So we have different type of contacts. We have family contact, eligible household contact, neighbor contact, and social contacts. So ideally it is 20, we target for 20 cases. So this is the dosage. And we have inclusion criteria and exclusion criteria also. Exclusion criteria, the pregnant women and the people receiving rifampicin, people with history of liver disease, and with possible signs of symptoms of leprosy and having other TB or acute illnesses. So this is the flow which the initiation of the medical officer will inform the paramedical worker. Then they have a committee, they form a 2-member team. They will go to the village, they will inform them, take counseling, and then start the contact tracing among the neighbors and all the eligible contacts. And then during the contact tracing also, we find many more cases. So this is the adverse event management. There is adverse administration like small adverse reactions, stomach, nausea, headache, nausea. The medication, it gives red discoloration. The MPW worker will be educating the people. So we have implemented in 2000, we started in 2019-20. So on an average, we have, on a national average, it was 6 per index cases, but now it has gradually increased, and now it has reached 15% per person. Now the achievement. The milestone which we have achieved is 638 out of 797 districts have achieved elimination. This data is also dynamic because there is changes in the number of districts. Recently also many districts have been added. This is as per 2024 data, and 43 districts have achieved elimination. That is no child leprosy case since the last 5 years, and 3 years adult cases. 134 districts have achieved interruption of transmission. This is no child case since the last 5 years. So no child case means this is a good indicator. This is an indicator for the transmission. So this is a last slide. Sorry, sir. So in this slide, we are showing after the implementation of the PEP was implemented in 2019-20. So the number of child cases, the indicator which we look for is in the child cases, and the number of cases have decreased from 7857, and now it has come down to 4722. This is what I wanted to tell. This is showing that PEP has also one of the reasons for reducing. Thank you very much. Thank you for kind hearing.
Thank you, Dr. Lily. I think for you summed up the efforts of the national program, the success, and also on the PEP also.
Yes.
No, I think we all realize that the program is inching towards the final success.
Yes, yes.
But what will be the deadline, we don't know. But I think we congratulate you, but we wish you good luck with the very tough
Yes,
task is ahead,
yes.
actually, yes.
Sir, another good thing is that there is challenges during for the PEP also.
Yeah.
But we have requested WHO, and now the rifampicin have been received in the GMSD, so we are going to be supplying.
Thank you for coming and joining also, and I think enlightening everybody.
Thank you, sir.
Thank you, madam. Thank you. Well, it's a pleasure to invite Dr. Paul Saunderson. He's again a very old, distinguished colleague, a clinician, but I think with the long years of working in leprosy in Ethiopia, everywhere. And he has contributed to the neuro leprosy also, and the current editor of Leprosy Review. I think it's very difficult to sum him up. His career is an outstanding career of anybody, any clinician working in leprosy. Yes, Paul.
Thank you very much indeed, Dr. Katoch. It's very kind of you to have invited me here, and I've enjoyed the presentations so far, and it's impressive to see what is happening in India with PEP from the last speaker. And my experience is mainly outside in other parts of the world, especially Africa, so I'm not so familiar with the situation in India, but I hope there are lessons that can be learned from other places. I don't need to go through my CV, but these are the topics I want to discuss. And in general, transmission of leprosy, although Dr. Kumar went back to the 19th century for the history of leprosy, I think the history of the transmission of leprosy, we have to go to even centuries ago. Then I also want to talk about post-exposure prophylaxis. And I think in the current world, the important thing is that it is targeted. And the more accurately we can target it, the more effective it will be, using mapping especially. Then there's this rather unfortunate incident of a paper on PEP causing disability, which I think is certainly erroneous. The paper misinterpreted the study design of LPEP, and that led to, unfortunately, a completely wrong result. And as I was involved in the study and also a co-author of all the papers that are quoted, I can just give you some of the details on that, and then some future prospects. So historically, transmission has been declining very slowly over centuries. We know that leprosy in Europe was very common in the Middle Ages, so the incidence was high, although the number of cases was not very high because the population was low. The population nowadays is obviously much higher, so with a lower incidence we have more patients. But although the data are not at all accurate, leprosy seems to have declined over several hundred years. And some explanations are that the Black Death in the 14th century killed about 50% of the population in Europe. So it's possible that people who survived the plague actually had a possibly better immunity that enabled them to resist leprosy. Then a somewhat similar thing took place later, between 1700 and 1900. Tuberculosis caused up to a quarter of all the deaths in Europe over those 200 years. And so, again, maybe people recovering from TB or exposed to TB developed a better immunity against leprosy. So those are things we can't really answer, but they're interesting possibilities. And this is a map from 1891 of leprosy in the world. So clearly it may not be very accurate, but it still shows that there was quite a good, the pattern of leprosy was very much similar to what we have today. Some places, like Norway, for example, have no more leprosy, whereas they had quite a lot at that time. But in many other parts of the world, the distribution is still somewhat similar. And then the question is, has transmission really stopped in many areas of the world? And this, the WHO definition, which I think is actually very good, that if there are no child cases in an area for 5 years, as was previously mentioned, we think that transmission has stopped. And it doesn't seem as if people get leprosy again in those areas. So in Europe, there are many visitors every year diagnosed with leprosy, but there are virtually no secondary cases. So there are only 1 or 2 known autochthonous cases in the UK in the last 100 years. And in the USA, there were a lot of people from Marshall Islands who moved to the USA after the Second World War, and the Marshall Islands are very endemic for leprosy, and many of those developed leprosy after moving to the United States, but again, there were no secondary cases. And now we know that armadillos are a much more important reservoir of leprosy in the US. So the underlying mechanisms, we tend to speculate rather than going from knowledge, but certainly overcrowding and hygiene and nutrition are very important factors in whether transmission occurs or not. And I personally feel that the infective dose is quite important in how severe an infectious disease is. And if the infective dose is very low, as when the endemicity is low, it may be that no transmission actually occurs, and that a small dose of leprosy can very easily be overcome by the immune system. And this is more proven in viral infections that are easier to study. We know that the higher the infective dose, the more severe the disease and the more likelihood of death. How are we doing on time? Okay. So in the modern era, we have more active measures to try and stop transmission. So the most important one is active case finding and effective treatment of new cases. And it's interesting that probably over the last 100 years, the areas where there's been most effective case finding is in countries that are more authoritarian, and they have been able to do compulsory annual contact examinations for every single contact of any case. So that has actually brought down the number of cases of leprosy in Russia, China and Vietnam really quite steeply. And not many other countries can do that, have that degree of rigor on active case finding. Then BCG is quite important, which was developed in 1920, and Russia was one of the main producers of BCG, and so it was widely used in the Eastern Europe and the Russian area from the 1950s onwards. So there was very consistent use of BCG in the whole of Central Asia from the 1950s. Whereas in the global south, BCG use has only really expanded after the 1980s. And it may be that nowadays we are seeing the effect of that more widespread use of BCG. Then PEP, we know that it has an impact at a local level, but it's too soon to assess any global impact. But it can easily be organized alongside active case finding, so it is actually easy to implement. Then some of the basic evidence, and I've been fortunate enough to be involved in many of these studies, both either as a study group advisor or I'm the co-author on many of the papers on the studies. So the original COLAP study in Bangladesh, plus others at around that time in Indonesia, showed this figure of 57%. So they're quite, and that actually you get a bigger reduction in people that have had BCG previously. And there are similar results in many other studies. There are some limitations and misunderstandings about PEP. So all these trials that are quoted were only a one-off intervention. So I personally think that if you had a programmatic use where you were doing it regularly, there would be a snowballing of the effect, and it would actually be an increasingly useful preventive effect measure. So Morocco is one example of, it was very low endemic, but they managed to institute an ongoing PEP program. But several other countries are starting routine nationwide targeted campaigns. And obviously India is in that category. And then there's also the misconception that PEP provides protection against leprosy for 2 years. But as the previous speaker mentioned, it's not, it doesn't change the immunology, it's not protection, it just abolishes an incubating infection at the time it's given. So the bacilli that are present are killed, and then the person doesn't develop disease, so you have a decrease in new cases over the next few years. Then there are some, many people still oppose the use of PEP, and the arguments, I think there are 4 arguments that are usually given. One is that it could promote drug resistance in both leprosy and TB, although the theory behind that is quite weak, and there's a lot of suggestion that it doesn't promote resistance, but also the other effect of that is that in most places where PEP is being introduced or studied, you actually get better studies of drug resistance levels. So the situation is being monitored more closely. And there's still no evidence that in PEP areas there is an increase in drug resistance. Then other people say that it is not 100% effective, but that you would expect from any intervention. And the effect may vary between different groups of contacts that are given PEP. But that's not an argument against it, really. Some people say that the definitions of contacts and clusters are not the same in all programs, but to me that is not an objection. Every country and every area should do what is appropriate for their area. And then drug supplies and costs and logistic difficulties are all aspects of a program that have to be dealt with. Then, so I think that PEP in practice needs a targeted approach with mapping. And the regimen we've heard about, we can screen index cases, but I also think we should recruit greater numbers of contacts through this so-called blanket approach. Now with mapping, you can identify very precise areas where cases are, in particular where there are child cases. Then you can cover a small area and that has the advantage of not identifying the index cases. And skin camps are an alternative in poorer, highly endemic areas. So these are just 2 countries that have used this map that WHO, or this tool that WHO has produced, the Leprosy Elimination Monitoring Tool. This gives much more precise information about where the child cases are. They're in red in these different areas. And that helps to target really small communities for PEP. And you can even have mapping of within those sub-districts. So does PEP cause disability? Actually, it's just a completely wrong understanding of the study. So this was about, they looked at the data from the LPEP study, which was one study, and it was a feasibility study. It didn't study any outcomes. So all the people with disability were amongst the index cases. The contacts were recruited and given treatment, but the contacts were only seen once. They were never followed, they were not followed up in the research program. They were followed up by the routine program. So this was the graph that was shown in the paper, and this is if you want to mislead people, this graph is one way, one example of how to mislead people, because the scales are completely different on the graph, and the timing is completely wrong. So I won't go into more detail because of time, but that is just a totally false paper. So for the future, there are more potent regimens coming along, PEP++, longer-acting drugs like rifampicin, bedaquiline, and telacibec, and then vaccines could also be used. So the main problem is logistics and actually getting things running and off the ground with all the background, especially mapping. But if that is done, I think PEP can be very successful. Thank you very much.
Thank you, Paul, for a, I think, very nice discussion, nice actually analysis of the situation on the PEP use, and also what that data, published by AIIMS also. Hopefully, I'll get some of the rebuttals to that, because nobody published sent any rebuttal to me so far. We will publish anything which any argument coming on the other side also. But so far, nobody has sent any analysis to counter that argument. So but that I think should be brought out. I think you publish either in Leprosy Review or you send to somebody who is writing it up to me also. We'll publish here also. No problem.
So the refutation.
No, see the question what the AIIMS published. See those arguments which analysis you are presenting.
Yeah.
That really not the argument that his arguments were flawed.
Yeah.
That should be countered in the scientific discussion only. That's in the publication only. So the people should read that actually. Yes. Okay. We look forward to that.
I'll talk to you later.
Yeah, sure. Most welcome. And thank you very much. Thank you very much for a very, very comprehensive presentation. And brought these 2 presentations have brought one very clear issue, I think one very clear, PEP will kill only where is it incubating, it is where the infection is there. So, and furthermore, it will kill only those which are multiplying on that time. So it will have an impact on, a limited impact on the infection, which is all people already infected actually. And for prophylaxis, for the prevention for others, I think if you say want to reduce the immunity, this has to be through the vaccine only. And of course, we have a vaccine MIP which protects 60 to 70%. So I think that's one of the options we have been pushing for. Let's see what happens with that. And BCG is already used in our program, so that's a part of our society. Thank you very much, Dr. Paul. Thank you very much. Sir. Thank you, sir. Thank you. Thank you very much. Yes.
Now, any conference, the heart of the conference is panel discussion. And our subject is steps of involvement of IAL members. So, yeah, our chief guest, Chief Justice of Patna High Court is just coming. So the panel discussion will be after the inauguration. Okay, thank you.
A very good morning to all. Respected dignitaries, esteemed colleagues, and dear delegates. A very warm welcome to the inaugural ceremony of 33rd Biennial IAL National Conference of Leprosy, Lepcon 2026. Mahatma Gandhi once said, "The service of leprosy patients is the highest form of service." His words reminds us that our mission goes beyond treatment to upholding dignity, eliminating stigma, and upholding humanity. As we gather here today with the theme of Leprosy-Free India, moving closer and reviewing progress, let us remember that elimination is not merely a milestone, but a responsibility. With these words, we will now proceed to the inauguration ceremony. I would now request Honorable Mr. Justice Sangam Kumar Sahu, Chief Justice, Patna High Court, to kindly come to the dais, and I would request Dr. Abhishek Kumar Jha, Organizing Chairperson, Lepcon, to kindly accompany him to the stage. Next, I would request Professor Dr. Raju Agarwal, sir, Executive Director and CEO, AIIMS Patna, to kindly join us on the dais. I would request Dr. Shwetalina Pradhan, ma'am, Scientific Committee Chairperson and HOD, Department of Dermatology, AIIMS Patna, to kindly accompany him. Next, I would like to call upon the stage Dr. Lily Gangmai, Additional Director General, Leprosy, Government of India. I now request Dr. P. Narasimha Rao, sir, Chairperson, IAL Academy and immediate past President, Indian Association of Leprologists, to please come on the dais and join us. Next, I would request Dr. Sujay Sunitha, sir, President, IAL, to join us on the dais. Dr. Santosh Dev P. Rathore, sir, Honorary Secretary, IAL, I would request him to join us on the dais. Dr. K. Rajalakshmi, Treasurer, IAL. I would request her to kindly join us on the dais. Dr. Abhishek Kumar Jha, sir, Organizing Chairperson, Lepcon 2026. Please join us. Dr. Vikas Shankar, sir, Organizing Secretary, Lepcon 2026. Kindly join us on the dais. Dr. Shwetalina Pradhan, ma'am, Scientific Committee Chairperson and Head of Department Dermatology, AIIMS Patna. I would request her to join. May I now request the organizing team to kindly present bouquet as a token of our respect and gratitude. Honorary Chief Justice, Mr. Sangam Kumar Sahu, Mr. Dr. Raju Agarwal, sir, Executive Director and CEO, AIIMS Patna, Dr. Lily Gangmai, Additional Director General, Government of India, ma'am, please join us. Dr. P. Narasimha Rao, sir, Chairperson IAL. Dr. Sujay Sunitha, President IAL. Dr. Santosh Dev P. Rathore, sir, Honorary Secretary. Dr. K. Raj Lakshmi, Treasurer. Dr. Abhishek Kumar Jha, sir, Organizing Chairperson, Lepcon 2026. Dr. Vikas Shankar, sir, Organizing Secretary, Lepcon 2026. Dr. Shwetalina Pradhan, ma'am, Scientific Chairperson, Lepcon 2026. To mark the formal commencement of Lepcon 2026, may I request our esteemed dignitaries to kindly proceed for the ceremonial lamp lighting.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं
Now may I request the organizing team to kindly felicitate our guests. First, we'd like to felicitate our Honorable Justice Sangam Kumar Sahu, Chief Justice, Patna High Court. Dr. Raju Agarwal, sir, Executive Director and CEO, AIIMS Patna. Dr. Lily Gangmai, Additional Director, General, Government of India, Leprosy. Next, P. Narasimha Rao, sir. उसके बाद सुजय सुनीता, sir. Dr. P. Narasimha Rao, sir, Chairperson IL. Dr. Sujay Sunita, President IL. Rajlakshmi. Dr. Santosh Dev Rathod, sir. Rajlakshmi.
मेरा छोड़ो पहले विकास को बुला लो जब मेरा विकास के रह जाना इतनी ना करोगे
Rajlakshmi. Dr. K. Rajlakshmi. Dr. Abhishek Kumar Jha, sir, Organizing Chairperson, Lepcon. Vikas Shankar, sir. Dr. Vikas Shankar, sir, Organizing Secretary. Dr. Shwetalina Pradhan, Scientific Chairperson, Lepcon 2026. Thank you. I now invite Dr. Abhishek Kumar Jha, sir, Organizing Chairperson, Lepcon 2026, to deliver the welcome address.
Good morning, everyone. Nyayamurthy Sri Sangam Kumar Sahu, sir. Director AIIMS, Brigadier Dr. Raju Agrawal, sir. हमारे इंटरनेशनल लेप्रोसी ऑर्गेनाइजेशन के अध्यक्ष एवं पूर्व अध्यक्ष आईएल के डॉक्टर पी नरसिम्हा राव सर, हमारे अध्यक्ष आईएल के डॉक्टर सुजय सुनीता सर, हमारे सचिव डॉक्टर संतोष राठौर, हमारी कोषाध्यक्ष डॉक्टर राजलक्ष्मी, हमारे इंडियन गवर्नमेंट से आई हुई एडीजी डॉक्टर लिली जी, हमारे साथ ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर विकास शंकर और हमारी साइंटिफिक चेयरपर्सन डॉक्टर स्वेतलिना प्रधान, और आप सभी का मैं स्वागत करता हूं और धन्यवाद करता हूं कि आप यहां आए हैं। लेप्रोसी एक ऐसी चीज़ है, दिस इज़ अ काइंड ऑफ थिंग which is mostly ignored in today's practice, but seeing so many people coming from all around the globe and India, so I thank you and I welcome you all. Most importantly, we are having this theme of leprosy-free India, moving closer, reviewing progress. We hope that we will achieve this without taking much time. I welcome you all again, and I hope that you will enjoy the wonderful scientific program and the hospitality of Bihar. Thank you so much.
Thank you, sir. May I now request Dr. Santosh Dev P. Rathore, sir, Honorary Secretary IAL, to kindly introduce the conference.
Om Tat Sat. Tasmadaum ityuha dahatya yakshadan tapah kriyaha. Meaning, to obtain the supreme, we should chant the syllabus Om before beginning any pious activity as per the Vedic standards. Respected Chief Guest, Honorable Justice, Chief Justice Sri Sangam Kumar Sahuji, our respected AIIMS Director and very kind host, Brigadier Dr. Raju Agrawal sir, our guest of honor, Dr. Lili Gangmei, my President, Dr. Sujay Sunitha sir, our past President, Dr. P. Narasimha Rao sir, my Treasurer, Dr. Rajalakshmi ma'am, and the organizing chairpersons, Dr. Abhishek Kumar Jha, who is really very hardworking to make this conference successful, organizing secretary, Sri Dr. Vikas Shankar, scientific chairperson, Sri Dr. Swetalina Pradhan, and the scientific secretary, Dr. Sri Panna Deb. I would like to take a moment to explain the rich tradition of the 33rd Biennial Conference of Indian Association of Leprologists. Ours is an age-old, very old association which incepted in 1956. And it has been a tradition to organize a biannual conference every year since then. And a significant landmark developments have occurred which has guided the policy and the program over the years during the discussions of the conference. I would also like to thank the Central Scientific Committee team, Dr. Kiran Katoj ma'am for her guidance, Dr. Sunil Dogra sir, Dr. V.M. Katoj sir, in guiding the program and keeping the theme. Lastly, all the faculties, delegates, and volunteers who made the effort to be here in this movement. The conference theme is Leprosy-Free India, the way forward, reviewing progress. We have tried to plan the sessions in such a way that we can assess the progress that we have made and we can realign with the goals of National Strategic Plans 2027. So where do we stand just a year before the National Strategic Plan goals are to be estimated? This conference should give us a good idea about it. Moreover, it is heartening to see participation of government, the ADG Leprosy, Dr. Lili Gangmei. We also have state leprosy officers from Bihar, Odisha, Punjab, and also district leprosy officers from Odisha and Bihar. This is a significant involvement because the advancement in leprosy care, if are learned by this district leprosy officers through this conference, definitely there would be improvement in the care provided to the leprosy patients. Another very significant stakeholders that are our ILAP partners, delegations from TLMTI, CLTRI, scientists from ICMR and PhD students. They make IL vibrant and IL congresses very scientific. Not to forget, people with lived experiences for whose cause we meet every year. Ownership of leprosy care, as we see, is shifting from the central institutions to the private dermatologists. And that is going to be the theme of very important panel by Dr. Rao sir in how to involve dermatologists, because they are the foot soldiers to whom now the patients of leprosy are presenting. As IEL, we sincerely appreciate the effort put on by the organizing team of Dr. Abhishek Jha and AIIMS administration for providing us with excellent support and infrastructure for Lepcon 2026. Happy conferencing to you all, and welcome. Thank you. Moving on, I would like to welcome my president, Dr. Sujay Kumar Sunitha, for his presidential remarks.
Good morning and warm greetings to all. Respected and Honorable Chief Justice, Sir Sangam Kumar Sahuji, Brigadier Raju Agarwal Sir, Dr. Lily Gangmai, other dignitaries on the dais, off the dais, respected senior colleagues, invited speakers, delegates, postgraduate students and friends across India and abroad, my heartfelt welcome to Lepcon 2026, the 33rd Biennial Conference of the Indian Association of Leprologists here at AIIMS, Patna. It is both a privilege and a profound responsibility to stand before you as president of the association. We gather at an important moment in the journey of leprosy control. While multi-drug therapy has transformed outcomes, leprosy continues to persist in pockets of endemicity, and India still contributes a significant proportion of global new case detections. The occurrence of child cases, grade 2 disabilities, and the continuing burden of stigma remind us that our task is not yet complete. This conference is therefore not merely academic, it is a reaffirmation of our shared commitment. Lepcon 2026 brings together leprologists, dermatologists, clinicians, microbiologists, surgeons, rehabilitation experts, public health professionals, researchers, and policymakers. This multidisciplinary collaboration is Indian Association of Leprologists' strength. Only by working together can we interrupt transmission, prevent disability, and restore dignity to those affected. The scientific program reflects the full spectrum of contemporary leprosy work. Advances in diagnostics we had start this morning, and therapeutics, antimicrobial resistance, management of reactions and neuritis, disability prevention, reconstructive surgery, chemoprophylaxis, and community-based interventions. I'm especially encouraged by the enthusiastic participation of young investigators and postgraduate students. The future of leprosy rests in your capable hands. On behalf of the IAL, I sincerely thank the organizing and scientific committees, particularly Dr. Abhishek Jha, Chair of the Organizing Committee, Dr. Vikas Shankar, the Organizing Secretary, and Dr. Svetalina Pradhan, the Scientific Chair, for their meticulous efforts in planning this conference. I acknowledge also the unwavering support of the IAL Executive Committee of Dr. Santosh Rathod, Honorary Secretary, Dr. K. Rajalakshmi, Treasurer, and Dr. P. Narasimha Rao, who is not only a past president of our association, but who presently is the president of the International Leprosy Association. As we look forward to Lepcon, let us renew our resolve towards zero transmission, zero disability, and zero stigma. Let us combine science with compassion and research with service. I warmly welcome you to Patna and wish this conference every success. Thank you.
Thank you, sir, for that very inspiring address. Now we move on to celebrate the lives lived for the cause of leprosy. We have three extraordinary personalities who have dedicated their lifetime, their lives for the cause of leprosy. As we move on to IAL Lifetime Achievement Awards. The first among the three Lifetime Achievement Awards to be given today is Dr. P.K. Roy, sir. May we have Dr. P.K. Roy, sir. I would invite Dr. Svetalina to read the citation for Dr. P.K. Roy, sir.
Professor Dr. Prasanna Kumar Rai, former head of the department, Nalanda Medical College and Hospital, is a distinguished clinician, teacher, and leader whose career spans over 4 decades of dedicated service to dermatology and leprosy care. After serving the Indian Army during early phase of his career, he devoted himself to dermatology, venereology, and leprosy, building a legacy of excellence in clinical practice, teaching, and public health. His scholarship, clarity of thought, commitment to education have mentored and inspired generation of undergraduate and postgraduate students. Dr. Roy has been widely recognized by leading professional bodies including Indian Medical Association, IADVL, both state and national level. He was honored with Lifetime Achievement Award by IADVL BR for his contribution to core clinical dermatology and for mentoring a galaxy of students. He is also a recipient of Best Teacher Award from East Zone by IADBN National and had delivered the prestigious Amar Kanjha Amar oration at major academic forum. A respected teacher in the profession, Dr. Roy has served past National Treasurer of IADBL, past President of IADBL Bihar, contributing meaningfully to the growth and governance of dermatology in India. He is also an active member of IAL. For over 45 years, he has devoted himself to comprehensive care of persons affected by leprosy, advancing clinical management, teaching, research, and rehabilitation. His tireless commitment has strengthened awareness, improved standards of care, and upheld the highest ideals of compassion and service. In recognition of his outstanding and lifelong contribution to dermatology, particularly core dermatology and leprosy care, Professor Dr. Prasanna Kumar Roy is being conferred the Lifetime Achievement Award in Leprosy by IL at Lepcon 2026 at AIIMS Patna.
Thank you. Next, we have IAL Lifetime Achievement Award for Dr. Colonel Major Jaiswal sir. Major General Jaiswal sir. And I would invite Dr. Abhishek Jha to read the citation.
Dr. Major General Ashok Kumar Jaiswal, the Indian Association of Leprologists takes immense pride in conferring the Lifetime Achievement Award in Leprosy upon Major General Dr. Ashok Kumar Jaiswal, an eminent dermatologist, distinguished military officer, academic leader, and compassionate clinician, whose 4 decades of service has profoundly shaped leprosy care in India. Born in 1948, an alumni of AFMC Pune, Dr. Jaiswal joined the Army College Corps and rendered 39 years of exemplary service to the nation. Rising to the rare rank of Major General, he held several prestigious appointments, including Additional Director General, Armed Force Medical Services, and Director of Premier FMC Hospitals. Throughout his career, he seamlessly combined clinical excellence with visionary leadership in patient care, teaching, and health administration. Dr. Jaiswal holds the unique distinction of serving for nearly 4 decades in leprosy centers, the army forces, his unwavering commitment to the diagnosis, management, and rehabilitation of patients affected by leprosy. Often in the remote and challenging trends reflects his deep compassion and sense of duty. He was among the pioneers who carried dermatological and leprosy services to the Ladakh and Northeast regions, expanding access to the specialized care in undeserved areas. A former national office bearer of leading dermatological association and founder presidents of FMC dermatologist groups, Dr. Jaiswal has shaped dermatology and leprosy service to both institutional and national levels. His many auditions and honored stand testimony in the enduring influence. A paratrooper with 64 jumps and deeply spiritual, philanthropic individual, Dr. Jaiswal embodies courage, humility, scholarship, and service. In recognition of his extraordinary contribution to leprosy care, educational research, and humanity, the Indian Association of Leprologists profoundly confers upon Major General Dr. Ashok Kumar Jaiswal the Lifetime Achievement Award in Leprosy on 28th day of 2026, in Lepcon 2026.
So Vishal, can you really activate your natural healing system and manage lifestyle diseases just through natural methods and diet?
Of course. See, there are three things that you need to understand if you want to live a disease-free life. The first thing is you have to have an alkaline body, and body can only be made alkaline through only one thing, that is oxygen.
Well,
And
sorry,
we
I'll
get
just take
oxygen
1
only
minute
from
to
three things:
acknowledge
the
this
food you
award.
eat, the
Well,
water you
ladies
drink,
and
and the
gentlemen,
way
it's
you
a matter
breathe.
of great
All three
honor
are
and
important,
personal
but
pride
what is
for
that
me
one
to
which is
stand
free of
before
cost?
this
That is
August
breathing. So
gathering on this
food and
special
water can
occasion
be adulterated.
on being bestowed upon with this coveted award. Well, I shall be failing in my duties if I don't dedicate this award specially to two persons. One, of course, my dear brother and my jigri dost, none other but the only one, Amar Kanja Amar. A man who ruled this Bihar dermatology kingdom for almost 3 decades and almost known as a Bhishma Pitama of dermatology family of Bihar. I was just wondering why I have been made to stand here all decorated. Is it because of my age, 78 years, or because of my seniority, or some achievements here and there in the field of leprosy? Well, they may be some of the contributing factors. But what I feel, I'm here mainly because of that olive green uniform and those shining stars which I wore on my shoulders once upon a time. And I must, on this happy occasion, salute the real heroes of our country, that is the soldiers of the Indian Army, ladies and gentlemen. The second person whom I want to dedicate this award is my father-in-law, Mr. Kedarnath Jaiswal. Why I say so? Because somehow that he had intense liking, care and concern about the leprosy patients. Every year on his birthday, he used to make sure that all the leprosy patients of the town were invited to his house through the local leprosy home, and used to give them a real treat, a meal, a sumptuous meal with good variety of veg, non-veg items, and followed by some gift. And this he followed for almost 10 to 15 years of his before his death. And the beauty is that even his son is following the same tradition after his death, and every year he also invites the leprosy patient for last 35 years. So one way it's a great tribute this family is doing, and you don't know, unke अच्छे कर्मों के कारण और उनके this missionary treat and goodwill, the leprosy also thought, why not honor their son-in-law with this coveted award. Thank you, ladies and gentlemen, long IEL, and thank you very much. God bless you.
Thank you so much, sir. Next, we have the IAL Lifetime Achievement Award for Service in Leprosy for Dr. Timir Yashwantlal Mehta, sir. I'll be reading the citation for sir. Sir, we take immense pride in conferring the Lifetime Achievement Award in Leprosy upon Dr. Timir Yashwantlal Mehta, who is a consultant dermatologist at Samarpan Skin Clinic, Modasa, Gujarat, in recognition of your 37 years of steadfast and compassionate service in leprosy care. Dr. Mehta began his journey in 1989 during his postgraduate training under the mentorship of Padma Shri Dr. K.M. Acharya in Jamnagar, where he imbibed not only clinical excellence but also a deep humanitarian commitment to the persons affected by leprosy. Since 1993, he has worked in close collaboration with Padma Shri Suresh Bhai Soni at Sahyog Kusht Yagna Trust, Rajendra Nagar, transforming lives through holistic, patient-centered care. Over nearly 4 decades, Dr. Mehta has examined and followed up more than 10,000 persons affected by leprosy. He has managed over 2,000 admitted patients, facilitated more than 100 surgical procedures, and ensured multi-drug therapy for over 10,000 leprosy-affected individuals. With more than 6,000 successfully completing treatment under his supervision, his commitment to equitable care has ensured free access to MDT for patients from Gujarat and Rajasthan. A tireless advocate in managing leprosy reactions, Dr. Mehta has facilitated the free distribution of over 10,000 units of thalidomide across India, His dedication to rehabilitation is reflected in providing MCR footwear, advanced footwear and prosthesis to more than 1,500 patients. Today at Sahyog Trust, the majority of residents, they are gainfully engaged as caregivers and staff, an enduring testament to his emphasis on dignity, empowerment, and community reintegration. Dr. Mehta has participated in over 150 detection camps and numerous academic forums. Through his clinical excellence, academic distinction, and unwavering compassion, Dr. Timir Yashwantlal Mehta exemplifies the highest ideals of leprosy care. The Indian Association of Leprologists proudly honors him for a lifetime devoted to a healing, rehabilitation, and restoring hope. Thank you so much, sir.
Thank you, sir. May I now invite our guest of honor.
We also recognize as IAL the combined role of an amazing couple who served the field of leprosy for decades in this country. Both husband and wife were committed to the cause of leprosy and served institutions and the government of India in many ways. And we want to recognize that as we honor Dr. Vishwamohan Katoch and Mrs. Kiran Katoch with a special appreciation award for them to receive, not individually, but together. They have received many awards individually, but this is an award for both of them together. Dr. Narasimha Rao, please.
It is my proud privilege to invite Dr. Vishwamohan Katoch ji and Kiran Katoch ji onto the dais. May I request Dr. Santosh Dev Rathod to accompany them. The Indian Association of Nephrologists takes immense pride in honoring Dr. Vishwamohan Katoch ji and Dr. Kiran Katoch ji at Lepcon 2026 in recognition of their extraordinary and complementary contributions to leprosy research, policy, and patient care in India and beyond. Together, the Katoches represent a rare and inspired husband-wife partnership whose shared professional journey has profoundly shaped the scientific and public health landscape of leprosy in our country. Their long and distinguished association with ICMR, National Jalma Institute for Leprosy and Other Mycobacterial Diseases reflects decades of leadership, innovation, and dedicated service. Dr. Vishwamohan Katoch, eminent medical microbiologist and former Director General of Indian Council of Medical Research, ICMR, as well as Founder Secretary of Department of Health Research, has been always involved in advancing modern diagnostics for tuberculosis and leprosy. His leadership, not only at ICMR but also at IAL, strengthened molecular diagnostic capacity, including DNA-based technologies, and facilitated the establishment of multidisciplinary research units, model rural health research units, and virology diagnostic research laboratories, bridging laboratory science with public health implementation nationwide. With more than 350 scientific publications and fellowship of major national science academies, his scholarship is matched by his vision for strengthening India's healthcare research systems as well as IAL. Dr. Kiran Katoch, a proud better half, I should say, a distinguished clinician, scientist, and former Director General of ICMR Jalma, has devoted more than 45 years of clinical, therapeutic, and epidemiological research in leprosy and tuberculosis. Her work has advanced treatment strategies, deepened understanding of systemic involvement in leprosy, and contributed to vaccine research as well as to use of clopazamine in daily dose for PB patients. Her pioneering epidemiological initiatives at Ghatampur evolved into model rural health research unit framework, which was later adopted nationally, significantly enhancing rural research capacity. With over 200 publications and numerous orations and honors, she exemplifies clinical excellence integrated with community-oriented research. As a professional partnership, Dr. Katoches embody the seamless integration of laboratory science and clinical medicine, policy vision, and grassroots implementation of leprosy research in the field. Their shared dedication has strengthened institutions, academies, mentored generations of leprologists and dermatologists, and advanced India's leprosy control and research efforts. In honoring Dr. Vishwamohan Katochji and Dr. Kiran Katochji, the IAL celebrates not only two distinguished careers, but a lifetime of collaborative service that has left an enduring mark on leprosy science and public health in India.
Thank you, sir. May I now request our guest of honor, Dr. Professor Brigadier Raju Agarwal, sir, Executive Director and CEO AIIMS Patna, to address the gathering.
Good morning, namaskar. Our chief guest, Honorable Chief Justice, Justice Sangam Kumar Sahu, and all the dignitaries sitting on the dais, very eminent dermatologists, leprologists who are in the auditorium. Warm welcome to all of you. I, being the host institute, it is my pleasure and honor to welcome each and every participants, delegates, speakers who are disseminating knowledge about leprosy in this auditorium. Indeed, I am in fact lucky to meet so eminent dermatologists who have achieved quite a bit for the community and for the patient, and they were awarded the Lifetime Achievement Award. We all know the government efforts from 1950s till now, initially for leprosy control and now leprosy eradication by 2027. And I'm sure so many district leprosy officers and all the stakeholders are there who have a vision and planning to achieve this goal of leprosy eradication for zero transmission, zero stigma, which was earlier a WHO goal also. So this conference, 33rd Biennial Conference, will go a long way in educating all of us regarding the present status of leprosy control in India and the steps need to be taken for this disease to be finally eliminated from our country. With that, I welcome you all and I hope this two-day session will be a great academic feast for all of you to take back important lessons. Thank you and Jai Hind.
Thank you, sir. Next, I invite our guest of honor, Dr. P. Narasimha Rao, sir, President, International IAL, to address the gathering.
Thank you. Yeah. Respected Chief Guest, Chief Justice of Bihar, Sri Sangam Kumar Sahu ji, Dr. Raju Agarwal ji, Dr. Lili Gangmai ji, and other distinguished guests of honor on the dais and off the dais. It's my pleasure to be part of this wonderful Lepcon 2026. This conference we are able to host due to the efforts, sincere efforts of the team Bihar, led very ably by Dr. Abhishek Jha, Dr. Svetlana Pradhan, and Dr. Vikas Shankar. I congratulate the team and EC of IAL for conducting the proceedings for last 2 years and proceedings of affairs of IAL for last 2 years, culminating in this wonderful conference. And this is also my privilege to convey, as President of ILA, my warm greetings to the organizers and delegates of Lepcon 2026, the 33rd Biennial IAL National Conference being held at AIIMS, Patna. The theme, which is the Leprosy-Free India, moving closer and reviewing progress, is both timely and forward-looking. India has achieved significant progress in leprosy control, but yet challenges remain in early case detection, prevention of disability, management of reactions, and stigma reduction. This meeting provides an opportunity and platform to review achievements, address gaps, and strengthen collaborative efforts. And on behalf of IAL, ILA, and Indian leprosy community, I congratulate the organizers for bringing together clinicians, researchers, field workers, and students of dermatology and leprosy to advance the shared goal of leprosy-free India. I wish the conference all the success. Thank you.
Thank you, sir. We now request all dignitaries on the dais to kindly join for the release of the Lepcon 2026 abstract book. Now we proceed to unveiling of the book, IAL Handbook of Leprosy for clinician, students and program managers. I invite the esteemed editors on stage, Dr. Bhushan Kumar, Dr. Tarun Narang, Dr. Sujay Sunitha and Dr. Ashwini PK. Soft copy.
Thank you for this honor and the opportunity to introduce this handbook here. The need was felt that the IL textbook, which is 3 times bigger than this, may not be easily used by all, because not everybody is likely to go deep into the subject. So the need was felt that for not only the non-leprologists, the general physicians, the community workers, the paramedical workers, and all the other people involved in leprosy care will need a basics of this. So that's why this book has been published, which is available, and for some reasons the book could not be transported. Maybe in the afternoon they will have it on the counter. So we have the honor and thank you for the permission to use this stage to launch this book for the utility of all. Thank you very much.
Thank you, sir. Now, we proceed to the unveiling of the book, Cutaneous Adverse Drug Reaction, a case-based approach for deeply pigmented skin. I would like to invite the editors on stage, Dr. Shwetalina Pradhan ma'am and Dr. Piyush Kumar sir.
Before we move to the Chief of Guests welcome address, I would like to thank Dr. Sudhanshu Singh, sir, for he is our organizing co-chair, and due to him, it was possible that the Honorable Chief Justice is here. So I would like to invite him to the dais to felicitate him.
Next, we'd like to felicitate Dr. Punkesh Kumar, sir, Treasurer, IAL. Treasurer, Lepcon 2026. And lastly, I would like to request on stage Dr. Professor Petron P.K. Roy, sir, to kindly felicitate him.
I request Director sir and the Honorable Chief Justice sir to kindly felicitate P.K. Roy sir. I request next Iparna Dev to kindly come onto the stage for felicitation. I request sir to kindly stay back, sir, for 1 minute.
Thank you, ma'am. It's my privilege now to invite our chief guest, Honorable Mr. Justice Sangam Kumar Sahu, Chief Justice, Patna High Court, to deliver the inaugural address.
Namaskar. Few days back, Health Secretary of State of Bihar visited the High Court premises because we had gone to the mental hospital at Ara with some of the honorable judges, some spouses, for legal activities, and that point of time the health secretary also accompanied us. And during the interaction, I said that please find time to visit the High Court Hospital. And when he visited the High Court Hospital, I met Dr. Sudhanshu Singh for the first time. I find a charming personality in him, and I was told by the health secretary himself that he is one of the best dermatologists in the state of Bihar. And he requested me that, sir, a national conference of this Indian Association of Leprologists is going to be held in AIIMS Patna. So please give the consent. I readily agreed. इसलिए कि मेरे को वो बचपन के दिन याद आ गए कि जब हम साई डिवोटी होकर नारायण सेवा के लिए 2 आश्रम जाते थे. वहाँ पर होता था गांधीपल्ली एंड नेहरूपल्ली, that is in Cuttack, in Potapakhari, and there used to be a leprosy hospital there, and the government used to finance everything, and used to take food there and distribute among the leprosy patients there. So I thought that ये जो बचपन से हमको सिखाया गया था बाबा सत्य साई बाबा जी से, तो मैं आप सबके बीच आऊं जो कि इतने सालों तक आपने सेवा की लोगों की, और जिन्होंने आज ये अवार्ड भी लिए, उनकी जो 30 साल 40 साल की सेवा लोगों के लिए, ये मुझे बहुत अच्छा लगा. और कहते हैं कि सर्विस टू मैनकाइंड इज सर्विस टू गॉड. तो 2 ही प्रोफेशन होते हैं, हमको कहा जाता है कि वो जो सबसे नोबल प्रोफेशन, और उनमें से एक है लीगल प्रोफेशन और दूसरा है मेडिकल प्रोफेशन, क्योंकि लोगों के डायरेक्ट कांटेक्ट में आते हैं और सेवा करने की मौका मिलता है. मंच पर उपस्थित डॉक्टर राजू अग्रवाल, डायरेक्टर एम्स पाटना, डॉक्टर सुजाई सुनीता, प्रेसिडेंट इंडियन एसोसिएशन ऑफ लेप्रोलॉजिस्ट, डॉक्टर पी नरसिम्हा राव, प्रेसिडेंट इंटरनेशनल लेप्रोसी एसोसिएशन, डॉक्टर लीली गांगमेई, एडिशनल डायरेक्टर जनरल लेप्रोसी गवर्नमेंट ऑफ इंडिया, डॉक्टर अभिषेक कुमार झा, ऑर्गेनाइजिंग चेयरपर्सन, Dr. Bika Shankar, Organizing Secretary, Dr. Svetlina Pradhan, ma'am, she is from Odisha, and I am really happy that she is holding a very high post, HOD of Dermatology and the Scientific Chairperson, Dr. Shantosh Dev Rathod and Dr. K. Rajalakshmi, Treasurer and Honorary Secretary, Indian Association of Leprologists, distinguished faculty, clinicians, researchers, public health experts, and policy leaders, postgraduate students, leprosy officers from Bihar and across the country, delegates and participants from across India, members of print and electronic media, ladies and gentlemen. The father of the nation, Mahatma Gandhi, was a staunch advocate for dignity and care of people affected by leprosy, actively fighting the severe social stigma and untouchability associated with the disease. He believed leprosy was service to humility, famously tending to leprosy patient Parachon Sastri by washing and dressing his wounds at Shavastram Ashram. He said, eliminating leprosy is the only work I have not been able to complete in my lifetime. Binobha Bhave, a pioneer of compassionate and stigma-free leprosy care in India, and he established Mahorgi Seva Mandal at Dattapur near Vadha in 1936 to provide care, rehabilitation, and dignified treatment to those affected, aiming to reduce the social fear and stigma associated with the disease. Mother Teresa dedicated significant efforts to caring the people with leprosy, focusing on treating the disease, fighting the social stigma, and providing rehabilitation. She established Shanti Nagar, City of Peace, a colony for leprosy patients near Asansol, providing medication, housing, and vocational training. She said, the biggest disease today is not leprosy, tuberculosis, but rather the feeling of being unwanted. The Honorable Supreme Court has consistently ruled that the leprosy is fully curable and that the laws, the rules, and the social practices discriminating against leprosy-affected persons are unconstitutional, being violative of Articles 14, 19, and 21 of the Constitution of India. The court directed the center and the state to abolish discriminatory laws, ensure free treatment, and prevent the stigma associated with the disease. In the case of Federation of Leprosy Organization versus Union of India, Honorable Chief Justice of India, Suryakant, and Honorable Justice Joymalia Bagchi on 30/7/2025 has been pleased to observe while dealing with a public interest litigation in which discriminatory, derogatory, and demeaning provisions in various statutes, rules, and regulations and instructions against leprosy-affected and cured patients was highlighted, issued certain directions to the chief secretaries and law secretaries of all the states. The central government in the year 2019 notified to remove leprosy as a ground for divorce, and 5 acts were accordingly amended, that is the Divorce Act 1869, the Dissolution of Muslim Marriage Act 1939, the Special Marriage Act 1954, the Hindu Marriage Act 1955, and the Hindu Adoption and Maintenance Act 1956. It is truly a great honor for me to be present at this national conference of the Indian Association of Lephrologists. I congratulate the organizing team for bringing together clinicians, researchers, public health experts, and policy leaders to deliberate upon a disease that has tested not only our medical science, but also our social conscience. Leprosy is a name that has echoed through the centuries, but for too long that echo carried the sound of a closing door, the sound of a mother being separated from her child, the worker losing his livelihood, or a young girl hiding a patch on her skin as if it were a mark of shame. Leprosy is one of the history's oldest recorded illnesses, yet in 21st century, it remains a formidable challenge. While we honor the milestone of achieving national elimination as a public health problem in 2025, we must remember elimination is not eradication. Thousands of new cases are still detected every year, and India continues to carry a significant portion of the global burden. I'm told that in several parts of the country, this disease still affects vulnerable population, particularly those living in rural and socio-economically disadvantaged settings. Poverty, limited awareness, delayed diagnosis, and persistent stigma contribute to the ongoing transmission. Tragically, preventable disabilities still occur because patients often seek care only after visible deformities appear. Leprosy does not just attack the nerves, it attacks the very soul of a human being, making them feel like a stranger in their own home. From a legal and human rights perspective, we must acknowledge that the person affected by leprosy have historically faced exclusion and discriminatory provisions in certain laws. Over the years, our judiciary has been unwavering, affirming that the right to equality, the right to live with dignity, and the right to non-discrimination are not merely abstract constitutional ideals, they are enforceable guarantees. We must never forget that no disease, however ancient or misunderstood, can ever diminish the intrinsic worth or the inviolable dignity of a human being. Community awareness is equally vital. Strengthening school health programs, training of primary health providers, involvement of community health workers, and use of digital tools for case detection can significantly improve early reporting and ensuring treatment at early stage. Empathy must remain at the heart of our response. A patient with leprosy is not a case number. He or she is a human being with aspirations, fears, and rights. Compassionate care means more than prescribing medication. It includes counseling, psychological support, rehabilitation, reconstructive services where necessary, and meaningful social reintegration. I commend the Indian Association of Leprologists and all healthcare professionals working tirelessly in this field. Your dedication to early diagnosis, quality treatment, research, and public education is deeply appreciated. Conferences such as this are not merely academic gathering, they are platforms to renew, resolve, strengthen collaboration, and translate knowledge into action. A leprosy-free India is a reality within our reach, driven by political will, robust health systems, and enlightened legal safeguards, but fueled above all by compassion. For centuries, the world looked away. Today, let us be ones who look directly into the eyes of our brothers and sisters and say, I see you and you are not alone. We must strive for a compassionate human future, zero transmission, zero disability, and zero stigma. I extend my best wishes for meaningful deliberations and impactful outcomes. May your discussions here translate into tangible progress on the ground, bringing us closer to the day when leprosy is not only eliminated statistically, but erased from the shadow of stigma and injustice. Thank you. Jai Hind, Jai Bihar.
Thank you so much, sir, for your dignified and inspiring words. Now may I request Dr. Vikas Shankar Sir, Organizing Secretary Lepcon 2026, to kindly deliver the vote of thanks.
Thank you. Sarve santu niramaya cha kustha. Sarve santu sukhna. May all be free from disease and also from leprosy. And may all live with dignity and well-being. Respected dignitaries, esteemed faculties, delegates, distinguished ladies and gentlemen, postgraduate students, and all. Swagatam, Dhanyavadam. On behalf of organizing committee, it is my proud privilege to propose the vote of thanks on 32nd Biennial Conference of Indian Association of Leprologists, Lepcon 2026, hosted by AIIMS Patna. Encompassing the pre-conference workshop on 27th, that means yesterday, and the main conference on 28th today and tomorrow, 1st March. First and foremost, I express our deepest gratitude to Honorable Chief Justice of Patna High Court, Mr. Justice Sangam Kumar Sahu Sir, for gracing this occasion and inspiring us with the presence and vision towards compassion, dignity, and justice for all. We extend our sincere thanks to Dr. Brigadier Raju Agrawal Sir, the CEO and Executive Director of AIIMS Patna, for his constant support and encouragement in making this conference a grand academic success. Our heartfelt appreciation goes to the leadership of Indian Association of Leprologists, IAL, including the National President, Dr. Sujay Sunitha Sir, International Leprosy Association President, Dr. P. Narasimha Rao Sir, Honorary Secretary General of IAL, Dr. Santosh Dev Rathore, the Treasurer of IAL, Dr. K. Rajalakshmi Madam, and all the other office bearers whose guidance and commitment continues to strengthen the mission of leprosy care and research in our country. We are greatly acknowledge the immense effort by the organizing chairperson, Dr. Abhishek Kumar Jha Sir, for giving us the strength, unity, and all the efforts for a teamwork which are needed in a team for making this conference a grand success. I also thank the organizing chairperson, Treasurer Dr. Pankesh Kumar, Scientific Chairperson Dr. Swetina Pradhan, Scientific Secretary Dr. Sriparna Dev, above all, our patron of Bihar Dermatology, Dr. Professor P.K. Roy Sir, for meticulous planning, strength, academic vision, and shape this enriching scientific program. Special note to Dr. Sudhanshu Singh Sir for their effort to bringing Honorable Mr. Justice Patna High Court at this gracious occasion present. A special note to all the organizing team members, faculties, speakers, session moderators, and delegates for across the nation whose contribution through their knowledge and participation and shared commitment for advancing leprosy care. We are also sincerely thankful for our pharmaceutical partners, supporting agencies and industries, collaborators for this valuable cooperations. Our gratitude extends to the dedicated Department of Dermatology of AIIMS Patna, their faculties, their PG students, staff for giving their effortless time and energy to making this conference a grand success. Finally, I would like to thank each delegate participants for this Lepcon 2026, not just a conference, but a collective movement towards scientific excellence, empathy, and human care for patients affected by leprosy. With these words, I once again thank everyone for their presence, support, and contribution. Jai Hind. Now I'd like to request to stand for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much all.
So, thank you all. Because of the time, we have slight rescheduling. The panel discussion will happen after the lunch break, and we are directly moving to the orations. For the orations, may I invite our respected chairpersons for this session, Dr. Kiran Katoch ma'am, Dr. Sujay Sunitha sir, and Dr. Abhishek Kumar Jha. Yeah, it's please.
डॉक्टर सुंदर राव नहीं आप जो भी बोलोगे वही चलेगा ओके सर ओके सर दैट्स फाइन सर डॉक्टर जाल मेहता का ही है सुंदर राव वाला
So after you read this, I will read the scene and then you invite him
okay,
to speak.
Okay, sir.
You will announce that first with the Jal Mehta oration. Madam is reading about Jal Mehta, then I will read this. Okay. Then this one you read.
Namaskar. Sorry to keep you all waiting. I will try to finish as fast as possible, all of us. I would just mention here that the oration awards which are going to be read today are Dr. Jal Mehta Oration Award, which is being conferred to Dr. PSS Sundar Rao, and Dr. R.N. Datta Oration Award, which is being conferred to Dr. Utpal Sengupta. So I'll request my co-chairpersons to please go ahead with this.
First is about Dr. Jal Mehta oration. I'll again request Madam to read a few lines about Dr. Jal Mehta before I introduce Dr. Sundar Rao. Can you read a few lines?
Thank you. Thank you, Dr. Sujay, as well as the whole committee. Dr. Jal Mehta was one of India's most distinguished reconstructive surgeons and leprologists, whose life was devoted to restoring function, dignity, and hope to persons affected by leprosy. At the time when disease carried out only physical disability but also deep social stigma, Dr. Jal Mehta combined surgical excellence with profound compassion to transform patient care. He not only devised several methods, but also he held several camps all over India in doing this reconstructive surgery. Dr. Mehta made pioneering contributions for leprosy-related disabilities, particularly of hands, feet, and face. His approach went beyond cosmetic connection. He emphasized restoration of function, enabling patients to gain independence and reintegrate into society. Through meticulous technique and structured post-operative rehabilitation, he established the reconstructive surgery as an integral component of comprehensive leprosy management. Dr. Mehta was also a visionary in rehabilitation. He initiated organized rehabilitation programs and helped to restore livelihoods and dignity to nearly 1,000 individuals who were cured of leprosy. For these extraordinary services to medicine and society, he was honored with the Padma Vibhushan by the Government of India. A committed leader and inventor, Dr. Mehta trained generations of surgeons and healthcare professionals, instilling not only technical expertise, but also to human and patient-controlled approach. He actively contributed to national leprosy services and academic forums, indulging in dermatology, surgery, and rehabilitation through multidisciplinary vision that remains relevant even today. In recognition of his enduring contributions, the Indian Association of Leprologists, together with his family, instituted the Jal Mehta Oration on Leprosy. This action honors individuals who embody excellence, leadership, and innovation in leprosy care. Dr. Jal Mehta's legacy lives on his countless lives he transformed and the high standards of compassionate and reconstructive care he has set for the field. Thank you.
This year, the Dr. Jal Mehta oration is being delivered by Dr. P.S.S. Sundar Rao, and I request him, Dr. Santosh, to bring Dr. Sundar Rao to the dais. Dr. P.S. Sundar Rao is one of India's most eminent biostatisticians whose career spans more than 6 decades and has been marked by outstanding contributions to medical research, epidemiology, and public health, with a particularly profound impact on the field of leprosy. Dr. P.S.S. Sundar Rao's contributions have profoundly shaped medical research and leprosy studies in India and beyond. An outstanding teacher and mentor and administrator, Dr. Sundar Rao has shaped generations of clinicians, researchers, and public health professionals. His leadership, intellectual rigor, and commitment to advancing medical science have been recognized with numerous awards, including the ICMR Dr. P.N. Raju Award, the Distinguished Alumni Award of CMC Vellore, and a lifetime honors from the Indian Society of Medical Statistics. In recognition of his monumental contributions to medical research and leprosy studies, it is indeed a privilege and honor for the IAL to invite Dr. P.S.S. Sundar Rao to deliver the Dr. Jal Mehta oration at this biennial conference.
I was hoping that I would say good morning, but I would have to say good afternoon. And I think 80% of the audience has gone for lunch. So I have a very select, dedicated audience for this oration. Can you all hear me? Is it okay? I have chosen a theme in line with the theme of the conference. I have put in 3 critical terms: thinking outside the box, working with the people to accomplish the impossible, which is, I'm going to end up by saying that it is possible, eradicate leprosy in India. The alternate terms had been zero leprosy, where we talk about 0 incidents, that is new cases, 0 disability, and 0 stigma. And I hope that the takeaway message from this oration would help those of you who are here to work with commitment and dedication. So let me move on to the purpose of this oration is both scientific progress and social responsibility. Yeah, a little more. Yeah. Okay. Yeah, I don't know whether glasses are better or... yeah. So as part of the oration, we're going to briefly examine the past. And you have listened to various speeches about the present, including the officials from the ministry. It's not helping, so. And so we evaluate the present and then we shape our future. Elimination has been declared, yet eradication remains unfinished. You can all see what is there, I don't have to read. The challenges are both biological and social. And I've added the word psychological. Numbers have declined. I am a statistician myself, but the statistics can be both good and bad, blunt or sharp. And as the Chief Justice has mentioned many, many times, stigma persists. Treatment exists, yet fear remains. If any one of you has been told a particular member of your family has possibly leprosy, immediately there is a shock, a bomb, a fear. And this is something that is present even today, when much of leprosy has been eradicated. In places like Europe and UK and USA, but I will be mentioning again and again that the mentality that persisted at that time, what we call as a middle age mentality, continues. And I will talk during this oration that we need to look at the problem with honesty and work with sensitivity and courage. I think Dr. Mehta's name has been mentioned. I would also like to pay a tribute to Dr. Jal Minokar Mehta, that he has been an outstanding personality in his time, and I'm sure he'll be happy to attend this 33rd Biennial and look at his legacy is being continued through our papers and our workshops, restoring the dignity and function of the people affected by leprosy. He was not only a surgeon, but he was also what you would call a social worker, a rehabilitation expert. And I think the all-compassing emotion right through from the past and even now is compassion. Compassion not because the disease is serious, but because of the thinking that goes behind every person who has a family member who has been told that he has leprosy. We know of many of our colleagues who had leprosy, but they don't have any disability. We know of many of our colleagues who had leprosy, but even in an era when there was no MDT, but they have been cured. But in the minds of people, leprosy is still an incurable disease. And Mehta's main focus had been to remove that kind of fear and the kind of mystery surrounding this disease. And he bridged surgery and dermatology and rehabilitation. And he was awarded the Padma Bhushan by the government of India for his exemplary and his work for leprosy patients. And so today we remember Jal Mehta, and we continue the legacy every conference to have an oration. And I was very happy to meet Dr. Jadhav and a few others who knew Mehta personally. And it is my privilege to be invited to deliver the Jalma oration. And I thank the organizers for inviting me and encouraging me to present this oration. I hope that what I mention in this message will be a kind of a continuation of Mehta's thinking. The structure of this oration, as I mentioned, I will do it in three parts. The past, roughly I have put a date as 1875 to 1950 when we became a republic. Then from 1950 till today is the present. And then the future from today onwards for the next, I don't know, about 75 years. I hope much earlier than that, we would be able to solve and eradicate leprosy. I hope you're not too hungry because I'm standing between you and lunch. Some of the delegates have already gone for lunch. Part one of the immediate past, most of you would know this, that leprosy has been present, and according to ancient Indian documents, archives, Dr. Shishrutas, and various other documents, it seems to be much earlier than 3,000 years. Skeletal remains have been examined in archives that leprosy was present much before that. Most of you would have noticed the pictures of the past about leprosy, how the disfigurement had been there. And even in Karigari during 1955-56, when I was working with Dr. Job and Karats and others, even at that time, we used to see a lot of nodular multibacillary cases, but not much of saddle nose, not much of lagophthalmos, even though it is there, madarosis, hoarseness of voice. And during the 50s, there was a Tamil movie called Rattaknir, that means tears of blood. And some of the famous actors who acted as a leprosy patient. This I'm talking about in the 50s, about a leprosy affected person, a leper, a word we don't use. It's very interesting that in spite of all the health education that the government of India and all of the state governments, all of the leprosy are doing, people remember that movie and talk about the disfigurement, the house and so on, but not about the latest information about the wonder drugs that we have, the kind of technology we have. And therefore, during my talk, I'm going to emphasize, you see, this audience is predominantly the people who are working for leprosy, not people who are working with leprosy. I hope the next conference we will have a strong group of leaders and people, ordinary people who have confronted leprosy and have overcome the fear and have taken away the myth and the mystery of that. The past, if somebody was diagnosed as leprosy, as you all know, was a death sentence. A person with leprosy does not exist. He is given a death certificate in many places, a begging bowl, shaved his head, he is being outcast. In no other disease does a family throw out their own family member except in leprosy. And therefore, when Paul Brand started his reconstructive work and established new units after people are operated, he called it New Life Center. That means a dead person has been resurrected. Even today, you feel that a person with leprosy is dead. Why is it that in spite of all that we are doing, that thinking still remains? There have been many attempts at cure during the past, and I think you all remember the Chalmogra oil. In Karigari, there is a tree called Chalmogra tree, and Chalmugra oil gave some possible response. But most of the therapy during the past has been palliative, has been, even if you have a picture of Mahatma Gandhi with Parachur Shastri, it was more in terms of massaging and trying to take care of the weak, paralyzed limbs. And the disease was considered in the past as incurable. There were a couple of people like Alice Bald who had used, and Leonard Rogers, you must have read about them, had used Chalmugra oil in injectable form and in oral form. But practically in the past, leprosy, there was no cure, almost up till 1945 when dapsone was discovered during the war.
Sir, it is 10 more minutes, sir.
So the main terms in the past were compassion and palliative care, and with that we come, people have been working, not only social workers but medical people like Muir and Kanolkar and many others, even while doing the social work. Even Wellesley Bailey, who started the leprosy homes in Purulia, they've all been trying all kinds of medications for both massaging as well as orally. But basically it was the heart and the brain working together to find a cure. So we come up to 1945, and then you have Paul Brand and others. He came to India as an orthopedic surgeon, and Dr. Cochrane, when he invited him to Chengalpat, leprosarium, and Paul Brand shook hands with some of the leprosy affected persons, and he found that the fingers were all stiff and bent and twisted. He asked Cochrane, I thought leprosy was a skin disease. You see a lot of dermatologists here. But why is it that the bones are affected? And Cochrane pretended to be angry with Brand, and he said, I am a dermatologist, you are an orthopedic surgeon. You find out why their bones are affected. And that is the beginning of Paul Brand's complete reversal of his career from an ordinary orthopedic surgeon to a reconstructive surgeon. In fact, Karigari was built for him to do some research on why leprosy-affected persons have their bones affected. And when he wanted a place next to the main part of the city where the CMC hospital was, the government at that time said, no, we don't want leprosy-affected persons, lepers flocking into the city. And they took him way back and showed him an area around Kudiyatham Taluk, Karigari, and said, you take as much as you want. And that is how Karigari was born in almost 1950, in about 200 acres, built, allow Paul Brand to experiment. And that's a long story, I'm not going to go into that, but basically Paul Brand was the first person. And today, you see the number of orthopedic surgeons who are involved in tendon transplant and reconstructive surgery. And so much of developments have taken place in that. And then during the past, there was a very significant event. That's why I started with 1853. 1873, Hansen, I've given his full name as Gerhard Henrik Armeer Hansen. He and his father-in-law used to fight whether leprosy was hereditary or infectious, and he demonstrated the infective organism. And so that was an outstanding event in the past, that leprosy was an infectious disease, and therefore there's a possibility of killing the organism and having a cure. Till that time, they said it was not possible to have a cure when it is a God-given curse or karma, and you cannot go against divine curses. But once Hansen discovered, and the term Hansen's disease was used instead of leprosy. I wish we had continued the term and removed the word leprosy, but we didn't. We continued the word leprosy. And so here we have the old stigma continuing in the name of leprosy. Okay, then in 45, after just around the time of the Second World War, we had dapsone or diaminosulfide, the DDS, discovered, which seemed to have a power of stopping the progression of the disease. It was a bacteriostatic drug and all that. And just as when MDT came, we all were so happy. When dapsone arrived, everybody was happy that finally we have a cure for leprosy. And 100 milligram of DDS daily was the dose that is given. And then some of the leprologists, some researchers were done that 100 milligram is not needed. You can reduce it to what? 75, 50. Became 25. During my time in Karigiri in 56, 55, we had what we called as low-dose DDS. And the lepre were very happy because they could get adapted to that level of DDS. And that was the beginning of monotherapy resistance or dapsone resistance. And that is how we end up the past, where we have a good drug, but because of certain policies, we messed it up, and therefore we had to look for alternative. And India got independence in 1946, 47, January, August 15th. We celebrated the Independence Day, and that was a new beginning and a new optimism. And 1946, I think Sir Joseph Moore had written a very comprehensive health and development report in 4 volumes. It is still available in most of the medical colleges. And in that, you'll find that Moore had very detailed description of leprosy, and he estimated at least 1 million leprosy patients at that time. So India at independence, as you know, history, I don't want to spend too much of time on this. You find that India started off with all the new ideas of 5-year plans. Jawaharlal Nehru and P.C. Mohanlanobis, who was the head of ISI in Calcutta, they had the vision and the help from various experts, ICS officers at that time, now IAS, in developing the India as a first-class modern nation. Okay? So that's the past. That's something which you all know. There is no need for it. Now, I've mentioned this in the oration because I think we all need to remember and keep in mind the burden that we had. The people are the ones who are continuing, and the past, with all its mythology and beliefs, particularly about the fact that leprosy is incurable. We go on to part 2, And during this again, you have listened to quite a lot of reports. I don't want to sound like another NLEB report in this oration, but the three outstanding events during the present era, one was the National Leprosy Control Program. In public health, we use the word about control, elimination, eradication, extinction. And so here, in the vision of the new India, with the new constitution, we had the National Leprosy Control Program in 1955. It was a vertical program with paramedical workers, non-medical supervisors, medical officers, almost entirely male. Would you believe that the vertical program was almost, and I was during that period. How would the men, paramedical worker, examine the women as the women don't get leprosy? And our paramedical workers were so resourceful, they took their wives and sisters to get the women examined, and they did a good job. Only thing is, it had a lot of flaws in terms of lack of privacy, and being a vertical program, again, the whole program was also isolated. Faster. Can you do part 3? Part 3, yeah. Okay, so this about the progress of the National Leprosy Control Program in 55 became National Leprosy Eradication Program by Dr. M.S. Swaminathan. And so the word eradication was used for the first time, and then it continued, and a lot of good work was done by Government of India. A lot of money was pumped in the budget. So much so that MTT fortunately was given free, and while the vertical program was dismantled, more women were added, auxiliary nurse midwives, Anganwadi workers, and then more recently, relatively, from the National Health Mission, the accredited social health activists, ASHA workers also put in. So you have an integrated program, primary health centers, lot of women, all the resources that are available, MDT adult and PB doses. In spite of that, only the late cases come to the primary centers. You look at all the NLEP statistics, you'll find that more 70% of the patients who come to PHCs are all multibacillary, already disabled, hoping that their disabilities could be cured. But that's the recent statistics. I don't want to go into it. You see the trends. At 2005, a sudden drop was made because the definition changed of what is prevalence. And with that new definition, we are now come down to almost low levels, but 2006 onwards, there is no change. It just continues. And NLEP had done special studies with the Ministry of Health, and you find that there are hundreds and thousands. Even one of the articles by Dr. Shengupta, he quotes more than 200,000 of new cases, hidden cases. So that is the key takeaways, and what we have is that we have MDT making its appearance. That's most like a god or goddess, and it was a game changer. It cured. Estimates say that more than 16 million leprosy cases are cured because of MDT. but all that evidence is mostly in the books. So we come to part 3 with the good intentions, and what I have said was that we have spent a lot of time since the discovery of Leprosy, on Leprosy. Even today we heard about the various kinds of researchers, lab researchers, molecular biology researchers, the proteins and others fighting the Leprosy. But Leprosy secrets are not revealed. We still don't know the epidemiology of leprosy. We don't know the portal of entry. Some guesses are made comparing it with tuberculosis. We talk about nasal respiratory and so on. But studies have shown that there could be extra-human reservoir. There could be other ways of doing it. And we try to look at contacts developing leprosy. And the first question they asked at the primary health center, is there anybody leprosy in the family? No, no, no. Not because of shyness or shame or anything, but really leprosy now is so widespread that you can get leprosy from anywhere. Need not be human. It could be extra-human, but we have no evidence on that. So what we have here is that so much of work has gone on, and even now it's going on. And even now the dermatologist talking to Dr. President, the dermatologists are more interested in the medical aspects of it. And we have, despite all that, Leprosy is a very clever opponent and enemy. It is not giving up its secrets. And so my main thrust in this oration is that we need a change of our mindset. We need to think outside the box. We need to involve, and I have included here that there are many philosophers who have said that we need to work with the community. And I mentioned the word of Goffman, who defined stigma as a spoiled identity, a cracked mirror. You cannot repair a cracked mirror. And there are two kinds of stigma. I didn't want to go and expand this about self-stigma. That is, a person himself feels that I don't want to reveal myself, as well as he has deformities and therefore other people restrict his participation. That is known as enacted stigma. There is more of self-stigma at this point. Yesterday at the workshop, we saw a lot of young youth people with non-healing foot ulcers. They come there because ulcer is not healed. They know it is leprosy, but they don't come and say that we have come for leprosy. So this kind of a situation, we cannot solve it through our lab, through our hospitals. It has to be a community partnership. And this is a famous philosopher. Most of you would know that. Go to the people, live among them, love them, learn from them, build on what they know. And once you do that, you find that the people will see we've done it ourselves. I would like to have more papers from the community where they have overcome this kind of stigma by working with the people. And I don't want to go into detail the whole question about evidence. And we don't need to actually know precisely the nitty-gritties of the bacteria. We can solve leprosy even without that detail, as John Snow did when he stopped cholera just by stopping the Broad Street bomb. So you see the path forward as for this audience, the emphasis, and that is what I'm sure Jal Mehta, if he were alive, would also say, because he had already started self-help groups and talking to the people. And I think if we spend more time, rather than on the leprosy, you might be able to get them to cooperate with us in being able to, as we honor Jal Mehta. So the role of IAL is very important at this point to reshape the thinking of the various nephrologists and the nephrologists. And what I had suggested was that we talk so much about scientific papers and so forth, but where is the evidence for the people? And most of our publications are in English. They are not in vernacular. So is it not possible for us, nephrologists, to begin a new movement whereby they write simple papers demonstrating the power of MDT? And I had suggested that we take some early cases and follow them up for even for 3 months, 4 months, 6 months, and show that the leprosy did not progress. Cut off the link between disease and disability. And once you get early cases, cure them, there's no disability. There's no stigma. There are no new cases. So I think zero leprosy starts with the nephrologists here demonstrating that with their kind of they have a lot of respect. They are not just medical people. I feel the nephrologists are more psychologists, sociologists, and physiotherapists, and people respect them. And this is a matter of not public, kind of a sensitive, you talk to them confidentially. Tell them, I am here for you. I am here for you. I'll be with you. You see that your son, your daughter, your wife doesn't get leprosy, doesn't continue. There's no disability. And I think I would like, I was telling the president that we should have a small core group in IAL who will just work in producing pertinent vernacular papers, bulletins, and shouting from the rooftops that here you have a drug, make use of it. How do you get early cases? How do you get, unless the people themselves come forward with that and tell you confidentially, doctor, I have so and so, so and so. And the nephrologist takes them into confidence. Then they believe in the nephrologist, have the drugs, cure leprosy. We must begin, even if we begin in 2026. I think even by the next biennial, I'm sure you'll have significant progress with this methodology. So I will not prolong my oration. I just give best wishes to IAL and thank you. Jai Hind.
My honor.
Good afternoon, everyone. Moving to the next session. That's R.N. Datta oration. Mr. Rabindranath Datta is remembered with deep respect as a man whose life embodied integrity, humility, and unwavering moral conviction. Though not a member of the medical profession, his influence was profound, particularly in shaping the character and values of his son, late Dr. Ratindranath Datta sir of Kolkata, an eminent dermatologist, leprologist, and past president of IAL. Dr. Rabindranath Datta belonged to a generation that placed a high value on education, discipline, and service to society. He believed deeply in the transformative power of knowledge and in the responsibility that accompanied it. Though quiet strength and principled living, he matured in his family a deep respect for human dignity, compassion, and perseverance qualities, and became hallmarks of Dr. Ratindranath Datta's professional life. As a father, as a guide, Mr. Rabindranath Datta encouraged intellectual curiosity while emphasizing ethical conduct and social responsibility. His influence reminds us that professional excellence is often rooted in unseen foundations, in homes where character is formed, values and strengthened, and service is honored. In recognition of his enduring legacy, IL and his son, Dr. Ratindranath Datta, instituted the R.N. Datta Memorial Oration. The oration honors not only an individual life of principle, but also the vital role of family and moral grounding in shaping leaders in medicine and public service. Personally knowing Dr. R.N. Datta sir, he was friend of three generations, my father, me, and my son. In last 10 years, I worked with him in many conferences, and I really miss him, sir. The R.N. Datta Memorial Oration stands in tribute to the enduring power of values, integrity, compassion, and commitment, which continues to inspire in the field of leprosy today. Thank you.
It is my privilege to invite Dr. Itu Singh to read the citation for Dr. U. Sen Gupta, who gets this award. Thank you, Itu. Itu, please.
Thank you, ma'am, for the kind invitation, and it is my proud to give the citation for Sen Gupta, sir. The Indian Association of Leprologists is deeply privileged to honor Dr. Utpal Sen Gupta with the Rabindranath Datta Memorial Oration at Lepcon 2026, the 33rd Biennial Conference of Leprosy at All India Institute of Medical Sciences, Patna. Dr. Sen Gupta is a distinguished scientist of national eminence whose lifelong dedication to leprosy research has profoundly enriched the scientific understanding and control of this disease. Over decades of committed scholarship, he has seamlessly integrated rigorous laboratory science with public health application, ensuring that research findings translate into meaningful advances in diagnosis, patient care, and disease control strategies. A graduate of Bengal Veterinary College, Dr. Sen Gupta earned his PhD in pathology from PGI Chandigarh, where he also served as lecturer. His early promise was further recognized through the prestigious Commonwealth Tropical Medicine Research Fellowship at the National Medical Research Institute, London, where he conducted pioneering studies on the survival and transmission of Mycobacterium lepremurium in experimental models. Joining the Indian Council of Medical Research as Senior Research Officer, Dr. Sen Gupta established the Department of Immunology at the Central Jalma Institute of Leprosy, Agra. Later he serving as its director until 2001. Even after retirement, he continued to serve as emeritus scientist at JALMA and subsequently contributed to national public health initiatives, including a Bill Gates-supported HIV-STI surveillance project at the National Institute of Medical Statistics, ICMR, New Delhi. Since 2011, as consultant to the Stanley Brownie Laboratory, the Leprosy Mission Trust India, he has guided research on early diagnosis and biomarkers of leprosy reactions. Dr. Sen Gupta's major scientific contribution include the standardization of the Dharmendra lepromin antigen, the development of monoclonal antibody-based serodiagnostic assay, and seminal work on immune mechanism, tolerance, and serological markers in leprosy. And he has also involved in the development of field-friendly diagnostic tool, and he has authored over 239 scientific publications, mentored numerous doctoral scholars, including me, and received several prestigious honors, including fellowships from NASI and NAMS, as well as IL Lifetime Achievement Award. Through scientific excellence, mentorship, and unwavering commitment, Dr. Utpal Sen Gupta has left an enduring imprint on leprosy research in India and globally. The IL take immense pride in conferring upon him the Rabindranath Datta Memorial Oration on February 28, 2026 at Lepcon 2026 in recognition of his outstanding and lasting contribution. Thank you.
There is a pointer. And here, how do you go back and forth? Slides कैसे ऐसे इधर oh yeah I think okay, maybe yeah is front no okay I'm very grateful to the organizers okay ये front है ना ये पीछे ये front अच्छा this is the point this point oh pointer ये है नहीं तो कहाँ है ठीक है I'm grateful for selecting me for this oration. A tribute has been given to I start straightly go with my topic. It is a multi-pronged approach we should take at this time of eradication because it's the small number of patients, of course, they are coming regularly, and we are unable to stop that prevalence of new transmission of the disease. So this is the WHO figure of the whole world. You can see here that how it has come down here, and it is becoming static here. And again, prevalence and NCDR, if you take, it is becoming static here. It is a plateau, and plateau is remaining. Sometimes it is going with a peak if there is something wrong, and then it is remaining at the same level. So this indication is that it is, transmission is going on. So it is the national figure. That was the figure for the world. This is the national figure. So this, if you take per 10,000, prevalence and NCDR, they are almost same, 0.7 and 0.6. Now, this is the total number of cases. At present, 58.4% of the total number of cases of the world is constituted by India at present. And this is the, I am giving here the world map we have in India, we have in Indonesia, we have in Philippines, we have in Brazil, next to us is Brazil, and then we have in some parts of Africa, of Ethiopia also. And then this is the national figure. You can see here the maps where it is quite prevalent, and the what is called this PR has gone down quite a lot, and in several places it is more than one. Several states, you see it is more than one per 10,000. Okay, let us go to the next, and this is the ANCDR. And ANCDR is about 25, 22, 23, which is quite high in certain states, but it is 6.27 or 2.08 per 100,000. Okay, let us go again, and it is the different parts of the way, and I want to show this. You see this part of, you see the prevalence, the ANCDR is 3.08 in Tamil Nadu, and out of that children percentage 6.38. That means transmission is quite in the southern part, where they have almost taken off due to MDT trial for many years. They have taken off in Tamil Nadu, say, and you see here that child cases are more, percentages are more in those numbers, in this small number. So that means transmission is very active. Anyhow, WHO theme is unite, act and eliminate. So you know unite, let us unite, eliminating this. You sensitize everybody, NGO, healthcare system, government officials and communities and individuals. And then immediately you act and you take proactive measures, public education, early diagnosis, everything. And then eliminate the disease as a global goal is achievable, and which should bring us closer with development of investment in diagnostics and innovative treatments. The same thing, if you take towards zero leprosy, the implement integrated countrywide zero leprosy roadmaps should be made, and scale up leprosy prevention alongside the integrated case detection, combat stigma, ensure human rights are respected, manage leprosy and discomplication, and prevent new disability. So there are four pillars, and implement integrated country-owned zero leprosy roadmaps in all endemic countries, scale up leprosy prevention alongside integrated active case detection, combat stigma and ensure human rights are respected, manage leprosy and its complication, and prevent new disability. Okay, in Indian strategy, the pillars are strengthen the leadership, commitment and partnership, accelerate case detection, prevention of disease, disability, stigma, discrimination, violation of human rights, digitization, that is NICUST, digital reporting and drug management. Now these are the pillars which have been already chalked out. Now let us see. I say that I have given 7 points for multi-pronged approach at the stage where we will have to eliminate the disease up to zero. If it is our aim to go up to zero, then we will have to have a multi-pronged, concerted and coordinated approach, and everybody should coordinate together and work together. First is early diagnosis I have given. Let us see what we can do in early diagnosis. The early diagnosis, using cardinal signs, definite loss of sensation, thickened peripheral nerve, presence of AFB in the skin, although leprosy can be diagnosed early, many times all these cardinal signs may not be present or satisfied, and hence a simple laboratory-based assay would be most useful for early diagnosis. Several attempts have been made with serological-based assays, PGL and many other antigens based on these, but it cannot diagnose all cases of leprosy. It lacks specificity and sensitivity. Recently, molecular-based assays, there are several, but I have mentioned A because we are working with it. RT-PCR, multiplex complex, that is 3 gene together, 16S RNA, SOD-A and RLEP, 3% sensitivity with 100% specificity you can diagnose. And that is at the field level where work is going on. It is feasible, it can be done at a lower cost, as well as it can be interpreted immediately. There are several on the serology which cannot. I have given this data just to show, but I just show that you see, you can, serological test, you can detect LLBL, but on the earlier side, early case, BTTT, they are not, you cannot detect all. So you take any antigen. So this multiplex PCR, I told already that you can detect with specificity and sensitivity quite well. And it can be done, sample can be taken in a Appendorf tube. It can be taken to lab, this is laboratory based of course, but it can be taken to field, and it is done in the field now, and you can do an assay this, and within few minutes you can get the results and interpret it. We did this in a field manner with our all TLM hospitals in India. I'll show you how TLM labs are, or TMS hospitals are distributed throughout India in my next few coming slides later. And we took samples from both slit skin smear and peripheral venous blood. We took both for serology and compared them and multiplex PCR. And then we compared them, we found that these are the numbers of cases. I don't go into detail. And you see that if you do a multiplex PCR at the lab and as well as in the field, they are similar. That means in the field it works. At the point of care test, I mean, where the patient is there, you take samples and do the assay. There is not much of difference. But if you do a serology, you cannot, the percentage is quite low for these same samples. So next is complete treatment without default. This is very important. Even if you take today, in any clinic you go, there is at least on an average 40% default is there. This is a big issue and it should be taken care of. So if you take the records, what we have in publication, actually 50% for patients at the hospitals, and if you go beyond from the near the hospitals, so the 50% default from there, and away from hospitals, about 60% they default. Still today, if you do it, any survey, any trial you take, and take intake of your patients, a new drug trial you are giving, there also it is more than 40% default. So it is very difficult. Now, where are these patients going? We should account for those. Here I am giving a figure that as the dose of your MDT increases the day by day, the default rate goes higher. Means as the number of doses are increasing, the default rate goes higher and higher. Then non-inclusion of defaulters is a big problem. That means if there is default, as defaulters have viable bacilli present, they are spreading in the community, so the transmission is going on. Defaulters mostly come up later with relapse of the disease. Many come with a relapse of the disease, and probably it may be it may not be responding to MDT. It may be a resistant one. Will lead to the emergence of drug resistance because of this. Considering the above, the defaulters have to be identified and treated fully and effectively. Leprosy disease should be declared in all states, should be declared notifiable disease, and every leprosy patient should be registered under NICUST. The central government, CGHS says NICUST is there, so you should report to NICUST. They should get one digital number, and wherever they are going with that number, they will be identified, so that every patient in the country could be traced and fully treated. Next is treatment duration till MLEPRI viability. This is another big issue. Wherever we have given the trial, we have not accounted for the viability. We give at a fixed dose therapy. Now, I don't think fixed dose therapy is a it is a comfortable approach, no doubt about it. But it is not a good approach for the patient, because all bacilli cannot die with fixed dose in all patients, because the dose of M. leprae, quantum of M. leprae will vary from person to person. It may be 1 million or few, more than 1 million in one, and it may be less than that in some other. So your dose of drug should be different from all. So how to do that? You can do by molecular method, and we did this, and we published that also. I show this figure. You have seen there are 3 genes we took. The main gene, 16S RNA, and is a EXA gene and heat shock protein. These 2 genes, they correlate with growth of M. leprae in foot pad. This has been proved, published. So we took these 2 genes, and you find that with 6 months treatment, they have gone up. Some has gone up, some are going up. Even after 12 months treatment, there are viable bacilli left. So what happens to those? Nobody is taking care of, and this I can tell you that M. leprae in an advanced stage with that high dose of M. leprae, immunity doesn't come back. It is a permanent negativity to M. leprae. You don't call back their memory to intercurve the bacilli and they will kill. No. Immunity to M. leprae remains nil for a long time, even after therapy. You do lepramine, after 2 years of, in a lepromatous case of leprosy, 2 years, 3 years of therapy, lepramine reaction remains 0. So that means they cannot deal with the whatever viable bacilli is left after 12 months of treatment, or even 2 years of treatment sometime. We have not done that, but we will be show you later. So this is another group with 3 genes, same thing. So it is very alarming that these patients will come back with relapse to you. Okay, this is very easy to do. You take a skin scraping, give it for analysis to a lab, if a reference lab, and see whether viable bacilli are left or not. Go for the treatment, further treatment for that patient. It can be done. In every patient it can be done if we want to do. Multi-pronged approach is fourth is screening of all household contacts and neighbors for early signs of leprosy. Now, contacts has been defined, and I am not going through the detail, household, neighbor, because this has been done very well for the prophylaxis prophylaxis therapy, which is going on, and you can do that easily, so the contacts are, you can go and search for those contacts, whether you have leprosy in that. So you'll have to go for all contacts, social contacts, air contacts, household contacts, neighboring contacts. Then look for drug resistance. The fifth one is look for drug resistance to rifampicin or fluoxetine, especially in new and reactional patients. Because reactional patients, it has been seen that they often come with a resistant M. leprae. New patients has to be taken because it may be permanent, it may be a primary resistance case to you. So this has to be done. How can we have published this, all this from our TLM hospitals. We published all these resistance cases. There are several publications. I am not going into the detail of that. So even outside the what is called drug resistant region, even in the pump, some resistance, some pump, this RPOC, the 16 unique SNPs where we have found the efflux pump resistance. and those gene resistance, and we published those also. So you can see here that rifampicin resistant from ENL cases. And there are several reports with PGI Chandigarh and RML hospitals on jointly it has been published. Those are all mostly from resistant cases. From reactional cases. Now this is where we all TLM hospitals are distributed. You can see almost it represents all parts of India. So you get samples from all these areas. So now we are getting from throughout India almost, it comes to us, and you can see that from all these places the resistant cases have been reported. All these parts of India, the resistance cases have been reported. Now, these are the areas. You can do it easily, send the sample, send to the reference lab, and immediately they will tell you whether it is susceptible or resistant. Now these are the regions. I am not going into the details, the gene regions, the nucleotides where you can go, it can go for change in the nucleotide and there is resistance. So AMR, if I take this figure for India and we have samples from all India, you see to rifampicin it is rising, and 2025 figure it is representing all India, whatever samples we get. So it's not, even on the top of it, we are giving post-prophylaxis with rifampicin, single dose. Single dose rifampicin is a very risky thing because the half-life of rifampicin is 5 to 6 hours, 3 to 6 hours. Half-life, and 15 hours it can remain in the body. You are giving one dose. The bacilli which has not taken, mostly they sleep, they don't grow. They will not take, as Dr. Katoch was telling, they will not take it inside at all. They will remain like that. But whichever is growing, they have got it one dose. Okay? And okay, that bacteria may die, but other bacteria which will remain, they will come up, they have taken and you have given one dose, it may not be effective, so they will come out with resistance. I think resistance will increase with PAP in India. If you take, they have taken it, with PAP has been taken throughout India, so we will find more of rifampicin resistance in future, I am sure. This is the picture we are giving for India. And tomorrow we will be able to say, because we are still doing work with that, we will give a figure whether it is rising or going down. Okay. Now this is the certain states. Purulia is a source of resistance. There is a lot of nucleus. They are together. You see, this is Jharkhand. There are areas full of resistance cases. You see, this is UP, and you can see here, this is Prayagraj, Allahabad, Naini is there. We get samples from here, so many resistant cases. This is in Delhi, this is Shahadra. We do not know where from they are coming. Floating population is there, so we do not know actually, but these are our figure from our hospital in Delhi. Now this is from Bihar. The lot of cases are there, but we don't know. Now what we should do at this stage, based on these findings, we strongly recommend setting up a robust active drug-resistant surveillance mechanism urgently needed throughout the country to stop the transmission of drug-resistant epilepsy in the community. Because if drug-resistant cases are going back and we are not detecting, and suppose they are going back, and if they remain surveillance mechanism in it, if I detect today a drug-resistance case, I should go to that village where he is staying, how he is giving it to the children. So we will have to survey. Without that, because they will come out pulmonary resistance tomorrow. So we should be cautious enough. We should immediately go, and that is the function of the nation. India should do this. Every drug resistance case should be surveyed for its contacts in the population, because primary resistance will be coming up tomorrow. I'm sure it will come up, and we'll see a lot of primary resistance cases in the community tomorrow. And I'm sure, I'm telling to it, strongly telling, because it is our figure which I'm seeing, and nobody is following up these drug resistance cases. Nobody. We have started, and we'll give you figure tomorrow. Screening of contacts of drug resistance cases to search for emergence of primary drug resistance in the community. So this is our strong demand now, but government is not hearing, and I will again thump it, whether it is good or bad, or whether it is not, they are not liking, but it should be done immediately. And we have some figure that transmission is going on. They have not come up as cases, but transmission is going on. This is the initial. I will not give you internal news. It is the, I am giving you just now because I am not going there. And you see, this has gone. We have skin smears positive, nasal smears positive for drug resistant Lepri. Tomorrow they will come up cases. These are positive now. So when they will come as case, and we are following them up from our at least figures. And then last is stigma. Stigma is very much there. Stigma has not reduced at all. Stigma is reduced in places where they work with leprosy, people who work with it. Still people who work with leprosy with mask, I have seen. Why? That means you have stigma. So, if you do not do this properly, you have a problem. So reduction of stigma is very important. And I have given, I don't want to go through this because these are all known to everybody, how stigma should be reduced. You have to educate people, educate the personals who are working. If I go with a mask in a leprosy patient's house, stigma is there. He will think, okay, it goes to, spreads to nasal secretion, nasal boy, yeah, I will also wear. So stigma is there. Educate people. These are all normal things. We know all this. Why to tell? So, elimination of leprosy is a multi-pronged. Early diagnosis, complete treatment without default. Strong. Not that for 12 dose. Country has maybe 12 dose. But TLM gives is 25 months. We give 24 doses. The reason is this, because they come with relapse. Then treatment duration till viability. Personalized treatment. I think, who will support me? Here, Sunil Dogra. Dr. Sunil Dogra. Till viability. Screening of household contacts and neighbors. Thorough. It should be, during the time of elimination, it should be more centric. You should go to their house. It is not that leprosy is not there. It will come up again. Then look for drug resistance rifampicin. And screening of contacts of drug resistance, for primary drug resistance. And then reduction of stigma. And if we can put hands together, coherent together, and work together, coordinate together properly, then only elimination of leprosy will be there. Otherwise, what is going to happen? We have done so many things. Such cases will keep on coming to us. This is the fresh case. A fresh case which has come. I will not tell from where. So this will come. This will come all the time then. So this is our team, and many of us are not there as prominent scientists. she is not here with us. She has joined another institute, Mulika. So, and there are certain technicians, good technicians, they have left. Certain people had done PhD and have gone out, working somewhere. And this is the present situation. Chief of our research chief, Dr. Joydeepa is here. And that's all. I think, thank you very much. Thank you. Thank you. तो अब तो ये सब लोग नाटक करोगे नहीं बैठने का जरूरत नहीं है
Imprisoning you in that chair. वो chair में imprison कर रहे थे. ठीक हुआ?
ये बैठना पड़ेगा ना
Dr. Abhishek.
हाँ सर बिल्कुल बहुत अच्छा हम वही डिस्कस कर रहे हैं हम भी आप लोग का उद्देश्य में डिस्कस कर
So that concludes our morning sessions and we are slightly delayed for our lunch. So we are cut shorting the lunch and we will gather again at 2:30 and we will have the panel discussion at 2:30. 2:30 in the main hall. All the parallel sessions will also be starting at 2:30. The parallel sessions are just, you can take exit from the right side and take the stairs. They are in the admin block. On the ground floor there is lecture theatre 1 which is hall C, and on the first floor there is lecture theatre 2, that is hall B. So award paper sessions and free papers and scientific sessions, they will be starting at 2:30 p.m. And there is a scanner which you can scan. All the pictures are uploaded on that and you can get your pictures from that scan. Thank you. Thank you. We will meet again at 2:30.
Is coming down. On the other hand, there are other diseases which are becoming bigger priority. For example, tuberculosis. And the other thing is, what is the incentive of continuing to work on leprosy. So that's again an area which needs to be looked into. Like we have young PGs here, right? Why they should be taking interest on leprosy.
Yes. Yeah, very well put, but the questions probably, answers are not easy, yeah, probably. But of course, there is a need to stop the erosion or loss of expertise, or probably more importantly, probably interest in leprosy. Yes, Dr. Sujay?
I think just we need to keep the leprosy agenda alive.
Yeah.
And we do that in conferences like this, but more than that, at a medical college level, if there is more awareness on the actual situation in India, the need for that skill, expertise, I think part of that. At a community level also, to keep the messages there that leprosy is curable, all the positive messages, and that if there's a skin lesion, it should be seen by a person. So I think there should be increased awareness among the health professionals as well as at a community level.
So,
and I think,
in other words, what you suggest is that you have more workshops in medical colleges level, as well as probably more interactions at community level.
Why not more awareness and CMEs and medical colleges too?
CMEs,
yeah.
Yes, absolutely. Yeah, got it. So now, okay, now coming to the how to involve the structured involvement. Now there is the absence of formal structured involvement of dermatologists under NLEP. While the National Strategic Plan of 2023-27 mentions IADVL and other private practitioners should be involved more actively, that is one of the National Strategic Plan agenda is to involve. But is there any structured plan or how they want to go about it? Dr. Lily, you can say that how CLD or NLEP wants to, because while the document mentioned 2023, I think it's also here. Yeah, so what I like to say is that is there any structured way that they would like to look at, or is there any strategy in place for NLEP or CLD, how they want to involve dermatologists or IADVR or IAL or other private practitioners?
So under NLEP we have a structure in the states under SLO. We have SLO, DLOs looking after this district. So now the dermatologists of the states, in the states and medical college, I think they can have a meeting together. They'll have a sort of meeting and workshop together, and they'll work it out how we can come together, because now our effort have to be intensified in all the components. Now we need the dermatologists also, or the districts, then private practitioners also, they can come and join with us. And moreover, now notification is declared in 14 states, so we should all work together. It's not only in reporting also, we can have a meeting together and then we can work it out together.
Yeah, in other words, what you are intending is that the dermatologists should have more involvement, and probably there should be meeting between state leprosy officers, district leprosy dermatologists.
Yes.
But maybe I think, unless I think a formal, I mean, if not a directive, a letter of such intent comes from higher up from your office, probably that dermatology should be there, interaction should be there, and also that in any difficult to diagnose cases, dermatologist help can be sought in a periodic basis, once in a month or once in 15 days or once in 2 months. The periodic engagement guidelines and protocols, if they are set from, I mean, higher your end, I think it will be more, it can flow down easily, and most of the people will have such something in the hand so that for them to follow those guidelines or directives.
So plans are already in process. We plan to have a meeting together with IAL and IADVL. So I think we'll be working out and we will be issuing letters in future.
Okay, thank you. Yeah. Anybody like to say?
I think precisely we had this symposium, national symposium, to sort of initiate a dialogue in Mumbai last month. And some of these deliberations and discussions have brought out certain recommendations which we have circulated. And one of them is to have a formal communication from CLD to the IADVL Association, CLD to IAL. So, and moreover, also from IADVL to all the members, because IADVL itself is a very big family, almost 20,000 membership. IAL also another professional big membership. So either ways, there should be a communication from the central to these two associations, from this association to the members. Those of you are interested, and there is, I remember in the previous meetings in NLEP, there was already a directory of all the dermatologists as well as the leprologists. So those who are interested can nominate their names, and as Dr. Rao mentioned, that you can identify certain districts. You mentioned today 141 districts are still endemic. 121 has already achieved transmission. The focus should be on these endemic districts, and we should identify the list of dermatologists, leprologists at the district level. Maybe you can even a pilot also. You can have a pilot operational work on this, and then sort of influence the national, scale up that.
Yeah, wonderful suggestion, Dr. Bai. Yes, this kind of thing. Probably, I think what he was mentioning is that, yes, the minutes are the symposium were compared, that all the discussion took place were compared, and we are going to submit them to the CLD in future. I think it's probably just on the way, and many of these issues were discussed.
Because this is the only way you can translate this recommendation into action.
Yeah. Yes, what was also discussed in that meeting is the representative of IAL and IADVL mentioned in the Mumbai that dermatologists are very keen to work hand in glove with NLEP, especially so in those high endemic states and districts. We have mentioned 5 states where it is still more than 1, and also, also in those 140 or 120 odd districts. Yes, you want to say something from there? Yeah.
I just wanted to add in this discussion. One of my family friend, he was a DLO in Raipur, and he was very close to me. And I said, why don't you provide us some free medicines like NLEP program? You choose the dermatologist from Raipur and you provide the medicines. Those patients are diagnosed and they should be given the free medicines from those centers. And whatever formality, register, maintenance, everything that dermatologist will keep. So he started this free NLEP program, and MDT and this possibly these medicines were being provided from my clinic for 2 to 3 years. And every month he used to collect the record from my clinic. The person used to, from district leprosy hospital, he used to come and collect a register, the name of the patient, every detail, whatever. And as soon as that doctor was retired DLO, and there was no one to hear me.
Yeah,
it was not continued.
Sorry, we got something. So I thought you are sharing your experiences on that, but yeah, I think let's have it little later once the discussion time is very short now for us. Thank you very much.
I would just like to add, sir, I would just like to add.
Please.
In fact, a letter will be issued very soon. We are including IADVL and IAL in the TRG, Technical Resource Group of NLEP.
Oh, wonderful news, ma'am.
Yes, this is going to be issued very soon because we have already put up in the file and it has been approved. So the letter will be coming very soon.
Yeah. So I think it's a time Sujay should be congratulated for all his efforts. Yeah. Sujay and Sunil. Yeah. And then Dr. Ashok, you want to say something? Yeah.
I came across a practical solution actually yesterday while visiting one of the blocks, and where we discussed with the health workers that what about one dermatologist getting connected to 5 PSC medical officers through a WhatsApp group. So they form a WhatsApp group, and this dermatologist becomes the mentor for the medical officers of these PSCs. Now the advantages: enhanced skills of the medical officers, early diagnosis of atypical cases, early referrals, investigations and treatment, early and stronger linkages of cases diagnosed at higher facilities, and higher treatment compliance, contact screening and PEP, and decrease in disability. So there could be so many advantages which we as a group discussed if this thing can be introduced, and it can be done quite easily.
Thank you. I'm sure Dr. Sujay and Dr. Lil ma'am was taking note of it. Probably we can pursue it, how to do it. While the nitty-gritties like this are very important, but I think in principle, madam has informed that IADL and IAL is going to work with Central Leprosy Division in some capacity. What capacity and how it can be worked? This is one model, is suggested by Dr. Ashok is good. Yeah. Anything?
I have one submission to Madam from NLEP. Just a letter may not serve the purpose for the meaningful engagement of dermatologists and IL members. I would suggest that there is a clear-cut structural engagement mentioned at various stages, that these are the roles and responsibilities which dermatologists can play at various stages: diagnosis, treatment, reporting, and whether they will be given some kind of recognition. It may be some kind of a letter or some monetary incentive for their staff. So it has to be very clearly notified along the framework of the program. If we just issue a letter to the society, it is more of a collaboration call, but on ground it may not implement. So my suggestion is, please formulate a subcommittee who can work on what are the ways of collaborating with dermatologists and IL members, and how they can be engaged at various levels. At the diagnosis, treatment, reporting, follow-up, disability prevention. So there might be some kind of amendment in the program framework.
Absolutely. And only I request Dr. Sunil and Dr. Sujay Sunita, maybe you can just make a note of what you're saying and maybe send it as a note to ma'am, and also keep a note for ourselves so that we can circulate it later to the government of India and Giteji and his office. Thank you. I think we just have about 10 minutes time. I think we have another 4 questions, not many. But yeah, continuing with this question, Dr. Sunil, do you feel that now that leprosy is notifiable disease, does it affect reporting? Suppose I am a private practitioner, or some of you are, like Sujay is running a NGO clinic and you see a lot of leprosy patients. Do you think he is affected by this notification that he is unable to notify every patient he has seen? Will there be any punishment, so-called punishment, if you don't notify them? Because of course there are 20 other diseases which are notifiable for Government of India, but for example COVID is, and also dengue fever is also notifiable, but I don't think there is any fear about not reporting those cases, but there is surprisingly there is a lot of fear among dermatologists and others that once leprosy becomes notifiable, non-notification becomes a punishable offense. You have anything to comment on that?
I'm not sure about the legal aspect, maybe madam can clarify, but if we all notify, it will add to the actual burden of disease in the country. And I would also suggest that all the practitioners, whether apart from public hospital, should be given access to NICUSH too, so that they can document case.
Can you say it again? You want?
I want that all the practitioners should also be given access to NICUSH too.
Yeah, so NICUSH is an app wherein registration of new cases happens in leprosy in India. So similarly there is one app called Nikshay app, which is for tuberculosis, Nikshay app. Whereas Nikshay app, private practitioners, clinics can register in the Nikshay app and also can inform about new cases of tuberculosis seen by anywhere in India. Whereas such facility, if it is extended to NICUSH app, so that all the private practitioners and clinics can also enroll themselves in NICUSH app, it becomes easy for reporting of patients. So this is what you meant, is it not? Yeah. So any comment from you, Dr. Lily, on this? On notification, any other further work is happening or further developments, how to enhance or encourage people to notify more and more leprosy cases from the community?
Sir, as of now, reference from private practitioners are in a very small way.
Yeah.
So we are expecting more private practitioners to refer the cases to us.
But the process, the point is that once it becomes notifiable, suppose I am running a clinic, say in this part of Patna, whom I should notify, how to notify, those nitty-gritties has to be worked out.
Yes.
Yeah.
So that linkages has to be made with the district leprosy officer.
They should communicate to them.
Yes,
No,
yes.
no, what I'm
So
saying is the mode of communication, whether by a messaging or by a call or by a monthly register, I think these details have to be still worked out. Or
it has to be worked out.
Has to be worked out. Thank you. So probably these are very important, yeah. Dr. Pike, can you give a quick response, please?
See, yeah, you mentioned about the penalty. In tuberculosis, there is a provision for that. But in leprosy, we had discussions when Dr. Mandal was there. So this clause of penalty was discussed extensively, and there is no such penalty.
Okay.
But
yes. Can you say it louder again?
Yeah, there is
no penalty
there is
for
no
not
such
reporting
penalty.
cases.
But the DLO can ask an explanation that why the case was not reported.
That's it. There is no penalty, or there is no, the dermatologists in private practice or others who are not having access need not be afraid that if you don't seen a case and not report it, something you will be punished. Probably it's ideal that they expect you to report all cases, new cases seen by you in leprosy practice. Sir, can you be quick question or comment, sir? Yeah. Can you say it again, sir? Can you go with in the mic?
Any notifiable disease will bring in stigma.
Huh? Is?
Stigma. It will bring in stigma.
Stigma. Okay, yeah. Stigma. Yeah, that is a different point. Yes. Nice. Well taken. Okay. So now this is the question directly to IAIL, President IAIL. So IIDBL is recognized as official partner of NLEP, while IAIL is still not an official partner as per the records. So, as the President of IAIL, is there any need to make IAIL also official partner? How we are going to go about it?
Yeah, I think it's important because IAIL also has people working in leprosy or leprologists, all committed to one cause of this disease.
So this is the right time for you to contact Lily Madam to make IAIL official partner?
Yeah, but I think in personal communications as well as now, Dr. Lily has expressed that the CLD would like to reach out to not only IIDVL but to IAIL. So that's a good move, and I think as IAIL also we are very keen on working along with you.
Will you be communicating them through a letter that IAIL likes to become official partner?
Sure.
Yeah. Would you like to?
Yes, I think Dr. Sunil and myself would like to take that forward with Dr. Santosh Rathod also.
Wonderful. Thank you. Okay, so this is specifically one question. Specifically, I just want Dr. Ashok Kumar's opinion, and of course, Restasim can also give. What is the role of NGOs? Like for example, ILEP. I mean, ILEP is the biggest, big bunch. There are about 9 partners or 8-9 partners are there. And the optimal utilization of expertise of dermatology community for the benefit of Indian leprosy at large. Yeah, Dr. Ashok ji.
Thank you.
Ashok ji representing NLR. He is NLR India.
So, as we all know that NGO plays an important role as a bridge between the system, right, and the community. So, especially connecting the dermatologist, either directly or through the system, NGOs can play a good role. Second, NGOs, they strengthen the frontline capacity. Like I gave an example of healthcare workers. So we routinely provide technical assistance to different levels of health workers. Third, NGOs can enable structured engagement with professional associations like IAL, IADVL, IMA also. Because if you are saying general practitioners, IMA needs to be engaged. Also, we improve quality of care by passing on the learnings from the different guidelines of government. Fifth, NGOs, they are also like innovation platforms. Just to give a few examples, we heard TLM in the pre-lunch session, where they have developed qPCR test, right? Similarly, NLR has worked on prevention. Currently, it's working on PEP++, I'll be sharing tomorrow, plus helpline. I mean, there are so many things. So NGOs also bring the science along with them. And I think the most important thing is that they significantly contribute in reducing the stigma because they work with the community. So, I mean, these are some important things, some roles which NGOs can do in partnership with IIDVL, government, etc.
Yeah, so I think it's, in principle I understand. So Dr. Ashok Agarwal not only is presently heading NLR, but also he was the Indian National Coordinator of AIIMS for about 2 years back. Yes, Dr. Sujay wants to say something.
I just wanted to say that I'm very happy to state that NLR has reached out to IAL and that NLR would like to get IAL involved in the 5 states that they are working in North India.
Wonderful, wonderful.
And therefore we are trying to work together in those 5 states of North India as an organization.
Very good news. Very good news. Okay. So
if you allow me, just 30 seconds.
20 seconds. I think it's just done. Yeah.
So Dr. Sujay mentioned about a collaboration. We have made this brochure in collaboration, which talks about how AL can support PEP. So I'm not reading it because it's going to take time, madam.
Yeah. Ma'am, any last word from Ma'am Lily, ma'am?
Yes, ILAB as an NGO partner, they have been supporting LEP in every way. Like they have been involved in monitoring and supervisions also, then RCS also, many areas. So we welcome the organizations working in the field of leprosy.
Yeah, absolutely, ma'am. So thank you very much, all of you, and it's a very wonderful, very fruitful discussion, I hope, for all the listeners. And now the time is up. So we just had a brief discussion wherein all the members, all the panelists have agreed that there is a need to have a dialogue wherein we can have inclusion of dermatologists and other leprosy private practitioners who are working in leprosy to be working in hand with ILEP. And of course, there are methods are being worked out, how they can do. And very happy Dr. Ma'am, Lily Ma'am has said that CLD is trying to rope in IIDVL and IAL. How to do it, probably the plans will worked out. Very happy that Dr. Ashok ji has mentioned that ILEP and its partners, our NGOs, will use the services of dermatologists better in future. While already they are doing it, probably they will improve how they work. And also thank Dr. Sunil Dograji and Dr. Pai for their inputs. Thank you very much for this wonderful opportunity. I thank the organizers and my panelists. Thank you very much.
Thank you, sir, and respected panelists for that insightful discussion. We now move to one of the most anticipated sessions of Lepcon 2026, the debate session. I now request our esteemed chairperson, Dr. Timir Mehta sir, consultant dermatologist at Sahyog Kushti Yagna Trust, Gujarat, Dr. Birendra Kumar Singh sir, Dr. Punkesh Kumar sir, consultant dermatologist at Patna and treasurer of Lepcon 2026, to kindly take their seat on the dais. We are also privileged to have our esteemed judges, Dr. Vithal Jadhav sir and Dr. Sunil Dogra sir, Professor, Department of Dermatology, PGI Chandigarh, to guide and evaluate the session.
I request Dr. Santosh Rathore sir and Dr. Rakhi Gupta to kindly chair the session. And Dr. Timir Mehta sir.
So without further time delay, I would like to invite Dr. Vittal Jadhav and Dr. Sunil Dokra sir, who would be the judges for the debate. Yeah, please you can come, sir. For the first debate, we would invite Dr. T. Ravindran, and the debate is on, are leprosy campaigns sufficient approach for active case finding for hidden case load? Do we need to do more? Dr. T. Ravindran.
And the debate, Dr. Ravindran versus Dr. Satyaki Ganguly, and the debate time is 30 minutes. The topic, I repeat the topic, are leprosy campaigns sufficient approach for active case finding for hidden case load? Or should we do more in this?
So the actually structure of the debate was, the first presenter was going to make one presentation for the talk, for the topic that is given, and then the next presenter would present his viewpoint, and after that the judge would ask few questions about it and will summarize the debate.
Good afternoon to all. On behalf of our state leprosy officer, I am presenting that there is no presentation here. In dermatologists, private practitioners, and even from our NLP system and primary health care level, because of the name, the elimination. After that, for the 10 years, 2005 to 2015, CLD launched the leprosy case reduction campaign, which is a 14 days door-to-door physical screening of all individuals. The benefits of this are the most hard to reach area, tribal populations are completely covered. The rural area completely covered. In the urban area, all the vulnerable population, slum areas are covered. And also the migrant population is covered at their workplace, like construction site work or some bricklaying work, some on the industries. Especially to achieve the goal of elimination in 2027 to 2030, we have to reduce the child incidence of new cases. So, we are using the RBSK team also meticulously to screen all the school children in the government sector and unaided private sector also, to screen the children, which showed there is more than 30 to 40% increase in the new case detection in total. The LCDC accounts for nearly 36% of annual total new cases, which is a very huge margin in the recent decade. Only during the COVID, we didn't conduct the LCDC. After this, there is a gradual rise of LCDC, the new cases in LCDC. Especially, it is also used as a mass contact survey. for an index case or one retrospective contact tracing and contact tracing or the contact survey for a healthy contacts of an index case, we are using the LCDC. During this, there is also a widespread IEC is given that about that it is not due to the sin or something like that. We are reducing more stigma among the community, which is the reason for the hidden cases in the community. So LCDC is also a novel tool for a mass contact survey and is a mass IEC which reaches individually. In all other IEC, there is a target population, some are attentive or some are not attentive. But here, the field level workers are going to their houses and explaining and asking for the symptoms, 20 symptoms of the leprosy to the individual family members. That is a widespread IEC, which is a very, very novel approach here. For this IEC, after this IEC, the stigma is very much reduced, and as it is conducted every year, they are casual about it and they are voluntarily coming forward for the examination and the treatment. So there is a reduction in the stigma. Also, initially we detected more grade 2 deformity cases in the initial periods of LCDC. Now it's gradually decreased. So prevention of grade 2 deformity also, it is very essential. Prevention of pediatric case also, it is very essential for the LCDC. And the early detection. Now we are moving reversely, because in the initial stages we are seeing more cases of MB and grade 2 deformity. Now we are seeing more cases of PB cases. Nearly 53% of total PB cases are detected especially by the LCDC. So without LCDC, we won't detect PB. All are hidden, all are late reported to the passive clinic, passive surveillance. So it is very important for the early detection and more PB case detection, which was thought it's an imaginary or it's a dream. For every leprologist, detection at a PB level is a dream. To achieve that dream, LCDC is very vital. Thank you.
You said house-to-house surveys. So do you think a house-to-house survey for a limited period will be good, or throughout the year like previously the leprosy technicians were doing will be better?
We are selecting some particular dates, sir. Especially in Tamil Nadu, we are selecting post-Independence Day, 14 days from the post-Independence Day. We are doing door-to-door survey, which is very comfortable for that climate also. And we start at the 6:30 a.m. till 10:30 a.m. we are doing door-to-door survey, sir.
Because last month, two months back, in Maharashtra, in Pune district, they did house-to-house surveys and all. In 2 months' time, 7,000 new cases have been detected. So, is this going to be, it has to be a continuous process, that's what I think. If you want to detect the cases early and prevent the deformity rate. So like previous leprosy program was there, do you think it should be done in similar way?
It should be continued for further, sir.
Pardon?
It should be continued.
It has to be continued.
It has to be continued in further years.
Yes.
Now we are extending the criteria. Previously CLD gives the criteria. LCDC should be conducted in grade 2 deformity areas in the last year. From this year, we extended the coverage to the grade 1 deformity cases detected in the last year. So those blacks, those rural population with 1 lakh population having 2 to 3 cases in the previous 5 or 6 years have detected more than 10 cases during this 14 days LCDC, sir. It is also a very good information.
Yes.
Thank you, Dr. Ravindran. You can have a seat on the stage. And we invite Dr. Satyaki Ganguly, Professor Head at the Department of Dermatology, AIIMS Raipur. He will be giving his viewpoint that we need to do more.
Good afternoon, respected judges and chairpersons. So,
at the onset, I'd like to thank IAL and the organizers for giving me this opportunity. So today, the debate is, are leprosy campaigns sufficient approach for active case finding for hidden case load? Do we need to do more? So I'll be speaking against the motion. I have no conflicts of interest. So if we carry out anything, any purposeful activity, there are three main aspects we should consider. What is being done? Are we even trying to do the right thing? Second is, how well is it being done? Our planning may be fine, but the execution may be flawed. And third thing is, what is the effect? The effect will give us an indirect idea about whether the planning and the execution have some, is it being done properly? So I'll just analyze the LCDC campaign in these three headings. So what is being done? Leprosy LCDC campaigns, door-to-door surveys, especially in high endemic areas, focus leprosy campaign, special plan for hard to reach areas and high risk population, healthy contact examination of newly detected cases, retrospective contact tracing and examination of new cases detected. So an absolute ASHA based surveillance for low endemic areas. I'll come to the ASHA worker later. So LCDC is basically one ASHA worker and one field worker is tasked to cover the whole population of an endemic district. At that time, and according to the NLEP guidelines, no house should be left unvisited. That is, around that time it was 124 out of the 708 districts in India. So basically, it is like 1/6 of the Indian districts. This is the magnitude of the workload. The average population of a district is 17 to 19 lakhs. This is average. There are districts with 35 lakhs population. And I am not even talking about districts where the total population may be less, but it is difficult to reach because of geographical terrain and all that. So this gives us an idea about how difficult it is to be carried out as the way it has been proposed. This is just a map showing, this shows two things, the red and the yellow ones are the endemic district. This shows, number one, it is not uniform. And this also shows that most of central and part of the western India has high endemicity. Only at the tips, that is at the southern tip, Tamil Nadu, Dr. Ravindran is from Tamil Nadu, and the northern and the Gujarat, they are northeast are comparatively lower. So this again shows that we have a huge volume of work at our hand if we want to carry this out. So who is carrying it out? According to NRHM guidelines, ASHA should be an honorary volunteer. They are on incentives, not salary. Not received any salary, and her work would not interfere with her normal livelihood. The prescribed educational standard is 10 standard, but often it is relaxed and made 8. The workload should be, supposed to be, just 2 to 3 hours, 4 days a week, along with extra events. So basically their work is just a supplement to her main livelihood. Now, there are close to 35 national programs approximately which gets carried out through an ASHA worker. Most ASHA workers are working between 25 to 28 hours a week and even beyond that. To multitasking beyond a limit, it just will decrease the quality of the work done. So this, we are asking them to achieve something nearly impossible. How well is it being done? There's a good study by Lepra, the NGO, in Munger, Bihar. I'll quote that little in detail. Munger is an endemic district. 9 blocks, population around 13 lakhs, 72% of the population is rural. So they carried out this, we can see here, this is the publication. They carried it out by 3 ways. Contact survey for all index cases, then focal survey for all MB and child PB cases. For contact survey, they screened the household contacts. For focal survey, they went beyond and checked 20 to 25 houses around that, and that they did for all MB cases and child PB. So basically, they just excluded adult PB cases who are non-infectious supposedly. And a special search in this case for scheduled tribes by 3 trained paramedics. Please note, just 3 trained paramedics. They managed to cover 85,000 total population by contact, focal and special search, everything combined. They discovered 321 new leprosy cases. This is the lepra study. So if we take the population screen, that is 37.5% prevalence, and if we take the whole population of Munger, which they did not screen, still it will come at 2.4. An alarming 37% of the new cases were found to be child cases, which we all know indicates high transmission. The same time, the national percentage was 9 and 14.2 for Bihar, and even for Munger it was 16.3, the official statistics, but this is more than twice of that. The LCDC was also carried out in Munger because it's a high endemic area. They found 102 new leprosy cases. There for the lepra campaign 321, here they found 102. They covered 84% of the population, that is 8 lakh population. Whereas in the lepra study they covered just 85,000, that's all. So, and they had, LCDC campaign had identified 780 suspected patients of leprosy. So basically if we compare, that is 1 per 10,000 in the official LCDC campaign screen, that is, and 37.5, that is approximately 40 per 10,000 in the lepra study, in spite of screening almost 10% of what is the official LCDC campaign. 3 times more cases, 321 and this is 102. In LCDC further, only 102 of the 780 suspected cases were confirmed, whereas for lepra study, all suspected cases were confirmed. So this shows the difference in the training. So training matters. How well is it being done? We all know, Dr. Gite is not here, but he had sent a letter in last year, in July. So that letter said that there is a special monitoring framework. Today morning also we had spoken about that. This is for, now it is 121, high priority district across based on the prevalence at that time. So joint supervisory and monitoring visits by designated officers have been recommended to identify gaps in program implementation. So we all know that there are gaps. It is not, all is not well. To support the formation and operation of district leprosy task forces. So this is being needed. That means the existing mechanism is not enough. What is the effect? Apparently prevalence rate is fine, but the NCDR is still 7, the percentage of child cases is still 4, this as per the official statistics, and we know that it can be an underestimate. I just showed you. Now very interestingly, the latest data which I could get for 2024-25, 27,000 new cases were, all over India this is, were found out by the LCDC campaign, and at the same time there were around 1 lakh new cases. So if we tally these two data, it becomes like 1 in 5 new cases are being identified approximately by the LCDC campaign. So if we take the data opposite way, every 4 out of 5 new leprosy patients are still presenting by themselves to a healthcare area, which we know for leprosy happens always late, and that means till they are discovered, they are transmitting the disease. So what should be done? Dedicated, well-trained personnel. There is no, any system is dependent upon the people who carry it out. Training is very, very important. Geo-mapping of cases to allot resources. Ours is a poor country, we cannot have everything. So to aim for every house, probably we are not taking half of the houses. So geo-mapping, technology can help. Prudent reallocation of resources. As the map showed, it is not uniform everywhere. So we can take away resource from where it is not needed and put resource where it is needed. Contact survey, focal survey, special search, which the lepra study had done. It showed much more yield. So therefore it can be followed. These are my references. Thank you.
Thank you, Dr. Ganguly. I can add to the what should be done, that all suspected cases should be confirmed by specialist, right? And but indirectly, it also suggests that campaigns do help to identify the cases in the community who may not self-report, right?
That's
so,
true,
but
sir.
otherwise,
Actually,
very critically
definitely
presented. Thank you for that. Yes,
you,
you want to say something?
Yes, I was saying, like, there are areas where it is being done properly. So
Yes.
anything has to be done properly, as Dr. Ravindran showed.
Yes.
The success in Tamil Nadu is not being replicated everywhere else. That is our crux of the problem, I guess.
I agree. So quality has to be ensured in all the activity what we do.
Do you think integrating this leprosy in the general health services was a mistake? Because if this is the case, then Might be because of the integration. Is this happening?
Partly,
Two
yes,
different
sir.
views and
Partly, sir. My views are, sir, the some amount of expertise has definitely been lost. When we had specialized workers, the expertise was much more and it has become mixed up, and the ASHA workers, this is not their priority work. They have other priority work where the incentive is more. So this is not being prioritized. True. Absolutely true.
Thank you, Dr. Ganguly. Our next debate, which was on FDT for all versus individualized FDT. The FDT for all section was to be covered by Dr. V. Santaram, but unfortunately he could not come. So Dr. Tarun Naran, who was going to be debating for individualized MDT, he has been kind enough to do both the parts and summarize that for all of us.
Thank you, Dr. Santosh. And it will be difficult for me to speak for FDT because, I mean, for the last 15, 20 years, I have been saying the otherwise. And I think since morning we have been listening to talks. We've been listening to Dr. Sen Gupta. I think if we can replay that talk, that would be enough for mine as well. We could save time and we can go to the next session. So I'll ask you, how many of you feel that 12-month MDT is enough for all patients of leprosy? By raise of hands. So do we still need this debate? Anyway, these were the cases that I saw last week in our leprosy clinic. With LCDC going on and so many efforts, I am still getting these cases. One of these is a person who is from UP. He was working in UAE. He must have been having some lesions, didn't get medical care there. Then he came to us in this state. Another one says that his nose kind of collapsed because he fell down after having alcohol. So people have their own reasons for not coming. Awareness, I don't know how much awareness is there. So these are the type of cases. And the third one, the one with the lesions on the thigh, if you see, I don't know whether you can appreciate those are histoid leprosy lesions. This gentleman came to me for his child. He didn't know anything about his disease. It was just that we examined him and we found that he also has leprosy. And these are some more cases. These were sent by my friend from Gorakhpur. He sees these cases every day. So this is the situation. And this was the child I was talking about. This child was also smear positive. Then we come to the issue of FDT or fixed duration treatment for 12 months. This is another case which I saw last week only. 32 years old male, MB leprosy, initial BI 5+, completed MDT, uneventful course. He was doing fine, but even at 1 year, he had persistent and active erythematous nodules and plaques, as you can appreciate in this photograph, I think. His BI is still 4+, okay, if you go by the response that is normally expected, 1 log fall is very good. But he has progressive nerve function impairment also. So what do we do in this case? We think that 1 year was enough, 1 log fall has occurred, now the body's immunity will take care of the rest of the bacilli and the nerve function impairment can be treated with steroids. That should do it. Never. Yes. So this is what I was saying, that we assume that the host's immunity will take over. But in patients who are lepromatous leprosy, who are energetic, how do we expect MDT to upregulate the immunity? I am not aware of any studies where this aspect has been studied, like whether giving MDT upregulates the cell-mediated immunity in patients with leprosy. If that is not occurring, then we need to take care of these remaining bacilli. Otherwise, we will have relapses, we will have reinfections, we will have reactions as well. And this is the reality. So this was a study that Dr. Sen Gupta was also talking about, that they studied the biopsies in patients who were on MDT at 6 months and at 12 months, and they did a viable bacillary load of these patients. And about 66% of the patients had viable bacilli in their skin. So how can you stop treatment when the patient still has viable bacilli in the skin? I think there is a study being presented today by one of your students who shows that even nasal swab has viable bacilli after rifampicin. So they are still transmitting. If you don't want to accept that skin lesions, but then even in the nose there are viable bacilli. So do you think it is wise to stop treatment in a patient who has viable bacilli? No. This is a study that we did at our center. We also found that about 50% of the patients had viable bacilli at the end of 1 year. And a few of these patients had received alternate leprosy treatment, that is minocycline, ofloxacin and clofazimine. So even after giving this treatment for 1 year and after ensuring adherence to treatment or compliance to treatment, we are seeing viable bacilli. Yes. So let's say this is a study from Brazil. This is a big study. About 131 patients were studied, recently published, and they evaluated these patients after 24 months of MDT, clinically, bacteriologically and histopathologically. And they did mouse foot pad inoculations in these patients. So they found that viable bacteria were found in 64% of mouse inoculations. So if you don't believe in molecular methods or say that they are not so correct, they may be overestimating the problem. Mouse foot pad is something which is the gold standard. So 64% of the patients where they inoculated the samples had viable bacilli, and another problem that they saw was there was a clinical and bacteriological dissociation. Most of these patients were clinically better, but it was only with a SSIS or a histopathology or a mouse foot pad they found out that the response was not that good. So if I don't have these facilities with me, I am just looking at the clinical aspect, then I'll say, yes, the patient has improved very well. Let's stop the treatment. But then they also saw other things, like 87% had ongoing or worsening nerve issues. Well, nerve function impairment is a cardinal sign of leprosy. So we have not treated that. That is worsening. And the disability also rose from 5% to 23%. And that, mind you, this is after 24 months of MDT. So this is the situation that we want to interrupt the transmission, and we are not treating our reservoirs correctly. How do we manage this? By just giving single dose rifampicin? Will that be enough if the source is still there in the family? Will SDR prevent it afterwards also? So one of the things is, if you have chemoprophylaxis or immunoprophylaxis, the case has to be treated adequately. If the source is there, you can't do much about the transmission. Then there are many studies which have compared the relapse rates. We all know that the relapse rate is inversely proportional to the duration of treatment. That is, shorter the duration of treatment, higher is the relapse rate. There are many studies which have shown that. And we have this low relapse illusion that MDT is very good. The relapse rates are just 1 to 2%. When we are not following up the patients, we don't know what is happening to the patient after release from treatment. So how do we know what is the actual relapse rate? So this is the human cost. Dr. Rao, PSS Rao had I was really impressed by his talk. The human cost is very important. This aspect has to be looked into. After 12 months, the patient continues to have recurrent ENL, has nerve function impairment, has worsening of disability. So how does he think that I've been cured of my disease? This is another patient that I saw, that another approach, you stop the treatment after 1 year. This is what happened to this lady. She was doing fine till 1 year. MDT was stopped at 1 year. She started developing reactions. SSS is not available at most of the centers, so it was not done. She pleaded to the doctor. I was all right. I was doing fine as long as I was on MDT. Restart it. He said, no, we can't do it. We can't give it more than 1 year. She was on steroids, that didn't control it. She was shifted to thalidomide, then methotrexate. She got all those together, but she still had ENL. But she was not given MDT or any other treatment, or resistance testing was not done. Slit skin smear was also not done. So is this the approach that we want, FDT? And now she has all these problems. She has Cushing's, she has osteoporosis, she has glaucoma, diabetes, and she has suicidal ideation. A young female. This is another patient. MDT till 1 year, then no treatment, just treatment of reactions. She even received TNF alpha blockers. And now again she is in the same situation. She started, these patients then, they know that steroids is the only thing being given to they start taking it themselves. Self-medication. They have the problems with that. We have lost 2 patients because of that. Well, if you go by evidence, then this is a network meta-analysis of 70 years efficacy and safety of drugs for treating leprosy. Conclusions are MDT is the cornerstone for programmatic control, but. So what are we talking about? Programmatic control or cure of the patient? MDT is effective but may not be enough in all cases. I am not saying MDT doesn't work. It does work in cases with PB, with people who are like the smear positivity is less. They said that fluoroquinolones improve efficacy when added to MDT. Adjunct regimes, they also work. Immunotherapy, they did mention that immunotherapy is a good option. And they did say that need for personalized regimens in high BI cases and recurrent reaction states. So even a network meta-analysis recognizes this, that this is a separate subset which requires personalized treatment. But the problem is that now we are seeing resistance to fluoroquinolones as well. So this is the biggest problem that we are facing. And we know that drug resistance will increase in these cases because drug resistance increases with the increase in population of bacilli, or the bacillary load is directly proportional to the chances of developing drug resistance. Many studies have shown that. And we did see in Dr. Sen Gupta's slides as well that the drug resistance is not coming down. The graph is climbing. So what do we do about that? Detect earlier and monitor safer. We have many good studies which talk about diagnosis of leprosy, early diagnosis. But what about monitoring the treatment of leprosy? I have diagnosed, if I am still going to give FDT, then okay, no need of monitoring. But I need tools by which I can monitor. How many viable bacilli is there? What is the total bacterial load? So monitoring is always very important. Point of care diagnostics, post-MDT surveillance for high-risk cases, and AMR surveillance, very important. So we have to basically tailor the treatment. Like we see that in Japanese guidelines, they do have a subset of patients where they see the SSS after 1 year, after 2 years. And if the SSS is more than 3 or more than 4, MDT is given. But now we have facilities for drug resistance as well. We can do that as well. So we have to individualize. If a patient has low bacillary load, then okay, standard FTT, good enough. If the patient has high BI, I won't even say 4+, I would say 3+. Then you have to give an enhanced regimen. And the lowest hanging fruit is the immunotherapy that we've been using since, I think I did my PG in that about 20 years back. That time I was thinking that why did sir give me this topic? Leprosy is going to be eliminated in 5 years and he wants me to study a vaccine in leprosy where the treatment is so good. So ever since then it has stuck with me that this is something which really works, but we still are not using it properly. This is something which could have been implemented, and you could keep the duration same, like we have seen results. Another option is BCG. If you don't have access to MIP, if you find MIP difficult to procure, then you can use BCG. I won't go into too much details, I might be boring you a bit, same thing. But yes, MIP is a very versatile vaccine. We published this scoping review last year and we see that it can be used in prevention of lepra reactions. There is a study being presented in another hall today itself, I think. Treatment of recalcitrant reactions, besides being used as an immunotherapy in cases with high BI and in LPEP. We are saying that drugs don't have memory, but vaccines have immune memory. So why don't you combine it or give vaccine? There was a study, I don't know whether the results of that are available or not. There was a study initiated by ICMR about MIP being given in contacts of cases of leprosy. It was in Bihar and Gujarat, I think. I'm not sure, I couldn't find the results of that study published. But that is a good option. We all know vaccines prevent diseases. Drugs can't, especially a disease like leprosy, which has a long incubation period. So how can you tell me in 1 year what is the efficacy? The incubation period is 10 years. The cases will come after 10 years. So tell me how much effective is a vaccine after 10 years. Then there are a number of options that we can do. There are a few studies on these as well which have shown that if you use better drugs, bactericidal drugs, along with the drugs like dapsone and clofazimine, they can be helpful. You don't want to prolong the therapy, I know. It is very difficult to say the patient that you have to take the treatment, say, for till smear negativity, but we don't talk about these things when we are talking about HIV, right? Do we tell them that you have to take only for 5 years, even though there the viral load is 0 or undetectable? We don't stop ART because we know that the virus can reactivate. We've seen this in leprosy as well. We have persisters which can't be killed. So why can't we prolong the treatment or give something that does take care of the persisters or the immunity? We are discriminating against leprosy, isn't it? Even in treatment. So there is PMM regime, then there is daily rifampicin as well. Then there are a few new drugs, the EETC, electron transport chain inhibitors like bedaquiline, telacibec, which have shown wonderful results. You don't want to give therapy for a longer period, incorporate these into the regimes, or at least give it to patients who are not responding adequately to the treatment. We change it all the time. We don't always wait for seeing resistance in other infections. We change the drugs. Why do we want to confirm and show that this, if the patient is not responding after 12 months, 24 months, how long can you give the same drugs? All the resistant mutations are not picked up by the tests available at the moment. There are wild type of mutations which we don't know the significance of. So we should have good drugs before we have resistance to these as well. Combination has shown wonderful results, and I think, yes, this paper was published in ICMR bulletin quite some time back. It was in 2002, and it says a question on ethics is also important. There is a need to take moral concerns of individual patients vis-a-vis community, right, into account, and balance must be achieved between the cure of the patient and protection of the society at risk. So far we are keeping society, I don't know whether we are protecting society also or not. This means that where feasible, treatment till cure of the individual should be ensured, and such individual should receive help, respect and compassion from the society both during and after therapy. Are we doing that? Then finally, for MB patients, is the present therapy for 24 months adequate? That was 24 months. Now we are giving it for 12 months. Remains the question. The answer depends upon as to what is the purpose of treatment. This is very important. If it is to cut down the transmission of disease, as is the need of the program, then the answer could be yes. But have we been able to cut down the transmission? So the answer here is also no. You don't treat the index case adequately, how can you cut down the transmission? So we have to adopt prolonged treatment or better treatment for patients who have a high bacillary load, integrate immunotherapy to reduce disability also, and to enhance immune clearance, monitor using modern molecular diagnostics, move from calendar dates to objective cure measures. 12 months is not equivalent to cure, or even 24 months for that matter. This was one of our papers that we published in IJDVL. These are the points that I have been harping on for the last 20 minutes, I think. Thank you. Thank you.
Thank you, Dr. Tarun Narang. That was excellent and very thought-provoking talk by you. And I think good for your opponent that he did not come today. Since I also have same school of thought, so I'll request Dr. Jadhav to ask you any question in case he has.
No. How many of highly infectious patients we treat? And how much follow-up should be there? Because individually, see, all, as Dr. Dogra and Dr. Narsera have previously said, that 40% of the leprosy patients are treated by dermatologists. But everybody is using his own technique. I mean, 1 month, 1 year, 2 years, 3 years, 4 years. So what is the end? You said till the cure. What is the cure point?
That is what I am saying, that sir, we have to first start doing the slit skin smear. Bacillary load तो पता होना चाहिए. Cure तो बाद में देखेंगे.
Because अभी सब लोग देते हैं, ये इसको ये दिया, उसको दिया, कोई publish नहीं करता है. So everybody is individualizing the treatment.
Yes.
That doesn't mean FDT is wrong.
No, I am not saying.
I mean, in the sense, whatever is benefits of FDT are already there.
Yes, they are.
So
sir.
whatever we dermatologists are doing, we should gather the data, publish it, compare it. Then we can have our say.
Yeah, we are publishing it, sir, but कुछ हो तो नहीं रहा वो FDT वो तो 6 महीने का भी कर रहे थे सर.
15, 20, 30, 130 केसेस से कुछ नहीं होता ना सर.
नहीं सर, 2005 से पब्लिश कर रहे हैं सर. काफ़ी स्टडीज़ हैं, मैं तो अभी ढूंढी भी नहीं सारी हैं. बट वही चीज़ है ना, ऑपरेशनल ईज भी है, वो मुझे नहीं पता सर. मैं एपिडेमियोलॉजिस्ट नहीं हूँ, आई एम अ क्लिनिशियन. मेरे सामने मरीज बैठा है, वो कह रहा है जी आपने तो 1 साल में कहा था मैं ठीक हो जाऊंगा, मुझे तो 5 साल हो गए.
The problem will always be there. Yes. After FDT or UMDT we did, at the end of the thing, the patches are there. Naturally, the patient is going to ask, how can you say I'm cured? But how many of them you have followed? We are following and we are seeing that the patches are going.
We have follow-up of 10 years,
with the addition of clofazamine for PB, definitely the patches are going within 6 months of time. That much I can assure you.
No, I
so
think,
you have
sir,
to follow them like that.
We are, sir. We are. At least at our institute, we are. That is why we have come up with this data. We are following up these patients till smear negativity also. And now we are seeing relapses. Patients whom I treated when I was a JR, now they are coming back to me with relapses.
We are talking about the persisters. What is the guarantee that your 4 years or 5 years treatment period will stop the persisters?
Yes. So that is why immunotherapy is important, sir.
So immunotherapy, yes.
Yes.
I have tried MW vaccine in 40 patients.
Yes.
Afterwards, unfortunately, it was not made available. Now MIP is there. But results were quite good in recurrent ENL.
Yes, that helps a lot.
ENL, their results were very good. But they were not to that extent in BI more than 2 or 3
No,
months.
as a matter of fact, we recently did a thesis, sir, where we did the viable bacillary counts pre and post treatment. And we saw that significant number of patients who were on BCG and MIP had very low or undetectable viable bacillary count after 1 year of treatment plus 2 doses of MIP or BCG.
Okay.
So it does help there as well, sir.
Immunotherapy will definitely help.
Yes.
I am sure about it. Yes,
Yes.
yes. Thank you.
Thank you very much, Dr. Tarun.
Thank you, sir.
Thank you very much, Dr. Dogra sir, Dr. Jadhav sir. Yeah.
Always the last say.
Thank you. Very interesting. Karan, everybody understands what you are saying, and probably we do not have the answer to all what you have raised. There is one extreme, like Vittal was saying, and there is a published study in Leprosy Review where they have found that after 10 years, every patient heals.
Every patient?
Heals.
Heals.
Yeah,
Okay.
you have 4+ at the time of RFT and
Okay.
It's a study published and 9 years or probably 9 years. 9 years every patient heals. Issue is, do we wait for 9 years and wait for the complications to occur? Do we wait for 9 more years for the person to go on spreading the disease? It is not only a study which we are talking as an academician, that yes, 1 year of treatment is sufficient and we have followed patients for 10 years and they all heal. Perfect. But what happens in all these 10 years to the society, to the patient is another issue. Yeah, it is a problem, yes.
Yes.
We do not have the clear-cut answers to all this. But do you think there is something in between 10 years and whatever you are suggesting that we should give more drugs, more, or whatever?
No, immunotherapy, as I said.
Yeah, that is that.
Or you have drugs like now bedaquiline, they say it acts against persistence as well.
Yeah. So
And even once in a month dose gives you good enough drug levels.
Sure. But unfortunately, we still do not have enough material on that. That is one. And just one point, probably it relates to what you said about SDR. Everybody knows that one dose doesn't do. Brazil has not accepted it. The people's trial doesn't support it, or many more things. But I have only one point to make. The number required to treat to prevent one case of leprosy occurring in the society and the cost involved. When the study was published about the collapse study, then probably the cost for one patient was about $258 exactly, or $260. And now the cost will come to more than $2,000 or maybe more, maybe even more than that. Do we really afford that? Can we afford that, or should we go in for better ways of LCDC or some other kind of a screening? So I think I have expressed my issues on that. More fun.
Thank you, sir. Narad, I agreed with you partially. 1983, when I was in CL trial, we are doing the maximum regimen study, WHO maximum regimen study. Delhi continue dapsone, rifamycin and clofazimine till bacteriological negativity. Many of our BLLL cases, I still remember, it took about 5 to 6 years to become bacteriological negative. After they become bacterial negative, we did the mouth purpura inoculation study in nude mice. And even after that, in 10% cases, we will find live bacilli. So the problem is, live bacilli will be there. Persistence will be always there.
Yes.
So what now are doing?
Sir, can I interrupt you, sir? Sir, yeah. Okay. Sir, sir, 1 minute more, please, sir.
Yeah. So, what we are doing now after 24 months, if there will be BIE will remain there, because in 1 year there will be reduction of BIE by 1.5 to 1 log.
Yeah, yes.
So we have to see that the drugs, gradually BIE is falling down.
Yes.
But as you told correctly, some cases develop ENL reaction at the end of 1 year. In those cases, what we are giving, the study we have published in the next hall. I just told the same thing in the next hall, because what we are doing that after 12 months, if still any reaction occurs, what to give, we give immunotherapy, MIP vaccine, along with, for live bacilli, monthly pulse 3 bactericidal drugs. That trial is going on. MCC and RCM and RMM, we are giving those cases and getting very good result.
Yes.
You continue pulse dose, 3 bactericidal drugs along with immunotherapy, and you can reduce the prednisolone dose, you can reduce the thalidomide dose very quickly. Very quickly. So that probably we should do in limited cases. But as Bhushan Kumar rightly suggested in a program, in public health program, we cannot individualize. So those cases, those come to us, we can individualize the therapy and give the regimens along with the immunotherapy to really control the ENL reaction. Exactly.
Thank you, sir. We have to close because we are running 1 hour late.
Only one of my patient, 30 years after the treatment, MDT given, he has developed the sensory loss, new sensory loss last year only.
Thank you.
30 years after the treatment.
Thank you. Thank you. Thank you everyone for your participation. Thank you.
Thank you, sir, for that thought-provoking session. I request you to kindly collect your memento. We now proceed with the next scientific session, that is reviewing progress in clinical leprosy and diagnosis. We would like to invite our esteemed chairpersons, Dr. R.P. Singh sir, Dr. S.K. Tripathi sir, and Dr. P.C. Das sir, to kindly take their seat on the dais.
So I welcome Dr. Swatilana Pradhan, Associate Professor and HOD, DVL AIIMS Patna. So it is her area and the details are there. And after such a long debate, I welcome you for your presentation, please.
Good afternoon, everyone. So I'll be speaking on antimicrobial resistance in leprosy, posing management challenges to the clinicians. So I'll be speaking on the various case-based scenarios. So there has been a lot of discussion about the current status of leprosy, what is the prevalence rate now since morning. So being a clinician, our focus to manage leprosy is the only option available with us is the WHO MDT. And among these three drugs, rifampicin is the only which is highly bactericidal. Dapsone, we all know it is bacteriostatic. And clofazimine is slowly bactericidal drug. So AMR, that is primary drug resistance, is of two types. That is primary resistance, when the naive case is resistant to the drug. And the outcome of this primary resistance leads to treatment failure, increased transmission, and it threatens the control strategy of the government to eliminate leprosy. So secondary drug resistance develops because of inadequate treatment And because of various gene mutations, you know the genes for rifampicin is RPO, FOLP and GYRA gene for fluoroquinones. So causes because of poor treatment adherence, prolonged monotherapy and indiscriminate antibiotic use for quinonols, like over-the-counter use of antibiotics for GI infections. So all these type of primary and secondary resistance causes treatment failure, continued transmission of the disease in the community, and the second line therapy which are available, so they are more complex and expensive regimens, and hence surveillance, drug resistance surveillance is a need of the hour. So I will show a few of my cases. There are a lot of cases, but because of time constraint, only few cases why there is a threat to the now treatment challenges because of drug resistance. So there are the first study which was carried out by WHO from various countries regarding the drug resistance prevalence among these various countries. So coming to my cases, first case, we had a 27-year-old male who was diagnosed as leprosy with type 2 lepra reaction and grade 2 disability without neuritis. Patient was MDT MB adult since 2 years. So he presented to us with 10 to 12 episodes of both nodular and bullous CNL since 2 years. There is ulnar clawing of left hand, hypoesthesia of bilateral hand and feet, and on and off pedal edema. So as I said, already 2 years MDT was completed, various dose of prednisolone 50 to 10 milligram over 2 years for ENL. So examination findings suggestive of Ellen Hansen's. So we did a slit skin smear, it came negative. So then because of recalcitrant ENL, 2 years MDT already completed, we sent a drug resistance tissue for drug resistance testing, and it was found, the report was resistance to dapsone and ofloxacin. But however, the patient was sensitive to rifampicin. So patient had already taken one at least bactericidal drug for 2 years, but patient was still getting ENL. So then we started that clofazimine, minocycline and clarithromycin regimen. We gave BCG, and then the patient was continued tapering dose of prednisolone up to 5 milligram along with thalidomide. So patient was off steroid for within 4 months, and along with this CMC, clofazimine, minocycline, clarithromycin regimen. So now the repeat slit skin smear was still negative. So in this case, if there is a discussion, the BI is coming down, but this patient was having slit skin smear negative from the starting, but the bacteria was this one in the drug resistance, we could find the bacteria having a drug resistance to dapsone and ofloxacin. Second case, 16-year-old girl diagnosed with leprosy, presented with recurrent ENL since 9 months, and baseline slit skin smear patient was having 6+. Patient completed previously 1 year of MDT child pack, then again 1 year of MDT adult pack. Patient presented to us with ENL. So we did a slit skin smear, baseline 3+, MI was 10%. That is patient completed 2 years MDT. After that, this was the finding. So we started on this CMC regimen again because of in view of MI, live bacilli and BI still 3+. So tissue was sent for drug resistance testing. So we treated ENL steroid, and because she was a young girl, so she didn't give consent for thalidomide, parents. So we gave up tofacitinib. So because tofacitinib 5 milligram BD, however, she developed transaminitis with tofacitinib, hence we withheld it. So patient still had a ENL, severe periosteal pain, and we did this one suggestive of periostitis. So by that time, drug resistance report was available. It was resistance to ofloxacin, sensitive to rifampicin and dapsone. Because of severe pain in the tibia and ENL, and there was no transaminitis to tofacitinib, the parents didn't give consent for thalidomide, we give her infliximab. And with infliximab, there was an improvement in ENL. Also, we regularly give BCG to our patients, and patient was kept on physiological dose, prednisolone 7.5 milligram. She is on 3 months. So after that, there was improvement, no new ENL lesions, periosteal plane improved with infliximab, and slit skin smear, no AB seen after 9 months of alternate this CMC regimen. So this is a follow-up photograph of the patient. Third case, 37-year-old male, leprosy with grade 2 disability, without neuritis, without reaction. Patient was on MDT 1 year completed. presented to us with persistent skin color, asymptomatic papules, nodules over back and abdomen, hypoesthesia over the dorsum of the left foot, and on and off pedal edema. So there was an examination, there was multiple papules, plaque over abdomen, peripheral lobes were thickened, there was hypoesthesia. So this treatment history, patient completed 1 year MDT. Slit skin smear was this time 2+ with MIE showing 20% viable bacilli. So we continued NDT for this patient because 1 year was given, but we sent for drug resistance testing the tissue. So the drug resistance report available were resistance to both rifampicin and dapsone, and only sensitive to ofloxacin. So we started on the CMC regimen, and the patient was followed up, observed for any reaction or other systemic complaints. So the response, the patient didn't have, the skin nodules and plaques began to fatten, no new lesions appeared, and patient didn't develop any reaction. Fourth case, 45-year-old man diagnosed with lepromatous leprosy with ENL, baseline slit skin smear 5+, admitted and started on MDT, MB adult, gave thalidomide and BCG injection. So however, after starting MDT, patient developed fall in deranged LFT and fall in oxygen saturation. There was a breathlessness, so we withheld both rifampicin and dapsone. Because of high bacilli load, cofazimine was continued. So we called the patient to come after follow-up after 1 month after the LFT improves. So we sent the drug resistance testing for this patient. So when the drug resistance testing came, it was resistance to rifampicin and dapsone, and sensitive to ofloxacin. So already we withheld because of deranged LFT and fall saturation. So both the drugs are resistant for the patient. So we started again to switch to CMC regimen. So now the patient is on follow-up on CMC regimen. Patient ENL is on the thalidomide 50 OD, no ENL and neuritis. Fifth case, 45-year-old male, RFT case of LL Hansen's disease presented to us with new onset nasal stuffiness, epistaxis, persistent loss of sensation over bilateral upper and lower limb, recurrent ENL for 12 months with last episode 15 days back. So there was previously patient took 2 years of MDT adult and was released from treatment in 2024. So examination finding there is bilateral earlobe infiltration, saddle nose deformity, ulnar clawing. So the diagnosis was LL Hansen with recurrent type 2 lepra reaction with grade 2 deformity. So patient was steroid dependent because of recurrent ENL. So minimum control dose of prednisolone was 50 mg. Below 15 he was having ENL. So did a slit skin smear, it was 1.5+, MI 30%, and this when he presented to us. So we sent a drug resistance, and both rifampicin and dapsone resistance came. And only sensitive was ofloxacin. So we started on the again CMC regimen, and patient was started because of ENL, steroid and BCG. And with this regimen, subsequently the ENL severity came down, so patient could be tapered over steroid on the 2 to 3 month period. So this is after the alternate MDT, currently she is on this CMC regimen. Sixth case, 52-year-old male, known case of BT Hansen with grade 2 disability without neuritis, completed 1 year of MB adult in 2020-21, presented to us with new area of loss of sensation over the distal half of bilateral lower limbs, medial aspect of right upper limb for 1.5 years. There is persistent hypopigmented patches over back with new area as per the patient, new patches over the back. So there was on and off pedal edema since 7 days. So examination finding, patient was previously BT when he came to us. There was bilateral earlobe infiltration, and there are 60 to 80% patchy hypoesthesia over dorsum of the bilateral feet extending to involve previously uninvolved areas. So we diagnosed the patient BT downgrading to borderline lepromatous Hansen disease with grade 2 deformity, no reaction or neuritis. So treatment history patient MB had already completed 1 year MDT, slit skin smear was 1.5 with 20% viable bacilli. So we shifted to CMC regimen, and we sent a drug resistance testing, and it was rifampicin and dapsone both resistant. So again already patient was on CMC regimen, so patient was continued on the same regimen, and he's on regular follow-up for observation without any for reaction or systemic complaints. So So I showed you variety of only 6 cases with different variety of presentation. So because we are thinking ki recalcitrant ELN, we are just switching the regimen to alternate therapy, all combination of bactericidal drugs, because we are not testing for the drug resistance. So we are also getting naive cases who are getting resistant to rifampicin and dapsone both. Recalcitrant Lepra reaction showing drug resistance. Some recalcitrant Lepra reaction even without resistance or not responding to MDT. So lots of ofloxacin resistance now we are getting because of over-the-counter use of this ofloxacin for GI infection. So because we are not testing for all drug resistance, hence no idea about alternate MDT or CMC, what about the other drugs, we don't have any idea. So rigorous drug resistance testing is in all cases, old and new cases should be done. Government should establish labs with this facility in all states, especially high endemic zones. As physician, we should come out with data of drug resistance from each zone to open the eyes of policymakers. So MDT is not enough for elimination of leprosy, I can say from my cases. So because these are the highly vacillated cases who require our attention. Thank you.
Thank you, Dr. Svetlana, for highlighting the drug resistance scenario in leprosy patients. Since the leprosy patient belongs to the same community where every other patient is there, and antibiotics of the fluoroquinolones and others are being prescribed right and left everywhere. So this is very relevant that drug testing patterns should be known right out the outset in at least nodal centers, such that once the treatment failure is recognized, then we go for a drug resistance pattern. That is a very difficult scenario. So thank you, Dr. Svetlana.
Thank you, sir.
Thank you. Now we call upon Dr. Swastika Survia for CNS involvement in leprosy. She is professor at King George Medical University, Lucknow, and honors and awards have got a big list, and publication articles more than 74, and presentation 42. I welcome you, Dr. Swastika, please. She will be speaking on CNS involvement in leprosy. Welcome, Dr. Swastika.
Thank you, chairpersons, for the kind introduction. And I'm Dr. Swastika. Thanks to the organizer for having me here. And thanks to Sujoy sir for giving me this much controversial topic. While many in the hall do not agree with this view of CNS involvement in leprosy, I'll still continue with my presentation. So M. leprae, we all know, and what has been classically taught to us involves the peripheral nerves. And what is debated, does M. leprae involve the central nervous system? And does it involve the nerve plexuses and ganglion? This was proposed long back by Ashmiat in 1898 based on his autopsy studies, but was refuted by Hansen's. But in today's era, we have MRI, magnetic resonance neuroimaging, and many individual case series, few prospective studies have reported abnormal neuroimaging, especially indicating involvement of these sites in leprosy. And evidence does suggest involvement of the proximal nerve plexus and the CNS. So MRI remains the modality of choice, unlike ultrasound, which is the one for peripheral nerves, because for imaging the brain, spinal cord, MRI is the modality of choice. The plexus you can do image with ultrasound as well as MRI, though MRI would be better. So what are the imaging features? These are the imaging features have been described based on previous studies. So the brachial or lumbar plexus, these are generally visualized on T2 or STIR as hyperintense, non-nodular, and less marked. The inflammation is less marked as compared to the chronic inflammatory demyelinating polyneuropathies. The spinal cord lesions are generally described as T2 hyperintense with or without contrast enhancement, and generally seen in the lower cervical cord. The lesions in the brain generally involve the brainstem, the pons or the medulla, as show you by some case scenarios. And these are generally focal. They show T2 or flare hyperintensity in the region of the cranial nerve nuclei. So the pathogenesis that is proposed for these CNS lesions, which are visualized on MRI, According to Phulwarisharif, it could be either direct infection by M. lepri, reactive gray matter changes secondary to proximal axonal transection, or immune-mediated inflammatory response. So what exactly is the pathogenesis? Maybe we can conclude it better by the end of this presentation. So these are some of the case scenarios that I have come across in my OPD. The first case relates to a 24-year-old male. He presented to us with left ulnar cloying and a small ulnar abscess, as you could see, for 6 months. What was interesting in this case was the biceps and triceps reflexes. They were increased. He had hyperreflexia, particularly on the left side. Our HRUSG showed the ulnar nerve thickening along with a hypoechoic area. You can see the dense black area that is there, marked with a red arrow. You can see that is the abscess, becomes entirely black. The other shows the sagittal section of the cord. It's a T2 weighted image. You can see a white signal there, again marked by a red arrow. The signal is extending from C3 to C7 level in this patient. So USG guided FNA was done, which showed epithelioid cell granulomas on a background of caseous necrosis. It was HE stain was done. A nerve conduction study in this patient showed left ulnar neuropathy. The slit skin smear was negative, and in all these cases, we also tried to do a PCR for M. lepri from the sural nerve, which was positive. A final diagnosis for this patient was borderline tuberculoid Hansen's disease with ulnar nerve abscess and probably cervical cord involvement, because we had ruled other chronic diseases like diabetes, hypertension, vasculitis. We had ruled it out, and then we had done the MRI with probable cervical cord involvement due to leprosy. The treatment protocol was the same. Patient was treated with MBMDT with oral steroids in a dose of 1 milligram per kg. And this is the repeat imaging that was done after the duration of 9 months. It showed minimal T2 hyperintensity. The intensity had declined after 9 months of MDT and oral steroids. This is the second case. It relates to a 29-year-old male. All my cases were MDT naive. They hadn't taken MDT earlier before visiting us. He had a positive Bell's phenomenon, you could see in the left eye. On the upper back as well as on the other parts of the body, there were multiple edematous lesions suggestive of T1R, which were present for around 24 months, which had become swollen recently according to the patient for last 2 months. Here also, a sagittal T2 weighted image showed a hyperintense signal at the level of C5 to C6. The coronal section shows this unilateral brachial plexitis. You can see these are more wide, the brachial plexus, the C5 and C6 nerve roots. It shows it's a bilateral brachial plexitis. The NCS again showed sensory motor polyneuropathy. The slit was negative, but PCR was positive. And a final diagnosis of BTHT with T1R with probable lower cervical cord involvement and bilateral brachial plexitis was made. And patient was again treated with MDT and oral steroids. In second case, a repeat MRI was done at the end of 1 year. The intensity remained the same. There wasn't much change. The case 3 relates again to a young male, 26-year-old male, you could see, had bilateral Bell's phenomenon for 4 months and deformity. See how intense the deformity was. He had claw hands and toes for 4 months. A sagittal T2 weighted image shows a long signal. The signal here was extending from C4 to C7 level in figure labeled as A. The coronal stir images again showed bilateral brachial plexitis, and in the panel C you can also see bilateral ganglionitis. This again showed by red arrows at the level of C8. Again, a nerve biopsy here was done. These were all ultrasound guided through-cut nerve biopsy that was done, which showed some foamy macrophages and lymphocytes. A weight-fight stain in the nerve again showed 0 to 1 bacilli per oil immersion field. A diagnosis of BLHD with deformities and probable lower cervical cord involvement, bilateral brachial plexitis and unilateral ganglionitis due to leprosy was made. Patient was again treated with MDT and oral steroids. The fourth case relates to a middle-aged male, 44-year-old male, you could see, presented with right-sided Bell's phenomenon. There's deviation of face towards the left side on clenching of teeth. Here also a sagittal T2 weighted MR cervical spine showed images. Here the signals were long. We labeled the signal as long when they were involving more than 3 vertebral bodies. So here also the signals were long. They were involving right from C3 to C7. and the ganglionitis, which was visible bilateral from C5 to C7, again on stir images. Slit was negative, a sural nerve biopsy was positive, the PCR was positive, and the biopsy was suggestive of BT. A diagnosis of BTHD with cervical cord involvement and bilateral ganglionitis was made. These are the follow-up pics of the patient post 1 year of MDT. It showed a residual short segment signal. So initially it was C3 to C7, you see. Now it has come down after treatment from C5 to C6. And the stir image also, the ganglionitis per se was persistent. It was earlier C5 to C7. Here also again, the ganglionitis per se is persistent, C5 to C7. Case 5 relates to a 33-year-old male. This patient presented with facial deviation towards the right side, the left-sided facial palsy. There is a weakness of the right hand and inability to dorsiflex the right foot without resistance, MRC grade 1. His MR brain showed enhancement, axial. Both pre and post-contrast images showed enhancing lesion at the pontomedullary junction, where the cranial, the 7th cranial nerve nuclei is there. There was enhancement at the level of facial nerve nuclei. HE again from the peripheral nerve showed the epithelioid cell granulomas and few foamy macrophages. Drug resistance testing was sent for this patient, which was negative. A diagnosis of mid-borderline Hansen's disease with left-sided facial palsy with probable brain involvement due to leprosy was done. Patient was treated with MDT and steroid. This was the follow-up images of the patient after a year of MDT, and all the sections, both axial, coronal and the flare axial images, they show no residual hyperintense signal at the level of facial nerve nuclei. The signals have disappeared and the patient also had clinically improved. This is the last case, relates to a male, again, middle-aged male, presented with left-sided facial palsy, weakness of the left foot and hand, MRC grading 2. He presented basically to us with ENL, fever and evanescent nodular lesions for 2 years. Imaging here showed a very long signal here in this case from C2 to C7. The stir image showed right-sided ganglionitis. It was unilateral at the level of C6 to C7. The section from the peripheral nerves showed numerous dispersed foamy macrophages, and the oil immersion field, the weight fight staining showed 0 to 1000 bacilli per OIF, globi were visible. So a diagnosis of LLHD with ENL, with deformity and probable lower cervical cord involvement due to leprosy was made. Patient was treated with MDT and steroid. These are the follow-up images of the patient after a year of MDT and steroids. Earlier the signals were from C2 to C7. Now they have declined from C5 to C6. The length of the signals have gone down. So these cases, they have been published in Curious, and these are the set of 6 cases that I have just shown. Only 2 of them showed positivity on weight fight staining, and we could get cases in all spectrum. You could see right from BT to BB to BL to LL, and there was one case of T1R as a case, and one case of T2R. In one case out of 6, one imaging or a follow-up MR was not possible. In the rest 5, majority, there was reduction in signals and complete resolution in one. Only in one case, the one with T2R, the signals were persistent even after 1 year. There was no such change. And these are the other studies. Very few studies have been done on this topic. And these are few other studies that I have quoted. These are the MR-based studies that have been done. These are generally few. These are generally case report or case series. And only 3 large studies, retrospective and 2 prospective studies have been done. The earliest one by Khadilkar, who proposed it for the first time from JJ Hospital, showed myelitis with ganglionitis. The one in American Journal of Tropical Hygiene, that is Phulwarisharif, it was a case series of 8 patients. They proposed in all cases, they got signals in the brain, in the cord, in the plexus, and they also proposed reversibility. In their cases, 7th nerve was generally involved. Palsy was there in all the patients except in one who had, other than 7th, involvement of the 5th, 9th and 10th nerve also clinically. What was interesting, he did a PCR for M. leprae in the skin or the nerve, was positive in all. But he also did a CSF PCR in 4 patients, the RNA-based study that would indicate a live bacilli. So that was positive in 1 patient. So maybe a direct infection of M. leprae is less responsible for these inflammatory changes. The third one is a radiological study. It was a retrospective cohort by Zabin. Again, showed lesions in the cord, brain, and plexus. The fourth is a study from our place, a thesis from the Department of Neurology, the prospective study. They analyzed patients without any cranial nerve palsy. They just analyzed patients who were weight fight positive on sural nerve, whose biopsy was weight fight positive. They took MB patients determined on nerve. And out of 29 patients, you don't get results in all. Only 5 patients had these signals. The other one is recently published, Bhoi one. They did a study on PNL patients. What they proposed is younger patients, they have more chances of getting these lesions in PNL. They got maximum, what they could get was ganglionitis, plexitis, and 11% they could get myelitis. And there's one also a brachial plexitis, which case report which has been published in IGTVL. So to end this discussion, a systematic review, this is the only systematic review till date which is available on this topic, has been done by Gargi et al., which included 16 case reports and 18 cohort studies. He not only took the MR imaging in perspective, he also analyzed autopsies, studies, the CSF analysis and EEG, and he concluded that there is evidence to suggest that the CNS is indeed involved in leprosy, but might be under-recognized till date. The limitations, of course, you cannot go and confirm. It's ethically not possible to go and confirm these lesions by doing a biopsy. And in future, maybe a functional MRI, a diffusion tract imaging can help with knowing what exactly these lesions are. If they are recovering, are there changes in the FA or ADC values? So who all should be investigated? Should we order MRI in all patients based on these studies? So what we could deduce is patients with cranial nerve palsies, especially with facial palsies, element type of facial palsies. You can image these patients, you can get in some proportion, you might get these changes. Patient with hyperreflexia, bowel bladder dysfunction, they should be imaged. Any patient suggesting involvement of the plexus, your sensory loss is extending beyond your normal areas. Patients with pansensory loss. So other than temperature and pain, we hardly go and check for vibration and position sense in leprosy patient. If that is lost in leprosy, they say it suggests involvement of the ganglion. This was suggested in the paper by Khadilkar. And disproportionate functional impairment. When the EHS scores are high, as you could see in all our patients, it ranged from almost 6 to 8. These patients might have higher chances of having these MR abnormalities. So to conclude, leprosy may not be confined to peripheral nerves. The more proximal nervous system like the plexus, ganglion, the brain and spinal cord is involved, and few studies are being reported and is increasingly being recognized. So every patient of leprosy warrants a detailed neurological examination other than what we are doing, checking for reflexes, cranial nerve palsy that should be checked. A targeted MRI, a craniospinal imaging should be pursued when you have clinical flags to suggest proximal disease, though even in normal cases with subclinical involvement, the imaging might reveal abnormalities. And probably just by concluding, looking at these cases, we might conclude that rather than a direct infection, that this could just be inflammatory because they are potentially reversible, as is shown in majority of the studies and even in ours. So my acknowledgements to my ex-HOD Department of Neurology, HOD Radiology, and my pathologist. So these are my references. Thank you. Thank you all for bearing with me.
Thank you for highlighting this cranial nerve and central nervous system involvement in leprosy as against the general view and opinion that it is excluded by M. leprae. Thank you, Doctor.
Thank you.
Yes, sir. Sure. Take one, Dr. Yes, Dr. Bhushan, please. Sir, you have to wait for.
Sorry, young lady. I think she's very fortunate to have collected so many cases in such a short time. Up to ganglionitis, I would accept because it is known, it is there. Now the question is that all these so-called BI negative patients having basilemia and also developing the disease to that an extent, maybe time will tell. Especially in patients who have the seventh nerve palsy, it is very well known that the nucleus for the seventh nerve is involved, even if it is not leprosy, even in simple Bell's palsy, it is there. So, from the autopsy studies, PCR positivity, even from the brain, doesn't mean that the brain is involved for that matter. So, maybe I'm ignorant, or maybe whatever I have seen in the literature doesn't fit in with whatever you have said. So I'll take some time to accept it, or maybe more evidence is needed for you to come to this conclusion. And the last thing is that steroids. The steroids tend to affect many of the palsy type of phenomenon, because most of them are inflammatory till such time they are related to some other neurodegenerative process. Thank you again for the observation which you have made.
Thank you, sir. The debate is still on. It's really difficult for people to accept this hypothesis till date, and that happened when we submitted our paper. So the controversy continues, and let's wait for more evidence, as sir says. But this is what we are getting in our set of patients, and also the fact that it's getting reversed after MDT. And we have another set of 7 patients. We have got findings. Other than 7th nerve, we'll disclose it later, sir. Thank you, sir.
Thank you once again. And I believe this next topic may also help in this, that is from PCR to genomics, as far as the diagnostic purposes are concerned. I welcome Dr. Rakesh Yadav, please, Postgraduate Institute of Medical Sciences, Chandigarh. You are welcome to present your diagnostic tools, that is PCR to genomics.
Thank you. Good afternoon all. And I first thank you to organizing committee to speak on this topic. From PCR to genomics, the next generation diagnostics of leprosy. So, a brief introduction. As we all know that leprosy is a chronic infectious disease caused mainly by Mycobacterium leprae and lepromatosis, and the organism Mycobacterium leprae is a slow-growing intracellular mycobacteria which has a very long turnaround time. The Mycobacterium leprae has never been successfully grown in the artificial media, and only the growth can be happen in like mouse foot pad and the armadillo animal models. So basically these growth-based methods cannot be used for diagnosis of leprosy or on the clinical management of the leprosy patients. So there are some molecular assays available who can detect Mycobacterium leprae directly from the clinical samples. In way back 1990, the first PCR was developed for Mycobacterium leprae, and after that some PCR modifications has been developed, and some newer methods has been also developed. So in molecular assays, basically we categorize into 2 categories. One is the conventional molecular assay, where we can include the PCR assays, loop-mediated isothermal amplification, and the other like modification of these PCR assays. The recent or advanced molecular assays basically includes the digital droplet PCR assays, the next generation sequencing based assays. In the coming slides, I will discuss one by one. If we talk about the conventional PCR, it was first developed for leprosy in 1990 by Williams and colleagues et al. And they have established a procedure for detecting Mycobacterium leprae DNA directly from the infectious tissues. And after that, a lot of studies has been conducted to check the sensitivity and diagnostic accuracy of PCR. And according to WHO document 2018, the sensitivity of PCR in multibacillary cases ranges from 40 to 100%, and in paucibacillary cases it is around 50 to 70%. However, the specificity ranges from 70 to 100%. Like once the PCR was developed in 1990, the other modifications like was also developed PCR followed by in situ hybridization, the PCR, one form of PCR that is the reverse transcription PCR in biopsy samples for basically detection of Mycobacterium leprae in clinical samples. These are the two studies from the JALMA. So the PCR sensitivity and diagnostic accuracy mainly based on their target which we used in the PCR reactions. The best target for Mycobacterium leprae detection in the clinical samples till now is the RLab, the repetitive sequence, which has a sensitivity and specificity of 100% in multivacillary and 80% of paucibacillary. However, the other targets like 18 kDa, 36 kDa, 16S, and these targets has been also validated in the clinical samples, and the sensitivity ranges from 80 to 100% in multibacillary and around 50%, 40 to 50% in paucibacillary samples. One study from Delhi where different types of the PCR targets has been clinically validated, like the RLab target, RPOT, SOD, 16E genes. And in this study also, the maximum PCR positivity was seen in RLab, followed by RPOT, and then 16S, followed by SOD. One recently meta-analysis was conducted for checking the diagnostic accuracy, and it was found that in the clinical biopsy samples, the overall sensitivity of PCR is around 50%, including the multivacillary and paucibacillary condition. Then these PCRs has been also validated in the to check the infection in healthy as well as the household contacts, and from these different targets, the PCR assay shows the positivity of 5.2%, 3.8% in household contacts to healthy contacts, like 1.2% to 7.8% in healthy contacts. These are the different studies where the other form of PCR, that is the multiplex PCR, was also validated, and it was seen that the multiplex PCR gives better results, like the sensitivity of 60% in skin biopsies comparison to the single targeted PCR, which has a sensitivity of 23% in biopsy samples. And the nasal swabs were, the M. leprae was detected in 53% of the nasal swabs in the confirmed PNL patients, while the single targeted PCR have a sensitivity of 10%. These PCRs has been also validated in other samples like urine, blood, and SSS. So the second form of the PCR is the nested PCR. I think everyone heard about the gene expert assay where this principle is being used, the hemi-nested PCR, real-time PCR. So nested PCR has been also tried in the for detection of Mycobacterium leprae, and I found only one study where they have said that the nested PCR has a advantage of 10% over the single targeted PCR, like the sensitivity percentage positivity was 80% for single and nested was 94%. The more advanced version of the PCR assays are the real-time PCR assays, which is also called as the qPCR or quantitative PCR assays. Nowadays, various studies has been conducted for the clinical validations, and if you see that the TrueNet Mycobacterium leprae assay has also based on the real-time chemistries, and now means like this is kind of the POCT test which can be used in the peripheral settings because it is a battery operated instrument and field friendly. The limit of detection of Mycobacterium leprae in TrueNet is around 330 copies per ml, while in this assay they have used multiple targets, like more than one target, that is the 16S and the SOD gene. Our studies has been yet not published on the TrueNet M Lepri, but the kit insert says that they have validated on a small number of samples, and this validation shows that the sensitivity, specificity and accuracy is around 100% in multibacillary patients. The another form of the amplification assays beyond the conventional PCR assays is the isothermal amplification assays, that is the loop mediated isothermal amplification, which is also a kind of the nucleic acid amplification assay, but the main advantage of this assay is that it can be performed on a single temperature. So we don't need the expensive PCR machines for these kind of assays, and with this due advantage, this can be used in the peripheral settings where less infrastructure is there, or resource poor settings where the expensive instruments cannot be afforded. And the end product can be visualized by the naked eye due to presence of the fluorescent dyes. The studies has been conducted for the validation of this isothermal amplification assays, and it was found that it is almost equal sensitive to the conventional assays, and having almost equal sensitivity or diagnostic accuracy with the quantitative qPCR assays also. So these were the form of the conventional PCR assays. So much more advanced molecular assays includes the droplet digital PCR assay. These advanced molecular assays basically have a better sensitivity or diagnostic accuracy than the conventional molecular assays, but the main problem is the cost. So if we talk about the cost of a normal thermocycler, that is around 4 to 5 lakhs. But if we talk about the digital droplet PCR, it is around 80 to 90 lakhs. So the cost per test gets increased for these assays, but the sensitivity and the specificity or diagnostic accuracy is far better than the normal conventional PCR. So one study was conducted on the droplet digital PCR, and this study's clear-cut shows that the accuracy in the postbacillary condition, the qPCR have a accuracy of 72%, while ddPCR have a sensitivity of 91.3%. The next assay, the much more advanced assay, is the next generation sequencing based assay. So one commercial kit, Diplex MyLab TB kit, is commercially available based on the next generation sequencing. And so basically this kit can identify more than 100 mycobacterial species, more than 31 targets for the typing, and much more and these 4 anti-leprosy drugs includes the rifampicin, fluoroquinolones, dapsone, and they have also included the bedaquiline also in there at this platform. So only 2 studies has been published yet. So they have...
Please try to conclude.
Yes, sir. So means in both these studies shows very good or high sensitivity and specificity for these assays. PCRs for Mycobacterium lepromatosis has been also developed, and on the basis of 16S rRNA and RPOPT sequence. So these are some commercial kits who are available in the market, like from Mole Biodiagnostics, Selene, and the Trust, etc. So in summary, like the qPCR, digital PCR, they have both high sensitivity and very high specificity, but the field use is moderate, the drug resistance detection is limited. But in NGS like platforms, the sensitivity is very high and drug resistance can also be detected. So this is the take-home message. At tertiary care centers, we can perform the PCR, real-time PCR and ease and everything. So newer test for low resource settings is a need, and the point of care diagnostic test should be developed for this thing. So these are acknowledged.
Do we have any questions from the audience? Okay, thank you, Dr. Rakesh Yadav, for your nice presentation. So So we move on to the next speaker of the session, Dr. Aparna Srikantam. The topic is antimicrobial resistance in leprosy, outcome, evidence to inform India's control strategy. Over to you, Dr. Aparna Srikantam.
Dear delegates, this is to let you know that the quiz is currently underway in LT2. And if any participants are here, kindly proceed to the venue at the earliest. Thank you. Good afternoon, respected chairpersons and dear audience. Yeah, the topic that is given to me is a bit very exciting, but also challenging. And definitely being in the field of AMR for quite some years for now, I tried my best to put whatever are the organizers, especially I thank Dr. Narasimha Rao sir and Dr. Sujay sir for challenging me by giving this topic. It's not just some data we present every time, but this is a bit more. I would like to also acknowledge with gratitude IIL Lepcon 2026 for giving me this opportunity for speaking. And certainly my travel is supported by ICMR through one of my research projects. And certainly for many years Lepra and right now Mallareddy University where I am have been supporting my leprosy work. And definitely since I have reviewed many papers, all the authors, their hard work is definitely what has made the basis for my presentation today. One of my PhD students, Mr. Pradeep, has helped me with literature review. I think I should not go too much into basics because we have been listening a lot about AMR in leprosy. Many of my previous speakers have spoken about that. But just one point I would like to make is, as a microbiologist and as a clinician, we all know that antimicrobial resistance is quite a natural emergence for any microbe that is exposed to an antimicrobial drug. It is more a rule than an exception, and Mycobacterium leprae is not an exception for that. So keeping that in mind, we all have accepted that, yes, definitely Mycobacterium leprae develops drug resistance, and the 3 drugs that have been part of the MDT are the most common drugs that can be, giving mutations in the bacterium. And in our regular clinical practice, we test dapsone resistance through PCR and sequencing of FOLP, and respectively the RPOB for rifampicin resistance and GAIR-A for fluoroquinolones. I just would like to bring, in the context of today's topic, I would like to review, being very close to the theme of this conference, just review what has happened in AMR for almost last 20 years. I still remember the first meeting we had in Jalma in 2006, where even the first thought about AMR in leprosy has brought in by WHO, and most of us were there in the meeting, and I was a very beginner then, and so I was observing what seniors were talking about. And since then, the WHO has taken up the global sentinel surveillance, wherein some of the labs in India have been part of that, and in 2017, WHO has handed over this to Indian program. I'm very happy to see that from where it was just taken over, in 2023, almost in 5-6 years, a full guidelines have come up, which are more customized for Indian programmatic application. And I consider this is all sort of a progress in terms of policy and capacity building. So as very much mentioned by Dr. Lily ma'am in her presentation in the morning, and I'm also happy since most of us who are sitting here have been part of these guidelines, and I've been also very happily contributed to this. And the objectives of the surveillance system was mainly to establish a nationwide robust surveillance system, because we learned lessons from other diseases, especially the close cousin, the tuberculosis. It also emphasizes that while developing the infrastructure, the technical expertise, which is already there, and involve all the stakeholders, but do a three-tier system where there is a peripheral level, sub-district levels of clinical and field work, and a district level where up to certain level of MR testing procedure will be taken care, for example, the biopsies or the slit skin microscopy, and an apex lab, precisely a tertiary care center or a medical college or any other lab, which will be doing the PCR and sequencing. This is how the lab preparedness and capacity development has happened, and really we have to appreciate the progress that has happened. When the WHO surveillance was there were just 4 labs for the entire country we were working, and during this course there were 7 labs by 2023, you could see in the guidelines. And now I'm seeing, like when I was reviewing, there are more than 10 labs and we are still counting. Many people are interested to work on this particular part of leprosy work. Having gone through all these papers, I thought, like, if I have to give something like review and inform to the program, what else than just go through a trend of what has happened to AMR testing and its trends during these years. So I just did a very simple review of what were all the publications during this time on Mycobacterium leprae molecular testing, so which actually have resulted in around 15 to 16 papers which has worked either on new leprosy cases or treated leprosy cases. There were a few papers which we have highlighted which have mentioned about ENLs and drug resistance. If you could look at the data that was shown, except there is one report in 2015, the RPOB resistance was not much in new leprosy cases. Whereas contrary, you could see of late for the past 4-5 years, there is a Guaireau resistance. The ofloxacin resistance has been observed. Whereas overall, the resistance in primary means the untreated new leprosy cases is not really very alarming. Whereas in the AMR in treated, or this could be a non-responder or a just treatment completed, MDT completed patients, or a relapsed patient or a recurrence. So all these were coming under this group. There is more or less quite a bit of resistance that has been observed for mainly FOLP and RPOB. And certainly there were instances where the resistance is even 20%. But I also draw your attention to look at, in most of the papers, the sample sizes were really a few. So this is what I wanted to show. While I also looked at the percentages, if we have put up as a trend, actually there is, there is not much significant change in the percentage of rifampicin resistance over these years, and more so for dapsone. Indeed, dapsone is reduced, but again it is not a statistically significant behavior. Whereas ofloxacin, still I expected little more, having seen so much of percentages, but even this trend is not statistically significant. So what could be the reason? So there were studies, but most of the studies they have conducted as focal studies. They haven't covered really wider areas, and they were conducted in tertiary care centers, or where most of the times the patients are expected to be registering after multiple referrals. They go to this kind of tertiary facilities. Though there is definitely AMR is present and persisting, but currently available evidence does not suggest there is any increasing trend. And even we have observed the sample sizes were much lesser and heterogeneous. So I'm not very sure, like my personal view as a microbiologist is, this is too insufficient an evidence to extrapolate it for a countrywide AMR trends. And recently there is a concern that most of the ENL patients have demonstrated AMR. So we tried to look at that and we found these papers. Certainly, yes, there is rifampicin resistance and FOLP resistance in both these, in all these papers that was observed. But the question is it the ENL is due to drug resistance, or is it just a confounding because it's just a relapse case which is presenting as a relapse presenting as an ENL. So this is something we all have to think about. So having done this interview, the review, we can contemplate all these questions. To know about actual incidence of AMR, we need wider evidence, at least as a baseline across the country, from which we can build on what actually the trends are. And resistance in new patients, how meticulously we are taking previous treatment history. As we all know, most of the patients are new to a particular facility, but need not be new to leprosy treatment. This is what is actually even our personal experience in leprosy, as well in TB resistance studies. We have observed this a lot. And certainly what is happening, persisters are hidden culprits. But can we think that these are dormant and still they can multiply to get that many number of mutations to be clinically presenting? We don't know. These are all the questions. And certainly we have to also think about, we just see a resistance in a lab, is it clinically correlating? Or a patient in whom we identify a resistance mutation, what is happening to them after second line treatment? So with all this, I thought like these can be suggested as recommendations for the control program in India. The number one, as we all agree, we need a capacity scale up, especially for testing facilities, to make it a nationwide surveillance. Involvement of medical colleges, of especially dermatology and microbiology departments are very important. And standard clinical protocols where treatment adherence is very important. As morning Dr. Sengupta sir was also mentioning, most of the problem of AMR can be prevented if the treatment can be adhered. Even whatever the regimen we give, if we could see that these are taken in full doses, that itself will be very helpful. And scale up early detection and measures for enhanced treatment adherence through built-in counselings. This could be thought of some new models, and certainly further research is needed, including operational research by the program itself. The control program, the NLEP, should come forward and give us challenges on what things we have to work. And definitely IIL can take lead on this. Innovative community engagement models, because we are right now working on some models. Maybe by next conference we'll come out with something. like it is very important to make the patients educated about the importance of treatment adherence. These are the references from which I have taken the data. Thank you for your attention.
Any question from the audience? Okay, thank you, ma'am. Oh, here is the question.
Sandeep.
Please provide the mic.
Thank you for the nice presentation, ma'am. Just a couple of comments, quick comments to make. I think in terms of drawing denominators around a sporadic occurrence, which is the case with AMR in leprosy now, we'll have to be a bit careful as to how we derive at the percentages, because a center reporting 100 cases this year, if it is reporting 1,000 cases next year, is an indication that something is happening. And you will not be able to draw a very solid denominator around what is the proportion of those 1,000 amidst the number of cases in that particular community. So it's not static, it's a very dynamic activity. Bacteria acquires mutations and it can just occur spontaneously sometimes, which we don't know. So the trend of how each center reports the number of cases each year is an important metric, and it should be followed as long as we have a very strong metric to say, okay, this is the denominator population. I think that's one comment, because you said some of your presentations showed not a lot of change in the trend because the denominators were small there. That's not the case always. The second point I would like to make is that there is presence of viable bacteria in an ENL situation, right? So the bacteria still persists viable in an ENL case, and if it would have acquired resistant mutation, it still multiplies in the body. And what is very important there is to understand the biological mechanism. Is it really expressing any triggers on its wall because of which an ENL is setting in more actively than it should be? I think asking those basic biological questions is important because there is an association somewhere. We are seeing that already being published. But we will not be able to say that the ENL could be a driver of that mutation, which is quite difficult to confirm. Just a couple of comments. Thank you.
Thank you. Yes. Yeah, we even found out that as one of the limitations of this review. And also, if we could look at most of the data is, and also the higher proportion of resistance are northern parts. We still don't know whether it is, most of the studies are done from there and a few studies are from south, but whatever it is, the proportions were higher. That is the first. Yes, we acknowledge that limitation of doing it like a heterogeneous analysis, not from that. And about the dormancy and persisters, I think we need to do more studies, because the more number of multiplications, the more chances of development of mutations. So if the bacilli are persisting just like a dormant bacilli without active multiplication, so how much it leads to mutation generation, that many generations of bacterial multiplication is something we all have to look at it. Yeah, fine. Thank you.
Thank you. Thank you very much, Madam Srikantam. Now we go for the next speaker, Dr. Manoj K. Ram, who is very expert and experienced clinician. He is going to speak on role of AMR in leprosy clinical practice, which is more important as we keep on seeing the patients, and many times, as in the previous presentation, it was discussed how much time we should give for the treatment. I believe Dr. Manoj will highlight on that also. Welcome, Dr. Manoj Ram.
Thank you, sir. Respected Chairperson, sir, dignitaries honored of the dais, I would like to thank the organizers, Sujay, Sunita sir, Santosh bhai and Rao sir, to give me this opportunity to talk about things I love. So basically we are going to discuss AMR in leprosy relevant to clinical practice. We will have data, we will have basic discussions, and we will have case-based discussions,
and we'll discuss how each step is clinically important. Lot of slides, we'll stop when the time runs out. So I have no conflicts of interest. So everything is aimed towards zero leprosy. And to achieve that, the clinicians, the foot soldiers, we have to encounter so many disturbances, so many opposition. AMR is one of them. And as we know, MDT is the backbone of this move towards the zero leprosy. AMR certainly poses a grave threat to it. Chemotherapy and drug resistance are basically two sides of the same coin. So what is AMR? Microbes no longer respond to medicines. Medicines become ineffective, increases the risk of disease spread, illness, disability, death and complications. AMR in leprosy is a rising public health problem. As since morning we have been discussing dapsone resistance and MDT introduction to overcome this. This graph shows the distribution of resistance. Initially it is a single drug, now it is a multi-drug resistance being reported. It could be a primary resistance or it could be a secondary resistance, as already discussed by many faculties. WHO recommends testing in all relapse cases and a sample of new multibacillary cases. Now when we are doing clinical practice, we should remember this. However, recent study has suggested modifying this criteria to including ENL, which is chronic or recurrent, which in clinical practice day to day we are seeing. The patient is coming again and again with ENL lesions. We are giving steroids, we are giving immunosuppressants. But again, why they are coming? That thought should strike the clinician in his clinic at least. So molecular testing, as we know, the drug-resistant DRDR genes reported across the globe. And the most important is the clofazimine and quinolone resistance are also being reported. So to come the basic thing, as a clinician, why should me, you and everybody should be worried by AMR? Now once we have a brief idea of AMR, already the disease burden in recent times what we are seeing is increasing, particularly in multibacillary cases. So AMR is going to increase it further, making the treatment difficult. Rising relapse rates in tertiary centers. Apart from clinic, in tertiary centers, in medical cases, colleges, we are getting more number of relapse cases. So basic backbone of MDT is currently now being threatened. And transmission of resistant strains are also being documented. So if I am seeing this number of cases in last 3 months, now as a clinician, what should I do? How should I treat? What should I think of? So we are patient, we are doing a split skin smear. We are starting MDT as per WHO norms, as per the government says. Now we are sending the patients to the DLO or the leprosy officer who takes care of the patient at the point of origin at his home, giving him uninterrupted medicine source. But drug resistance should be suspected in newly diagnosed of leprosy cases, not responding to treatment, MI positive even after 5 to 6 months of MBMDT. Now relapse cases, relapse is defined as a reoccurrence of leprosy, should exclude reaction at any time after completion of recommended WHO regimen. Recurrent and chronic ENL. Now how to assess EMR, we know, PCR DNA sequencing. Ideally, if a clinician is given the power, the facilities, then ideally new cases to be tested for resistance, retreatment after loss to follow, relapse cases, persistent positive morphological index cases, chronic ALS cases, recurrent ALS cases. As Jindal et al. Says, ideally this should be the case, but practically what happens in our clinics? When a single doctor is treating a patient of leprosy, a relapse case, a recurrent ALS case, how he should manage it? Now basic is just slit skin smear and a skin biopsy if possible, and PCR based gene amplification if the facilities exist. That is very important. I will say do test everybody, whoever comes to you, but the facility should be there. And we as know, till date, no facilities of AMR testing of leprosy are available in private laboratories or diagnostic centers at present. Now this is very important because in India, in the nooks and corners, there are dermatologists practicing in clinics. the facilities of AMR testing has to be there, but currently it is limited to NRL and RRLs, state-wise. So again, the clinician may ask, okay, I got a new case, I saw it, skin smear is 4+, I will start MDT. Why should I test? The AMR testing in leprosy is a crucial guide to effective management. Now the person has taken MDT for a few months, then he is lost to follow-up, then he comes back. If he has some records, that is very good, we can assess if it is rising or not. If he doesn't have any records, we get a 5+. Then if I have the facility of testing, I will send for resistance test. Implemented extensively across all geographic regions to identify regional variations. In India different, in Japan different. So not only for new and relapse cases, it should be also patients with recurrent or chronic AL and persistent positive MI. Now we will ask, okay, I treat my patient, I gave him MDT or I gave him a modified MDT as per the AMR testing, but what is it going to do in the community? Now AMR is responsible for the spread of resistance strains. We are getting new cases, we are getting more new cases. Now the second problem will be we are getting new and resistance cases, which will be going to be difficult to treat, and it is going to be transmitted all over the community. So it may lead to treatment failures, prolonged transmission, emergence of severe complications, thereby threatening leprosy control programs. So we have already discussed any drug resistance has been speculated to be responsible for chronic or recurrent ENL. Narang sir demonstrated a case where a split skin smear was not done and the person was treated with many modalities. So if a split skin smear can be done and sent for resistance testing, if the resistance test comes positive, then our treatment is going to be totally different. So it is going to guide the clinician regarding how he is going to treat. Relapse and retreatment. Now I am in my clinic, a person comes, now we have diagnosed him as a leprosy case, we are doing a split skin smear and we saw we got a relapse case. So a patient who has completed a full course of treatment returns with sign and symptom leprosy that are not deemed to be reaction. Retreatment should always start with the standard MDT while the results of AMR testing are awaited. So that is the importance of AMR testing in my or yours or dermatologist clinic setup. So this is the drug resistant leprosy and relapse difference. Now relapse mainly due to persister. If you see the IL textbook, the persisters are there. There is the endogenous source of reinfection in the patient. So practical diagnostic algorithm for a clinician who is going to see leprosy patients should be, when he sees a case with positivity or a new case, you must ask him whether his treatment history, whether he was prescribed MDT somewhere else, whether he carries that leprosy card, whether he was adherent to the full course of treatment, whether he took those 12 doses in 12 months or not. If doubt, repeat slit skin smear, rule out a reaction. If relapse is suspected, refer for molecular testing or AMR testing. And it should be documented and notified as per government regulations. So this is our first case. This case has been sent by our assistant professor Dr. Kanan. So 5 to 6 hypopigment anesthetic patches, 80% loss of sensation, SSS 1+. There is a defaulter after 8 months of MDT MBA, partial cloying trophic ulcer. Now when confronted with this type of case, we take the full clinical history, clinical examination and we send for the MR testing. Luckily the patient didn't come positive. It was diagnosed with B2 deformity with trophic ulcer and treated accordingly. The case 2, the facial, the body lesions, the hand lesions. Now this is a case with a 6 years history, BI was 2.7. No documented history of the MDT, but the patient said he had taken MDT, but no records were there. Now multiple subcutaneous tender nodules present over bilateral upper limb, lower limb, trunk and abdomen, LFT deranged, skin smear 4+, biopsy was suggestive. We sent for AMR testing and the patient came out to be rifampicin resistant and was treated accordingly. So the impact of AMR on clinical practice would be need for careful documentation, avoid empirical retreatment without testing, importance of supervised monthly rifampicin if available, educate patients about regular intake of drugs. These are the programmatic challenges, emerging concerns already discussed by many faculties. So AMR is one of the critical areas of intervention in the global leprosy strategy under the subheading of stop leprosy and its complications. This is revised classification for a clinician and new treatment guidelines for the drug-resistant leprosy. So as a clinician, as a dermatologist or leprologist, what should we do today? Action, integration in different government programs, partnership with different modalities, maintain high suspicion in relapse cases, because once my professor said, if the mind doesn't know, the eyes won't see it. Avoid irregular treatment, ensure complete MDT duration, and take home message, rifampicin resistance is the most serious threat, low prevalence but clinically significant, and almost always remember relapse is not always due to resistance, adherence should be there, molecular testing should guide the retreatment. My sincere gratitude to Nasimha Rao sir, Hemanka sir for guiding me, and my sincere gratitude to Dr. Dipti Bishoy, Dr. Kanan, and our postgraduate Dr. Lipika to provide us with the beautiful case photographs. This is a snapshot of the Leprosy and workshop in SC Medical College in 2024, and welcome to Meddama-Kon Bhubaneswar. Thank you.
Thank you for finishing in time. Any question from audience?
Sir?
So it is a true problem. We are convinced that antimicrobial resistance does occur, and thank you for suggesting the scenarios where we should suspect and recommend antimicrobial resistance testing. Thank you, Dr. Manoj Ram, for your nice presentation.
Thank you, sir.
Thank you all our respected chairpersons and speakers for the insightful session. I request you all to kindly collect your memento. We now proceed with the scientific session 2, reviewing progress, reactions and nerve damage. May I respectfully invite the chairpersons for this session, Dr. Hemant Kumar Kar sir and Dr. Joy Deepa Darlong ma'am, to kindly take their seats on the dais.
Dr. Jaydeep. This was okay. So our first speaker is Dr. Sudeep Das. He will speak on newer advances in etiology and management of leprosy reaction. Dr. Sudeep is a professor, head of the department of Calcutta National Medical College, and is very much associated with leprosy work. He has a lot of got prestigious national oration awards, IIDBL Best Teachers Award, Ganapati Panja Award, lot of international fellow leadership roles,
former national convener, PG tax force also, a lot of publications, a lot of presentations. Dr. Sudeep, please.
Thank you, sir. So instead I will start with the updated overview of the leprosy reactions. I'm not wasting the time. So this is actually the clinical spectrum between, this is BT, BB, BB, and BL and L that we all know. And this is the high cell mediated low bacterial load, and where it is low cell mediated high bacterial load. There is few lesions, there are diffuse lesions. We all know that, we are skipping that. Now these are the typical pictures of how a type 1 reaction looks and there is a type 2 reaction looks. Now the silent invader, it is a Mycobacterium leprae. What happens when Mycobacterium leprae, exposure to Mycobacterium leprae inside the host body, interaction with the alveolar macrophages, and the dispersal of the into the entire body. What have see that it affects the nerves and how the nerve damage occurs, the demyelination and the Mycobacterium leprae proliferation. The pathogen agents is Mycobacterium leprae obligate intracellular bacterium. These are definitely, these are standard, these are cannot be cultivated, that already been described, I am not going to say that. But the war of immunity, it is cellular versus humoral, that's the most important thing. If you look into the response of the Th1 type of response, interferon gamma and TNF alpha, and that actually stimulates the M. leprae, the strikes in the macrophages and the lysis of the microbial cells. And if the Th2 response is stimulated, what happens is the IL-4, IL-10 and IL-5, and this stimulates the B cells, and thereby the Mycobacterium leprae decrease lysis of the microbial cell, and there is bacterial proliferation. That actually is a key important of lepromatous. Now returning to the roots, when first medicines were chalmugratale, that is historical before 1946, there were bioactive metabolites in that also. They are not all. Then Central Astica, Bahunia variegata and neem, all these actually contain some amount of this anti-important. The all thing is not fallacy, whatever has been seen in our old past. The mechanism of nature is also there. These you can see the plant extracts and macula, the influx of phagocytosis. These are the historical aspects, but we'll go into the more details. Leprosy reactions are acute immune-mediated inflammatory episodes. They occur in 40 to 50% of your patients at some point of the life. Principal cause of nerve damage, deformity, and long-term diversity. So what we go? Now try to decode the leprosy reactions. If you try to decode the leprosy reaction, a surge in the cell-mediated immunity, there is a type 4 hypersensitivity. The T cells lead the inflammatory attack, and there is presence as inflamed skin lesions. If you look into the other part, there is caused by immune complex deposition, that is type 3 hypersensitivity. Neutrophils are the key drivers of the damage. So it presents as painful nodules with systemic illnesses, patterned with tender skin nodules, often accompanied by systemic symptoms, fever, joint pain. So immunopathogenesis, if you look, it is a central role of now the Th17 and the TREX axis. The TREX cells are the central pathogenic. Current evidence identifies an imbalance between the pro-inflammatory Th17 cells and the regulatory T cells. The TREX, as the central important, the crux of the lepra reaction. Under stable conditions, M. leprae promotes a TREG-dominant anti-inflammatory environment that allows bacillary persistence with minimal tissue damage. During reactions, the immune tolerance actually abruptly is broken down. So what happens is basically expansion of the Th17 cells, increased secretion of IL-6, IL-17A, IL-21, reduction of the FOXP3 TREGs, resulting in the loss of immune dysregulation, suppression of the TGF-beta, further destabilization of the regulatory pathways, and what is particularly important is this IL-21. It facilitates the conversion of TREGs towards the Th17 lineage, amplifying inflammation. The net result is persistent immune activation. Now, during the course of the time, I would come whether the biologics will be active in these things. The Th17 and the TREG17 population reactions are characterized by increase in Th17 cells, reduction of the TREG cells, cytokine profile. The imbalance leads to elevated IL-6 and IL-21, and particularly cytokine TGF-beta. There are the reports now. Tocilizumab, one of the known IL-6 inhibitors, has worked wonders in resistant variant of this type 2 reactions. Role of IL-21. This cytokine is pivotal because it promotes the differentiation of TREGs into the Th17 pathway. Now, pathological outcome, this shift chronic inflammation, neutrophil recruitment, leading to local edema, tissue injury, and permanent nerve damage. So what is this TH17 treg imbalance? Population shift, increase in TH17 cells. Then there is also cytokine profile is there. Role of IL-21 I already told, and the pathological outcome is chronic inflammation, neutrophil recruitment, tissue injury, and the nerve damage. So these TH17 treg imbalance is the basis of your reaction. So many cytokines central to the lepra reaction, especially IL-6, 21 and 23, signal through the JAK-STAT pathway, the STAT3 acting as the key downstream mediator. STAT3 activation is necessary for TH17 differentiation and maintenance. This insight provides the biological rationale for considering JAK inhibitors as future targeted therapies. See, I have given in one of my patients, I just tested my one experience. One patient was not responding to anything. I started out of the box tofacitinib in these patients. And tofacitinib 11 I started with, and the patient that was not responding to 60 milligram steroids thalidomide combination started to respond. And the now patient is almost fine with and I have already withdrawn I have been able to withdraw everything. Yes, vaccines I had not given because in my part it is not available that much. Role of JAK inhibitors and small molecules, JAK-STAT signaling pathways. The STAT3, the signal pathway, is central mediator in the immune inflammation. IL-6, tocilizumab, I already told, TGF-beta, STAT3 inhibitors. The significance, STAT3 is a significant downstream pathway of the JAK inhibitors, presents a highly static therapeutic trigger for interrupting the cytokine storm that triggers the reaction. So it cuts down the cytokine storm. Now is the small molecules. You have one of the small molecules, apremilast, a small molecule PD4 inhibitor. And these inflammatory cytokines like TNF-alpha and IL-12/23. We all know ustekinumab is available. It has been used successfully in chronic and recurrent Biennial, resolving the symptoms in approximately 15 days. Methotrexate acts by steroid-sparing effect, and methotrexate, take my words, in the same mechanism it acts in psoriasis, the same adenosine pathway. It has cut down the pro-inflammatory cytokines and works very well. So it can be a corticosteroid-sparing agent in there also. Colchicine, the small molecule, was pre-purposed for the management of mild DNL. Emerging candidates, small molecules, metformin and SSRIs are identified as potential future therapies. So what are the important therapies we are coming out? STAT3 pathways, inhibitors, the central mediator in the cytokine profile, apremilast I have already told, methotrexate is a very important, colchicine, and the emerging candidates are metformin and SSRIs. So this is, and besides that, there are multiple new things. The mechanism of nerve damage, the type 1 associated with borderline, we all know, type 2 associated with lepromatous, and mechanism is T-cell mediated is type 1, whereas mechanism is more complex, immune complex deposition. Sudden nerve paralysis occurs with type 1, and here it is painful red nodules and systemic inflammation. So I will go into the type, not go into these things, already we discussed, this neuritis has been described. Recent studies highlighted increased INOS expression, reflecting heightened macrophage activation. Impaired autophagy allows inflammasome activation, NLRP3 and IL-1 beta activation, genetic association with LLRK2 and TLR2 polymorphism, and relation of the pro-inflammatory pathways that can the other diseases as Parkinson's disease has been seen. The genetic susceptibility, the recognition of the TLR1 and the NOT2, immune regulation, HLA, DRB1 and IL-10, the autophagy, the PARP2, LRK2, RB32. These are shared with Parkinsonism. The skin barrier, filaggrin is also, which is important in atopic dermatitis, is also significant here. So these are the genetic relations, entry point, this direction point, and clearance point, also the killing point. I'm not going to the details of this because of the short time. The diagnostic gap. This is the current state, and these biomarkers are there now. RAKRT by B10, field PCRs, particularly the RPO-B resistance, and early detection, humoral plus cellular markers are there. The type 2 reduction, very shortly, I will state ENL is understood as a systemic inflammatory syndrome that predominantly affects the BL and the LL pole. The major paradigm shift of neutrophils are the key pathogenic drivers. Now increased circulating low density neutrophils. That is a very important bit. It is the neutrophils formation of the nets, that is the neutrophil extracellular traps which cause endothelial damage, vasculitis and tissue necrosis. and high levels of TNF6 alpha, IL-6 and IL-8, important the dead bacilli rather than the viable organisms contribute to the inflammatory milieu, and thereby explaining why reactions can occur even after effective antibacterial therapy. That explains your thing. Now, I will also see that there is a 5-gene transcriptic signature now, CCL2, CD8A, IL2, IL-15 and MARCO, that can predict the reversal reaction up to 2 weeks before the clinical onset. High titers of anti-PGL1 and anti-NDO lead-1 antibodies predict future ENL episodes. Now, easily accessible markers such as neutrophil to lymphocyte ratios, pentaxin 3 that can correlate with your reaction severity, epigenetic regulators, particularly myRNAs, MIR155 and MIR1291 are emerging biomarkers and possible modulators of TREC stability. So these are the new areas where leprosy studies are progressing. The predictive tools for the reaction are recent studies. This is a flowchart I have given, 5-zone transchromatic signature, predicts the reversal signature, high titers of anti-PGL and anti-NDO lead-1, predicts future ENL episodes, neutrophil to lymphocyte ratio that is doable in our setup, correlates with the reaction severity, pentaxin 3 also correlates with the reaction severity, epigenetic regulators, that emerging biomarkers, that possible modulators of TREC stability and possible modulators of the immune inflammatory responses. Now coming to the nerve damage, the final common pathway, these are, you can do it also with immune mediated destruction. These are the other pathway. High resolution ultrasonography Doppler has emerged as a key valuable tool to detect silent neuritis even before the clinical deficit has become apparent. So you can do a high resolution ultrasonography with Doppler. Immune mediated nerve destruction. Immune mediated nerve inflammatory cytokines but MMPs disrupt the blood nerve barrier, demyelination, axonal degeneration and high resolution ultrasonography with Doppler. I'll skip these things. I'll come. So type 1 reaction, this is actually the standard oral prednisone treatment.
Sir,
so
please wind up.
And low dose thalidomide, where this thalidomide has been used. These are other possible things. Infliximab have used. Just
Sir,
one more.
please wind up.
Just 1 minute. Inflammatory and obviously these MIP vaccines already some earlier speakers were speaking. These are worked wonders. Lep type 2, these are our responses, new things that can come up, and this is the leprosy over immunity. So, and these are the biomarkers. To sum up, I will just sum up with immunotherapy and prevention. This is already done. The fight against leprosy, past success and the future frontiers, you can see. I have just put it in that theory. So, these the limits of the old guard. Now, this is the new thing that I just want to highlight, this nanotechnology. This is a new innovation. And this innovation is another important innovation where you can prevent the drug permeability better. The same thing that in a different form. These are multiple studies on nano innovation, including one from Dr. Kanwar also. So this is in essence overall crux. Leprosy reactions are a collapse of the immune tolerance driven by TS17 mediated STAT3 signaling. Early biomarker detection rather than prolonged steroid use alone are key to the stability. Thank you.
Thank you. Thank you, Dr. Sujit. Are there any questions or any comments? Yes, Dr. Sengupta.
My point was that not everybody goes into reaction.
Yes, 30 to 40% of your patients will go into
Pardon?
reaction. 40 to 50% of your patients at some point of life.
We know that.
Yeah, sir.
Not why all patients go into reactions. The question is, they are same individual with same bacillary count. One is going into reaction, one doesn't go. We find, I think, that there are a lot of cell molecules which are mimicking with bacteria. And we have published many papers on this. And these are causing molecular mimicry in certain groups of patients, and that's why they want people go into reactions. Otherwise, there are a lot of cells which are going into NK1 cells, TGF-beta, and then self molecules are more recognized, and that's why probably the mimicking molecules are causing reactions.
So molecular mimicry is one of the possible mechanisms, what we have aptly said, that this is one of the mechanisms where why all patients do not develop.
Yeah, that's
that's acceptable.
In a lepromatous leprosy, about 1 million bacilli per ml, 1 million bacilli they circulate all the time. We have done basilemia long ago.
Yeah.
And continuous basilemia. And so, M. lepri has got lot of similar epitopes with nerve, with keratin, and we have identified those. And we have made peptides of those and they cause these reactions. Anyhow, we'll come with a lot of other things anyhow. Because
this is
yes,
very,
sir.
Very nice presentation for that matter. But this is one situation where the laboratory and the practical things simply do not match. IL-17, IL-21, 23 inhibitors, JAK inhibitors and TNF-alpha inhibitors, methotrexate and all, they uniformly do not work. They don't seem to match. So what we see in the lab and what we see in practical is entirely different. But as I said, that this is what you have presented, the laboratory findings, but they do not seem.
So just from my one experience, I can tell Abhishek and I carried out a study on ENL reactions and infliximab, because that was the only biologic that was available at that time. And out of 8 patients, all patients responded very well.
Lucky man.
Infliximab.
Thank you.
Excuse me, ma'am. I have a small announcement to make. So the central CC meeting will be happening at after 5 minutes at Hall C. So all who are the CC members kindly join the meeting in Hall C. Thank you.
We'll continue with the next speaker, Dr. Seema Chhabra, and she'll be speaking to us on the mapping of ENL pathogenesis from plasma priming to neutrophil-driven tissue destruction. Dr. Seema Chhabra.
A very good evening to everyone, the remaining person in the hall. So I will be introducing all of you into the fascinating words of omics today, and moving apart from the humoral and cellular immunity, I'll be targeting today innate immune system that is working in ENL as a trained memory. That's the innate immune system which is having memory and bringing about the devastating manifestation which are seen in patients who are suffering with ENL. So Dr. Sudeep has already made my job very simpler by talking all the things which are already known about M. leprae, and the 2 main cells which are in which the M. leprae is surviving in the body, one is the macrophage and second the Schwann cells. And indirectly Schwann cell is again an arm of the innate immune system, which is the non-immunogenic cells, and the macrophage is again a cell of the innate immune system. So we know this TT and BT, then this is LL pole. Despite the humoral immunity and the number of antibodies being much higher in number in LL pole of leprosy, these are the ones which are having the devastating manifestation of the disease. Why? Because these all antibodies, they are non-neutralizing. The same thing happened in the case of COVID, and again the devastating manifestation was seen. And we all know ENL is characterized by the neutrophilic vasculitis. And a lot of studies have been conducted with the main cells, which is the lesional cell, which is the cell in the pathophysiology of ENL, and that is the neutrophil. The role of MMP3 and CD64 activated neutrophilic phenotype, low density neutrophil, as Dr. Sudeep has already mentioned, it is the activated phenotypes or the band cell which are seen in the peripheral blood, which are implicated in the autoimmune manifestation of the variety of autoimmune diseases, and one of the target cell again in the ENL. So the need of the hour is to characterize a marker that allows the identification of leprosy patient at high risk of developing leprosy reaction. So this is the whole study that I'll be presenting today, is the work which is conducted by our PhD student, and we began with this thought in mind. We wanted to see what are the LL patient or the BL patient who are going to develop ENL in the future. To have this thought in mind and to work on this idea, we need to know what are the signature molecules which are defining ENL and which are defining the LL patient. And here we took the help of omic technology. And why this whole understanding about ENL is still poor. We are still struggling with the therapeutic options in cases of ENL patient. Somebody is trying biologics, somebody is trying with the methotrexate, but still the patient are not recovering. Why? Because there is no animal model till today which is having the manifestation of ENL. And so thereby there are difficulty in treating therapeutic options, because we don't have any model, in vitro model, by which we can study these reactions. So we began with the peripheral blood neutrophils. As already we all know that absolute neutrophil count as well as the NLR ratio, they were significantly much higher in patients in ENL as compared to the LL. And these are various activation markers that we shown on the surface of peripheral blood neutrophils, and CD11B as well as 62L, they were showing the higher impression, and meaning by heightened activity status of the neutrophils, of the peripheral blood neutrophils in ENL patients. We studied both the subsets, normal density neutrophil as well as low density neutrophil. So these are the results with low density neutrophils, where the frequency of the low density neutrophils was much higher in LL patient as compared to the LL patient. So this was again the activation markers were studied on the surface of neutrophils, and these are the 11B, which is an activation marker, and CD62 ligand, significantly different in the lower density neutrophil population as well between the ENL and LL patients. And we looked at the neutrophil extracellular trap formation. This is one of the another mechanism by which the pathophysiology of the ENL is driven. And we saw, it is at the basal level, or spontaneously at 4 hours, or with the plasma induction, or with the plasma dilution, every strategy we employed, and ENL patients were significantly displaying higher neutrophil extracellular trap formation. So then we went on to the proteomic analysis of the neutrophils. So we did look at the PCA plot, but the middle plot, and all the red dots, they are depicting the data which is driven from ENL patient, and the mustard dots, triangles, which are representing the data from the LL patient. All the LL patient, they are cleanly segregated in the lower left region, while the look at the heterogeneity which is seen in the ENL patient, they are everywhere, but they are quite distinct from that LL group patients. We look at the differential protein analysis. The red ones, the red dots which are on the extreme side, they were the upregulated protein, and the blue one were the downregulated proteins. Then we did the correlation analysis, and finally we went on to the pathway enrichment analysis. Now look carefully on the pathways that have been depicted here on this side, on the lower side. The pathway which has come up in the first 4 pathway was the necroptosis. So this is the one pathway that we have found and which intrigued our interest. And then we plotted all these pathways against the log to fold change of the respective proteins, and the protein which caught our attention were that of the histone proteins and Fc gamma receptor 2A, PML. So these are the log to fold change across various comparisons: total ENL versus LL, acute ENL versus LL, chronic ENL versus LL, or recalcitrant versus LL. Across all the comparisons, these proteins, they have having higher fold change as compared to the LL patient. And then we have done this PLDS analysis, and this is basically discriminating or defining the signature proteins which were associated with the ENL versus LL. Now again, look at this squares that have been drawn on the other side of the diagram. The protein which caught our attention was the PML. And so we finally jotted down these 3 signature proteins as the hub proteins. One is Fc gamma receptor 2A, second is the PML, that is promyelocytic leukemia protein, and MLKL, which is the main signature gene which is involved in the necroptosis pathway. Now what are these proteins being elevated in the neutrophils? What are they doing here? So then we went ahead with what is driving the priming of the neutrophils? We have already seen, we have started with the peripheral blood neutrophils. They're already in the prime activated state, which is revealed by the activation state of the various activation markers on the surface of the neutrophils, and there's something should be there in the plasma. So it is the LL or BL group of the patient which are having the higher antibody in the circulation which are manifesting ENL. So there comes the role of Fc gamma receptor 2A. So this is basically capturing the immune complexes, presenting it over the neutrophils, and then rest of the pathophysiology is being driven. So similarly, as we saw in the neutrophil proteomics, we are seeing the same results in the plasma proteomics. The LL patient, they are clearly segregated in the PCA plot that we can see is the central plot, and the red dots, they are heterogeneously, they are distributed all over the rest of the 3 quadrants. And upregulate differential protein analysis. And then we have the look at the topmost pathway which have been found upregulated. These are the acute phase response and the tumor necrosis alpha production. And then it is the interleukin 1 production and the LPS pathway. It is the lipopolysaccharide pathway which has come up and which caught our attention. Then we plotted all these respected pathway which we were interested in, and then we plotted against the log to fold chain of all the proteins which were differentially expressed across the 2 groups, ENL versus LL. And then we done the PLDS analysis. Again it showed the discriminatory power and what were the proteins which were characteristically associated with ENL, and some of them they were characteristically associated with the LL. So here the protein that caught our attention was the platelet factor 4 and MMP3 and LBP. It is a lipopolysaccharide binding protein. So what is this lipopolysaccharide binding protein is being elevated in the plasma is doing here? It is basically binding all the immune complexes or the lipoarabinomannan which is being circulated, the bacteria which have been broken down and binding them, and then it is taking towards the priming of the neutrophils. So then we have done the WGCNA analysis. In this, all the plasma proteins and the neutrophil proteins, they were clustered together so as to define where are they clustered together. So basically to explore the interconnectedness between all the proteins that we are interested in. There were 3 proteins that caught our attention in neutrophil proteomic analysis. One was Fc gamma receptor 2A, second PML, and third is MLKL. While in the plasma proteomics we found LPP, PF4 that is platelet factor 4, FSTL1 that is follistatin-like 1, and this is the glucosyl transferase that is ST6-GAL1. But when the dendrogram was plotted and in the epigenetic scoring was done, and look at the scores in the ENL patient, they were significantly elevated as compared to the rest of the 2 groups, that is healthy control and LL patients. So the corresponding validation was also done. For this, the 5 patients of ENL and 5 of LL were taken, and this confocal microscopy, look at the lower half of the graph in which the characteristically beautiful increased expression of the gamma receptor seen in the neutrophils of the patient from ENL. And this is the expression of the PML. Look at the lower half of the diagram in the confocal microscopy and look at this bar plot in which the results were significantly elevated in the ENL as compared to the LL patient. And this is with the MLKL. It is the phospho-LL MLKL with the downstream product which is significantly elevated as seen in the other side of the bar plot, which is significantly elevated in ENL patient as compared to that of the LL. Then we did the validation for these 4 proteins. So they are all telling their own story and they are building up at the connection, and they came out as a hub protein in the ENL pathophysiology. And ELISA was done for all these markers, and look at the red bar which is the result from the ENL patient. They are significantly elevated, and this was done in 18 ENL patients versus 8 LL patients, and the results came out to be statistically significant for all the 4 protein which came out as a hub protein in the whole analysis. So it is ST6-GAL1. So this is finally we came up with the new axis which is the Fc gamma receptor 2A, LBP, PML, MLKL axis, which is main pathophysiology driven by the necrobatosis and the NET. So all the soluble proteins which are there in the plasma, they were binding to their corresponding receptor. For example, all the red thing which have been shown here on the surface of the neutrophil, this is the neutrophil that have been shown here. On the surface of neutrophil, these were the highly upregulated protein which were seen in the plasma proteomic analysis as well as neutrophil proteomic analysis. And they are binding to their corresponding receptor, and they were leading to the opening of the chromatin, finally the pathway mediated by this MTPT which is there in the mitochondria, and the whole endocytosis machinery has come into play, which is displaying opening up the heterochromatin, and all the nets which have been being formed, they are exocytosed out of the cells. And so this opening of the nuclear chromatin of the neutrophil, it starts the transcriptional firing, thereby leading on to the devastating pathophysiology of ENL. So basically we are now planning to study the interaction of these 7 molecules that have come up in our study with all the available therapeutic which are available in the market and that are being used by the clinician, so as to see what therapeutics are hitting which molecule that has come up in our analysis. Thank you.
Thank you, Dr. Seema. Very nice presentation. Because time is lacking, only one question I want to ask you. What message you want to give to clinicians? Any protein signature predictor of development of PNL reaction?
I didn't get your question, sir.
Any message you want to give to the clinician to predict? Sorry, it's any message you want to give to the clinician, which is the best predictor, any signature protein which patient can develop, which patients could develop the reaction?
The 4 plasma markers that we have come up with, that is with, this was the thought that I started with. If any LL patient, if these 4 markers level they are seen, we are deriving, we are doing the ROC curve analysis right now on all these patients. So to divine a cutoff, if the levels they are coming out to be higher than the cutoff, so we need to observe those patients that if the patients who are having high cutoff value for all these 4 plasma biomarkers, in near future they are developing ENL. So that was my goal. I started the whole study because I sat with Dr. Tarun and Dr. Dogra. So what are the things that are bothering them in the as clinicians in the clinics? So they gave me this thought. So I basically hypothesized the whole study based on this.
Sir,
Thank you. Thank you, sir.
Sorry to interrupt you. The GBM will be at 6 p.m. Hall C. So everyone who is interested in GBM to kindly attend.
Thank you so much.
Thank you. Thank you so much, Dr. Seema. Our next speaker, Dr. Anupama Singh, will speak on biologics in type 2 leprosy reaction. Very good, you have used in leprosy reaction. Lepra is a term, some NGO. So sometimes when you write lepra reaction, we feel odd. Actually, it should be leprosy reaction, not leprosy reaction. Eh?
Thank you, sir. Thank you, chairpersons. And good evening, everyone. Despite the fact that Hansen's disease is one of the oldest disease known to mankind, about 4,000 years old, but still in India, it is considered to be a public health problem, contributing to more than 60% of the global burden. Until date, it is considered to be a devastating disease, producing deformity and disability. With the success of multi-drug treatment in combating the mycobacterial infection, the focus of attention has now shifted to the immune-mediated immunological reaction or inflammatory episodes that accentuates the chronic course of leprosy. Yes, the real challenge are the lepra, or sir is saying leprosy reactions. And obviously, we are more concerned about type 2 reaction because they are more common and also more chronic. Disability is more due to the ENL than due to the underlying disease. So the chronicity of the disease triggers the discrimination and and also the physical pain which the leprosy patients face. The multi-system immune-mediated inflammatory condition, when it is moderate to severe in intensity, it can be considered as a medical emergency because it affects important structures, vital structures like the peripheral nerves and vital organs like the eyes, causing iridocyclitis, leading to glaucoma, synechia, and even blindness, epididymo-orchitis, leading to sterility, arthritis, and nephritis. These type 2 reactions usually occur in the first 2 years after starting the multi-drug treatment. But it remits and relapses, and the median duration in a study was found to be 5 years, though it may go on for sometimes 10 years. The inflammation has to be brought down, and the most important drug or the most appropriate drug we find is in the form of steroid, which is given in high dose and for very long period of time because of the chronicity of the disease. This not only causes the hemodynamic and the metabolic complication, but also causes steroid dependence and predisposes the patient to severe life-threatening infection like septicemia and all. Other immunosuppressants like methotrexate, azathioprine are slow in action and not very effective in severe cases. So these were the side effects that we noted in our study of corticosteroid. So we are all aware, apart from the Cushingoid habitus indicating the HP axis suppression, we also noticed fracture. So osteoporotic fracture is one complication that we are wary about. And a study in Ethiopia showed a mortality up to 9% in steroid-treated patients of ENL. So this was one of our patients. Tumor necrosis factor is one of the most important cytokine which is found to be elevated in type 2 lepra reaction, and we have drugs which are active against TNF-alpha. We have found them to be effective indeed, and these are in the form of thalidomide and TNF-alpha antagonist biologics. So the serendipitous discovery of efficacy of thalidomide found by Sheshkin in 1965 gave a lifeline to our patients of type 2 reaction. It provides an effective alternative long-term control, but it was not without its peril, because we know that it is a teratogenic drug and it also causes neurotoxicity, and availability and cost is also a factor. Now coming to biologics, we have many case reports and case series showing the efficacy of biologics in type 2 reaction. Infliximab by Faber et al. It has been published in 2006. Baseline dose was given, then at 2 weeks, and then repeated at 6 weeks, and thereafter the patient did not develop type 2 reaction. Ramian et al. Has published efficacy of etanercept in type 2 reaction, and they kept on giving etanercept at 50 milligram per week for 2 years. And the role of adalimumab has also been published by Mendes et al. Secukinumab has also been used. So now I'll share in short my experience of use of thalidomide and etanercept in patients of type 2 leprosy reaction. We recruited 40 patients of chronic ENL from our leprosy clinic of PMCH. Females with potential for pregnancy were excluded. Now the severity of ENL was scored in the form of N-list at baseline and that at fixed interval. The required investigations were done. All our patients were young, between 30 to 40 years of age, the youngest being 10 years of age. Males predominated, and the duration of episodes ranged from 8 months to 6 years. Now the regimen that we used was, we were using combination of corticosteroid and thalidomide. We started with high dosage of thalidomide, 300 milligrams, especially in severe cases, and 200 or 250 in moderately severe. And we decreased the dose of thalidomide only when the dose of steroid came down to 10 milligram. And we did it very slowly by 50 milligram at the interval of 2 to 3 months, depending on the control of the ENL reaction. So these were the observations. The resolution of lesions was seen in a mean of 5.54 days, and the constitutional symptoms regressed in 2 days. The duration of thalidomide treatment was ranged from 2 to 2.8 years. These were some of the endpoints which we observed. Mean time to reach 10 milligram prednisolone was about 5.5 months. Time to off prednisolone ranged from 8 months to 1.4 years. And time to off thalidomide ranged from 2 to 2.8 years. But a subset of patients could not be weaned off thalidomide. So this is important. So these are the pictures of one of our erythema necroticans patient. Side effects of thalidomide that we noted during our study. So we conclude that with the use of thalidomide along with corticosteroid, we do get faster clinical recovery time, few relapses, and long period of remission. Initially, high dose should be given with slow tapering and long maintenance phase. will give higher success, and this is in concordance with a study done by Parekh et al. So more effective response is seen if we initiate thalidomide early, hit hard and early. Patient on higher and longer duration of steroid treatment required more time to improve. There was also improvement in neuritis with thalidomide, but we have to give corticosteroid in high dose if neuritis is there, because that is, steroid is much more effective. And it did provide us with steroid sparing effect. So addition of an adjunct will reduce the need for high and prolonged corticosteroid. Now the subset of patients who did not respond to combination of steroid or thalidomide, or if they did respond, we were not able to wean them off thalidomide. So total 7 patients were there. 4 patients were on thalidomide 50 milligram once a day for 3 months, and 3 were on thalidomide 50 milligram alternate day for 6 months. And they also used to have lots of arthritis and all. So we started giving etanercept in these patients. We gave low dose because of the cost, only 25 milligram weekly for 6 hours dosage, and then fortnightly for 6 to 8 dosage, depending on the response. All patients could be weaned off thalidomide with no additional side effects and were in complete remission in a follow-up period of 1 year. So taking cue from these patients from this series, we planned an randomized controlled trial using steroid and thalidomide versus steroid, thalidomide and etanercept in our department. And this study is being done by our PG student, Dr. Neha Nidhi, she's here. So 27 patients were given steroid plus thalidomide and 22 steroid, thalidomide and etanercept. Now the prednisolone dosage is, as we have already mentioned, standard 0.5 to 1 milligram body weight. And again, we started tapering it by 10 milligram at 2 to 3 weeks interval, depending on the response of the patient. And when the steroid dose reached 10 milligram, then we started decreasing thalidomide. And thalidomide also was given in high dose, and etanercept again 25 milligram subcutaneous, the same regimen. So these were the investigations. So just to highlight the response, this is group B, where etanercept is being used. The frequency of ENL is low. The number of lesions per episodes were low. The reduction of systemic complaints per day were low. Improvement in neuritis was high, and time to reach 10 milligram steroid was less as compared to group A. Then the cumulative dose of steroid was also less, and the cumulative dose of thalidomide was also less. Again, the same, showing the etanercept impact on cumulative thalidomide and prednisolone dose. So we can just see what are the differences, that the cumulative dose of steroid and thalidomide both are less in the etanercept group. So these are the side effects. No additional side effects. In fact, the side effects due to steroid, that is the Cushingoid features, the gastrointestinal complication, diabetes, hypertension, tuberculosis, all were low. So this is the spectrum of benefits that we saw in a study with etanercept. I would like to highlight that the average time taken to reach minimal dose steroid was 5 months when etanercept was not given in our patients, and it was 2.5 months after etanercept we started giving etanercept in our patients. Now, average time taken to stop steroid was longer before giving etanercept in the group where only thalidomide and corticosteroid was given, while it was 5 months in the group where etanercept was being given. And average time to reach minimal dose of thalidomide was 24 months in the non-etanercept group, while it was 10 months in the etanercept group. And average time to stop thalidomide was quite low in the etanercept group, that is 1 year as compared to 30 months. So the synergistic effect of thalidomide and etanercept could be seen in a study, though thalidomide also both act on TNF alpha, but etanercept is a more targeted therapy. and more effective. This use of both thalidomide, etanercept with steroid proved to be more effective with less side effect, and the compliance was also high in our patients. So we need to do multicentric studies, and a pharmacoeconomic benefits can be seen if we do many multicentric studies. Thank you.
Thank you, Dr. Anupama. It's a very nice, innovative study on the role of etanercept in ENL reaction. Any question from the audience? Please, please. Dr. Pai.
You mentioned about in one of the regimens was thalidomide and steroid in some cases. So did you notice any adverse effects in this combination?
No, sir. In only one of my patient, she developed some thrombosis, maybe because, but we were not sure, only one patient.
This could be DVT.
Yeah.
So any evaluation was done in these cases?
Yes, sir.
Any evaluation done?
Yes, sir. We had referred her to the neurophysician, but we were not sure because only one of our patients developed that out of all the patients.
The risk of DVT is
higher
with thalidomide and steroids.
Yeah, DVT is a very rare complication when we give thalidomide. Thank you so much, Anupama Singh.
Thank you, sir.
To continue with this DVT and thrombosis of thalidomide, one of the protocols that the Leprosy Mission follows is to give aspirin with all the patients of thalidomide, 75 milligrams per day. So that's, but I would also like to ask whether this regimen can be followed in primary care hospitals where most of the ENL patients present. So that's a question we need to ask ourselves. The next speaker is Dr. Bhavna Sharma. Request her to come quickly to the podium. And you've got 7 minutes to make your presentation complete. Investigating the regulation of cytokine production by signal transducers and activator of transcription STAT molecules in leprosy reactions. Yes.
Thank you so much, ma'am. Very good evening to chairs and good evening to all of you. As in this session, many of my fellow speakers already has discussed about reactions. Here, my part is I'm focusing that in reactions, how the cytokine production is regulated by, we are focusing on the molecules JAK-STAT pathway, and we are focusing basically on the activation of signal transducers and activator of transcription. Reactions, already people has discussed that reaction is the main problem, and to achieve the zero leprosy, the goal of 2027, our respected Prime Minister's goal to achieve the zero leprosy program, it is very much important to focus on leprosy reactions. Here, as we know that leprosy reactions are very much important, immunopathogenesis of leprosy reaction is somehow very much different from the normal leprosy. So how the immune mechanism is just regulating such kind of leprosy reaction, we are focusing here on STAT molecules, and as we know that the cell signaling mechanism is so much complicated. On the one hand, JAK-STAT pathway is regulating the production of cytokines, number of cytokines which are important for the production of various kind of T-cell subset, playing very important role in the leprosy reaction. On the other hand, there are some other kind of important molecules known as suppressor of cytokine signaling molecules, which are regulating that activation of STAT molecules. So here, the activation of STAT as well as how the SOX molecule is regulating the activation of these STAT molecules is the main thing. This is just to show that how these STAT molecules are just regulating the Th1, Th2 type of cytokine production in leprosy. And is this second one, this is showing that how Th1 is regulated by the activation of STAT4. On the other hand, SOX is negatively regulating the activation of STAT4 and affecting the production of Th1. Yeah. On the other hand, STAT6 activation is regulating Th2. Similarly, other SOX molecule negatively negatively regulating the activation of STAT molecule and affecting the production of TH2. Same with TH17. TH17 is regulated by STAT3. There are number of SOX molecules, mainly SOX3 is a very important player. SOX3 is playing very important role. Very important player of the cell-mediated immune response, T regulatory cell, that is regulated by the activation of STAT5. Number of SOX molecules here again regulating the activation of STAT5. So this is so much of complicated kind of mechanism that is happening in leprosy reactions. We are focusing here on activation of various kind of STAT molecule, basically focusing on STAT4 for TH1, STAT6 for TH2, STAT3 for TH17, and STAT3 basically regulating TH17 and T regulatory both. I haven't done this part with STAT5, but that is in my future plan. So this is the main rationale of study. This study was done with taking reactional cases, non-reactional, and a few healthy controls. This study is a part of an ICMR project. So till now we have included 16 non-reactional, 16 reactional cases and 5 healthy controls for our study. For the activation of STAT molecules, we have performed the Western blot technique we have used to just show the activation of STAT. Apart from Western blotting, we have also performed flow cytometrically phospho activation of STAT molecules. And for various kind of a T-cell subset study, we performed flow cytometric analysis. So in this one, this is the activation of STAT4. STAT4 is regulating interferon gamma. Here in this reactional, this is the control without any activation. This is 3/28 activation. I am using 3/28 activation, T-cell specific activation I am showing here. This is with reactional, this is with non-reactional, and this is with healthy controls. So here this is clearly that activation of STAT is more in reactional, STAT4 is as compared to non-reactional and in healthy. This is with STAT6 activation in reactional, in non-reactional, and in healthy. This is the flow cytometric analysis for interferon gamma and IL-4. So this is for interferon gamma. Here IFN gamma levels are high in reactional as compared to non-reactional and healthy. And here the production of IL-4, that is more in healthy and non-reactional as compared to reactional cases. So totally correlating with the results of STAT activation, where STAT activation was STAT4 and STAT6 activation is correlating with the cytokine production study. This is just a representative of phosphostaining, and these are the result of phosphostaining also. So phosphostaining is showing the same kind of result. This is with STAT3. The activation of STAT3 is regulating this IL-17 production, and we are getting more STAT3 in reactional as compared to non-reactional and healthy, and this is showing the flow results. With T regulatory cells, we also got the higher percentage, significantly higher percentage of T regulatory cells in reactional cases as compared to the non-reactional and healthy. So with overall of these kind of initial kind of finding, we can say that for the reaction, basically for management of leprosy, it is very much important to study the host pathogen interactions. Host pathogen interaction are very much important for vaccine designing, for biomarker and many of the things. So for understanding the basic biology, basic immunopathogenesis of leprosy reaction, how the production of cytokines is regulated by number of signaling molecules. Here we are focusing basically on the STAT activation. We can able to find out a good kind of biomarker that can able to provide little bit insight for the progression of reactions. So this is I can say about how far I have done with this. So this is all I have done in this 1.5 years of my project part. Thank you so much.
Thank you, Dr. Sharma. Are there any questions? If not, we'll go ahead with the next presentation. Thank you so much. Next speaker is Ms. Mansi Gupta. inviting Ms. Mansi to come and speak. Diagnostic clinical utility of granulocyte to lymphocyte ratio in patients with leprosy reaction. You've got 7 minutes. Wish you all the best.
Thank you, ma'am, for inviting me here. So today, I'm going to speak on diagnostic utility, clinical utility of granulocyte to lymphocyte ratio in patients with leprosy reactions. As there are leprosy reaction, type 1 reaction and type 2 reaction, which are immune-mediated complications, which can cause deformities and permanent disabilities. And the early diagnosis of reaction is challenging as they lack reliable biomarkers, and the GLR is marker derived from routine blood tests. It has shown promise in diagnosing various inflammatory diseases. The present study evaluates that GLR as a potential early diagnostic marker for leprosy reactions. So the aim of my study was to evaluate the diagnostic potential marker to granuloma lymphocyte ratio in identifying leprosy reactions, and the objective was to assess the accuracy of GLR as a biomarker or for early detection and differentiation for leprosy reactions. This study was a retrospective study which took place at TLM Community Hospital, Shahadra, Delhi. Total of 72 patients were enrolled in the study, from which non-reactional patients were 24, type 1 reaction were 27, and 21 was from T2R, type 2 reaction. The inclusion criteria for my study was untreated leprosy patients aged between 18 to 60, including non-reaction, type 1R and type 2R. And the exclusion criteria was the patients with comorbidities, TB, HIV, and pregnant females. Individuals with any concurrent diseases were excluded. Here is the workflow for my study, and the peripheral blood-venous blood collection was done in EDTA vials, followed by granulocyte and lymphocyte count by semi-automated biochemistry analyzer, and followed by granulocyte to lymphocyte ratio with the help of statistical analysis by using GraphPad Prism. Demographic characteristics of the recruited subjects was age, which was more or less same for all the non-reactional and reaction cases, and the gender, male were 16 in non-reactional cases, and 20 for T1R and 14 for T2R, and the female were 8, 7 and 7 for both the reactions. The mean BI was for non-reactional cases were 1.45 and 2.97 for T1R and 2.14 for T2R. And the mean granulocyte and lymphocyte ratio for T1R was 3.10, and for T2R it was 10.80, and non-reaction cases were 3.31. This scattered graph shows that the GLR across 3 subject groups, that is T1R, T2R and non-reactional cases. Statistical analysis was performed by one-way ANOVA test, Kruskal-Wallis test, which was non-parametric, and multiple comparisons were conducted by using Dunn's multiple comparison test. The key findings was for this study was that shows that elevated GLR compared to non-reactional cases and reaction cases. T2R patients had notably higher GLR than T1R, indicating a strong inflammatory response. Markedly, high GLR may help in differentiating T2R from T1R. Baseline GLR in non-reactional cases served as a very useful control for comparison. Followed by elevated GLR suggests as a strong association with the occurrence of leprosy reactions, particularly for T2R. And the findings suggest that GLR reflects the underlying inflammatory burden, and it could serve as a diagnostic indicator, probably for T2R. And as GLR is simple and cost-effective potential biomarker, it helps in distinguishing T2R and T1R, and showing as a predictive predictive marker for early diagnostic type 2 reaction, and the further studies are required for the validation. And for the future research, we have focused on the utility of GLR, including a large sample size, which could be designed to evaluate and validate our findings.
These are few references. And I would like to thank, lastly, to the director and the head of our knowledge management, TLMTI, and our Stanley Brown Laboratory team for providing me the necessary facilities to carry out this study. Thank you.
Thank you. Thank you, Dr. Mansi. We have 1 minute. Any question to Mansi? Thank you. Thank you, Mansi.
Thank you, sir.
Our last speaker, Dr. Ridhi Suresh Mehta. She will speak on an observational study of leprosy reactions in released from treatment cases at a tertiary care center. Reaction among the RFT patients.
Good evening, everyone. I am Dr. Ridhi Mehta. I am presenting a paper titled Leprosy Reactions in Patients Released from Treatment, an observational study at a tertiary care center. Released from treatment after completion of multi-drug therapy is generally considered indicative of disease control. However, immunological activity may persist even after bacteriological clearance. Delayed inflammatory reactions remain a major cause of neuritis and disability, particularly in multibacillary disease. Post-RFT reactions are often under-recognized and structured follow-up protocols are lacking. This study was undertaken to determine the incidence, clinical pattern, timing, and associated risk factors of leprosy reactions in patients post-RFT. The aims of this study are to determine the proportion of post-RFT reactions patients who develop leprosy reactions, to describe the types and temporal distribution of post-RFT reactions, and to describe clinical factors observed among patients who developed post-RFT reactions. It was a retrospective descriptive observational study conducted in the Department of Dermatology of a tertiary care hospital for 18 months. Over 43 patients diagnosed with leprosy who had completed MDT and were released from treatment were included. Patients with leprosy who had completed full course of WHO MDT were included, and newly diagnosed leprosy patients and patients currently receiving MDT or patients with incomplete treatment were excluded. Criteria for diagnosis of post-RFT reaction: type 1 reaction, sudden erythema and edema of pre-existing lesions with or without nerve tenderness or new nerve function impairment in the absence of systemic constitutional symptoms were included, and the criteria for type 2 reactions are multiple tender erythematous nodules with or without fever, malaise or peripheral edema with or without associated neuritis were included. Data collection was done and following variables were recorded: demographic profile, clinical spectrum of leprosy, type of reaction, time of onset after RFT, presence of neuritis, and past history of reactions. Data was analyzed descriptively using appropriate statistical tests. My results were: out of 43 patients, 14 developed leprosy reactions after released from treatment. Out of them, 3 patients were of borderline tuberculoid leprosy, 3 patients were of borderline lepromatous leprosy, 6 patients were of lepromatous leprosy, and 2 patients were of histoid leprosy. Out of 14 patients, 4 patients had type 1 reactions and 10 patients had type 2 reactions, suggesting type 2 reactions were observed more frequently than type 1 reaction. Out of mean onset for type 1 reactions was 4 months post-RFT, and mean onset for type 2 reaction was 6.7 months post-RFT. 12 patients had prior history of reaction and 10 patients had prior neuritis. These are the clinical images. First image shows necrotic ENL, second image shows multiple nodules suggesting type 2 reaction, third image shows erythematous plaques over back suggesting type 1 reaction, and fourth image shows swelling of hands in type 2 reaction. In the present study, 32.56% of patients develop leprosy reaction after released from treatment, indicating that completion of MDT does not necessarily signify immunological quiescence. A strong association was observed between post-RFT reactions and prior history of reactions as well as previous neuritis. This suggests that patients with prior immunological instability constitute a high-risk subgroup requiring closer surveillance. Type 2 reactions were more frequent than type 1 reaction, possibly reflecting higher bacillary load and persistent antigenic stimulus. The mean onset of reactions within 4 to 6.7 months post-RFT highlights a critical early monitoring window. Structured follow-up during this period may facilitate timely detection and prevent irreversible damage. These are the comparative studies. Narang et al. Reported viable bacilli in 15.6% of smear-positive patients at treatment completion, suggests that viable bacilli may be the cause of recurrent reactions. Shetty et al. And Gupta et al. Also demonstrated persistent disease activity at the end of 12 months MDT. These studies support our observation that immunological events may continue beyond bacteriological cure. These findings suggest that RFT does not equate to complete immunological inactivity. I hereby conclude by saying that leprosy reaction continue to occur in substantial proportion of patients after release from treatment, with type 2 being more frequent. Patients with prior history of reactions and neuritis appear particularly vulnerable and should be monitored closely during post-RFT period. Establishing structured follow-up protocols after MDT completion may aid in early recognition of reactions, prevent disability, and improve overall disease outcomes. These are my references. Thank you.
Thank you, Dr. Riddhi. Are there any questions for her? Thank you so much. Thank you all for your patient listening.
Thank you.
Good evening, everyone. The annual body general meeting for the conference is scheduled in Hall A today. So we would like to request all IL members to be present in Hall A. Also, we request sir and ma'am to be remain sir for the next sessions. Sir, please. Let's proceed with the next free paper session, which is the special sessions. May I now respectfully invite the chairpersons for this session, Dr. Chetan Solanki sir, Dr. Venkata Satya Prasad sir, and Dr. Shunil Anand sir to kindly take their seats on the dais. Ma'am, Dr. Chetan Solanki sir, Dr. Venkatesh Satya Prasad sir, and Dr. Sunil Anand sir. Ma'am, the last session, which is the TLMT 1 papers, free papers. Sorry, ma'am, there was some confusion. Chairpersons, ma'am, Dr. U. Sen Gupta, sir, Dr. Premal Das, sir, and Mr. Bino Vedi. So for the next session for today, the TLMT1 paper session, we'd like to invite respected Sir Dr. Utpal Sengupta Sir for the chairing the next session, and we'll also start with the first pre. So we'd also like to invite Dr. Subhajit Goswami sir for the first session, which is Understanding Healing, a Comparative Analysis in Chronic Disease with Leprosy. So please start.
Thank you. Just a clarification, I'm not a doctor. It is assumed that whoever attends the Lepcon is a doctor. You have managed to come this far, so I think you will tolerate us for the next few minutes. So to begin with, a common refrain that we are hearing since morning is, once you are released from treatment, it is not a guarantee that your suffering is over, right? You have complications, you have several other challenges that keep bothering you. And patients do come to us and ask, why do I not feel cured? And it's a legitimate question, right? And they would ask us that I don't feel like before, before I had contracted leprosy. And we really don't know how to respond to that question. As clinicians at the hospital tell me that we don't find ourselves equipped enough to answer this question. So that was a kind of a premise for the scoping review that we did. We realized that it is time to look into the existing literature and see how they are defining healing in leprosy. And there is also a global discourse on looking beyond cure and think in terms of the broader aspect of healing. And we are also quite confident of the fact that the current pathways of managing leprosy patients is purely biomedical focus, or largely. So we thought of asking us this question, that our scoping review will be about probing this question, that what constitutes healing in leprosy. And for that, we said that let's put our objectives very clear, which is, let's look at the existing literature, what they say about healing in leprosy. Let's look at other chronic diseases which are also stigmatizing, largely stigmatizing, and see how they are defining healing. And the third objective is that what are the models, what are the approaches that we can think of and we can learn from other chronic diseases and imbibe them in our program. So we scan through PubMed, PsycInfo. I have the Prisma diagram ready with me, but I'm sorry because it might be not too legible for you. So we looked at PubMed and PsycInfo. We scanned more than 3,700 studies, and based on the exclusion criteria, removing duplication, we zeroed in on 85 such studies from leprosy, tuberculosis, HIV, schizophrenia, and diabetes. And if you look at the studies that we have included, they are largely from low and middle income countries, which are focusing on stigma, inner well-being, healing, coping, resilience. These are the focus areas of these studies that we picked. And what we found is, if we go from the right to the left, in leprosy, healing is largely about physical cure and functional recovery, which is not the case for other 4 chronic diseases that we looked at. There it is about family support, person-centered cure, continuum of recovery, social integration, family support, ability to cope, resilience, and having positive interactions between provider and those who are needing the health care. And when we analyzed all these, looked at all those 85 studies, we realized that healing is not actually unidimensional. It has various dimensions to it. It has a physical dimension, of course, but it has 4 other dimensions: psychological, socioeconomic, socio-relational, and spiritual. So when we looked at each of those dimensions to see what leprosy can learn from each of these dimensions and what we can incorporate in our clinical setup, in our systems, in our programs, this is what we found. So most chronic diseases, they're talking about holistic care model that combines MDT with patient-led self-care. When it comes to, and there's a focus on lifestyle management also. When it comes to psychosocial, we saw the structured counseling and how that structured counseling is helping in not just treatment adherence, but also in reducing the number of cases that are lost to follow-ups. We see in HIV there's a cash transfer program when it comes to socioeconomic. In some countries there's a cash transfer program for HIV. For TB in India we have Nikshay, a nutrition support program. Then there was a focus on family-centered models and community-based rehabilitation. So when I say community-based rehabilitation, it is not just about restoring functional mobility. It is about giving community the ownership to take care of their own people. And of course, spirituality, engaging, leveraging faith healers to change the narrative from condemnation to compassion. So what are we going to do with all the insights that we are drawing from these studies? That's the way forward for us, which Dr. Joydeepa will present to you in some time. Thank you.
Thank you. Dr. Is there any question? Please. One question. Anybody? No, there is no question. Thank you for your Subhadeep. So Dr. Joydeepa can come.
Taking that conversation further that Shubhajit started, this was continuing to discuss what healing is. We developed this holistic care guideline in leprosy. Now this I see as a resonance of the discussions that we've had since morning, and the theme that we have this time is moving closer. I believe when we move closer to something, our clarity of vision improves. When we look at a mass of people, we see one blob. But when we go closer, every person becomes an individual. So that's exactly what's happening when we are when we are going towards the finishing line. Instead of seeing the en masse people of leprosy, now we have started looking at every person, and we are realizing every person is important, every person needs a holistic care, and every person consists just not of the physical skin and nerves, but he also consists of several domains that he has. So looking at the previous presentation, now I would present this guideline that was developed with the funding from Leprosy Research Initiative, and this is on the 3rd phase of the study, and we have completed this guideline. And there are some printed copies of that guideline which my colleagues would distribute among you all, and as I present the guideline, I would ask you to follow from that booklet. It will come to you shortly. So some of the questions that, some of the statements that our patients make is 12 months of MDT completed, I won't have any problems, would I? Or at RFT, the smears are not negative. Should I take MDT for some more time? What's the use of taking medicine? Look at my patch, it's not going. And my color, everyone is asking me about it. I told him, he keeps saying it will be okay. I don't trust him. This is about the doctor. On default, he says, I can't tell my employer. He will kick me out. I feel tired all the time. Then asking for leave, it's out of question. He's not happy that I asked so many questions. Whom then will I ask? They tell us, sit there, don't come near to me. They also say, it's a very bad ulcer. The leg has to be chopped off. And the healthcare provider says, he keeps asking about his disability. I don't think I have any answers. I feel so bad and inadequate. I know 12 months of MDT is not cure, but what can I do? I can only reassure. I'm afraid to ask questions. I'm afraid to ask his conditions about home. I can't deal with it. Last time he was very angry with me. His reactions are coming again and again. He always defaults, giving one excuse after the other. So these are the conversations we've had with persons affected by leprosy and also with healthcare providers. Patients don't feel healed and healthcare providers are not confident that they are providing healing. So we have come to this juncture where there is a need of a holistic guideline. Is it possible for someone to continue to feel healed despite living with reactions and disability? So this was the development process, and I'm going to talk about the guideline development with the expert review. I believe persons affected by leprosy are also experts, and people who are working in the field with their extensive qualifications and experience are also experts. So we did this in Bilaspur district in Chhattisgarh. We had 2 guideline meetings. One was in Delhi and one was in Chhattisgarh. The Delhi was with senior people from different aspects of life, mental health, social medicine, leprosy, TB, and other domains. And then persons affected by leprosy took part in the second meeting. And this was a scoping review that was presented to us. So we felt that leprosy is a journey. And it is a journey from diagnosis to treatment to MDT completion and beyond. And then there are several types of patients. Patients without any complications, just patches, reactions, and with deformities and ulcers. And this guideline has been developed as a bipartite guideline, which speaks to the healthcare worker and also to the patient. There are questions that a healthcare worker asks and also the patient asks. In provider pathway and in each section, there are the framework that is applied. So for example, in a provider pathway with complication, there will be complication counseling. They will be asked about mental health. They should be emphasized about family support, hope and treatment, and compassionate community in life. Provider pathway with complications, counseling, mental health, family support, keep reassuring and keep compassionate communications open. Provider pathways for long term, we have to talk about relapse. We have to talk about self-care, RCS, pensions and entitlements, follow-up plans, encouraging social reintegration, livelihood options, and mental health support. There are case stories that people would find interesting to read about how there were treatment struggles and adherence. Patient pathways is questions asked by Sapna, the mascot. It shows how the guideline empowers patients to ask questions, what they should know, what they should expect, and what rights and what support they should receive. So this is like the patient being empowered to ask and seek information. What are the strengths of the guideline? It is bipartite. It speaks to both. Integrates physical, psychosocial, and spiritual domain. It's a visual decision pathway, and it's practical, reproducible tools. Built into the guideline is communication, written plans for MDT and follow-up, check your attitude section, balanced information, supply and demand, provides ethical patient autonomy, and incorporates spiritual well-being, which is supportive in culturally relevant contexts. Clinical best practices principles, I'm going to talk about it tomorrow. Accurate, honest communication, continuity of care, respect, dignity, and empowerment, shared decision-making, and evidence-based explanation. There are some appendices which you can scan and find these practical tools and resources. It will be a dynamic document where all these appendices would be continuously edited and updated. And this is my acknowledgement, which I thank all the people who helped us to develop this guideline, and also for the funders. for this work. So this is a work in progress. We would like a lot of feedback from you, and then we would have a finalized version of it. We hope that it could be taken up in some manner in the program or in people who practice, so that they understand that the person is a holistic one, and that will enable healing in people affected by leprosy. Thank you.
Any question, please? Yes, Dr. Sandeep.
Thank you for the quite comprehensive presentation. I was just wondering, how does this particular guideline talks with the existing guidelines in terms of diagnosis, management, and other things? Because it's a whole package, isn't it? And it should talk with other documents that are also there.
Yes.
Especially if you think about psychosocial support, there is a mental health guide that has been recently developed for MTBs across just not leprosy. How do they talk with other documents? How does this particular guideline will talk with other documents? That's one question. And where does this begin to start with? Because care begins the time they know something is there in their body, isn't it? Because
yes.
That's when the whole process changes, life changes, everything changes. So is there a sort of a time points where you start?
Yeah, yes. So you saw that path journey. So the care begins. We actually started, the whole study was post-MDT care. But we realized that post-MDT care cannot happen unless it starts at the time of his registration, at the time he knows his diagnosis. So it has to start when he knows that he's a person who has contracted the disease. And the second question that you say, guidelines, how does it speak to the others? The guidelines are actually to keep in mind that a person is just not physical. The guidelines also should tell us that even though I'm looking at a reaction, the person is also having a mind of his own. He has an emotion of his own. He has a livelihood to take care. So that is where the guidelines comes in. And it talks to the patient, that talks to the provider, saying that apart from looking at the body, I do also have to take care of the other parts. I may not be able to do it myself, but I need to ask some questions and I need to signpost to the right people. If it is a mental health problem, I need to find referral pathways and put a person there. So this is an evolving document. So the next stage, the expert committee put us for the next stage where we would put up lots of scenarios, the case stories, which will enable people to say that, okay, if a person is suffering like this, this is what I should be looking at. If a person has encountered a stigmatizing event, I should be looking at such questions. So the compassion, the hope, the support, and the right framework that is there, that needs to be addressed. And we don't need to tell every patient everything. Those which are relevant only need to be told. So we classified the patients and we told them, you don't tell everything on the diagnosis day. You can break it into phases and tell them when they are ready to accept it. Because stigma won't be there at diagnosis, no need of talking about stigma at diagnosis. And livelihood will come later when he is unable to work. Mental health will come when he has accepted his disease. And more he will require a physical, the treatment, everything at the diagnosis. At RFT, he'll require what is RCS, what is entitlements, what are the pensions that we will get. So you have to break it down. So this is where the guideline breaks it down, takes the healthcare provider through a guide which will tell him that I needn't tell everything at one point. And where to talk, when to talk, how to talk, and what to talk is what this guideline is about. Thank you.
Okay, thank you. Thank you. Next speaker is Dr. Ritu Singh. Please come. I'm not telling the high title which is there already.
So just one announcement we need to make. There is an election for Central Council members going on the right side. So we will be starting in 5 minutes. So if any of you are IL member and want to vote, please come to the right side. And for the 10 minutes, for like next 10 to 15 minutes, we are open for voting. Thank you.
Good evening, everyone.
my title for presentation from detection to elimination, the role of multiplex PCR in leprosy control. So I'm going to give the overview, and main data is going to present by Dr. Vinay Pathak tomorrow in the morning session. So background is there is no gold standard method available for the diagnosis of leprosy. Experienced clinician can diagnose leprosy on the basis of cardinal signs and symptoms, and we can diagnose leprosy cases on the basis of Ziehl-Neelsen staining. And histopathological picture can also give us the idea if that patient is having disease or not. And there are few serological assays are also available, like NDO-BSA, PGL1, LID1, and molecular test is obviously we have heard in the morning session about PCR and all other tests. Why diagnosis is important? Diagnosis is important because we want to interrupt the disease and interrupt the transmission of the disease, and after diagnosis early treatment can be done, and after treatment transmission can be stopped, and we can stop the consequent disability in the patient also, and it will also help us in achieving zero leprosy target. So this table shows the few serological tests available for the diagnosis of leprosy, like PGL1 ELISA. It is most widely used test and detect IgM antibody, and it is useful in multibacillary cases also, but its sensitivity is that it is low sensitive in diagnosing the PB cases, and it cannot distinguish between active and versus past infection. And there is lateral flow assays available that is based on the PGL1 or recombinant antigen, and it is field friendly rapid test, and but it has also same limitation as the ELISA, and it has the reduced sensitivity in PB cases. NDO-LID is the combination of synthetic PGL1 and recombinant protein like LID1 and NDO-BSA, and it has higher sensitivity than the PGL1 alone, and it can detect PB and MB both cases, but it is also has the less sensitivity in the case of PB diagnosis. And multiplex serology is also available. It has the panel of recombinant antigens like ML2028, ML2055, and it can improve the sensitivity and specificity, and it is for the research use, and it has not been standardized for the routine diagnosis. Then now I am talking about the molecular test like PCR, different targets, RLAB 16S, SODE, quantitative PCR. I am not going to give the detail because it has been already discussed in many sessions. Multiplex PCR and reverse transcriptase PCR, LAMP based assay and NGS based assay. And now I am going to give the single gene based molecular methods and comparative diagnostic metrics about these genes. Like for RLAB, early detection can be done, and it is the best diagnostic method for if we are using the slit skin smear, and it can diagnose 90 to 95% of MB cases and 50 to 60% of PB cases. But for the diagnosis of PB, we are losing the PB cases for the diagnosis. 16S, rRNA, RPOT, SODE, HSP65, DNAK, GROW-L, and HSP targets are also available, but they have low sensitivity than the RLAB. So we have published few papers like SBL used 16S rRNA based RT-PCR method to determine the viability of mLepre in slit skin smear in leprosy patient in 2005, and viable mLepre was observed in environmental sample in 2008, and we have compared the different gene target, and we found that RLAB gene target is the best gene target, and among the samples slit skin smear is the best sample, and we have compared between the blood sample, slit skin smear, and saliva and nasal swab, and we found that slit skin smear is the best sample. And we also observed the positivity in the like CNS is involved, in those cases PCR is found to be useful for the diagnosis of leprosy cases. So we developed the multiplex PCR for the diagnosis of early cases of leprosy, and we found that this multiplex PCR can diagnose 100% of MB cases and 93.3% of PB cases. This paper has been published in Diagnostic Microbiology and Infectious Disease in 2019. And these are the gene target like RLEP, 16S, rRNA and SODE. And it is useful for diagnosis of early cases of leprosy. Those are PB cases. This is the comparative analysis of the single gene versus multiple genes, and we found that RLEP, 16S and SODE gene target is the best method. And it is useful for the diagnosis of PNL cases also. And so on the basis of this assay, we collaborated with the TrueNet and we developed this method. It has been standardized in the lab, and clinical validation also has been done. Field evaluation is going on, and we found that TrueNet result is comparable with the conventional multiplex PCR test in PB as well as MB cases. And this test has got CDSCO license also. So, diagnostic application in elimination of leprosy is multiplex PCR offers superior diagnostic yield over single gene like RLEP PCR in clinically challenging leprosy groups. And its integration into diagnostic algorithm and surveillance framework can strengthen early case detection, improve child leprosy monitoring as a sentinel indicator of transmission, and accelerate progress toward leprosy elimination. So take home message is multiplex PCR is not just a laboratory innovation, it is a clinical enabler for leprosy elimination, bridging the gap between early detection, contact tracing and programmatic surveillance. I want to thank Effect Hope, TLMGB and our host organization TLMTI and ICMR for giving the fund and giving the infrastructure for conducting the study on this. Thank you.
Question, please. Yes, Dr. Kaur. Mike.
Audible? Yeah.
Yes.
For multiplex PCR, which specimen you take for diagnosis of PNL?
Sir, it is approximately, we found that it is 53% positivity we found for the diagnosis of PNL cases.
Now, which specimen you take for diagnosis? Which specimen?
A specimen is we have tested in different samples like FNAC and nerve biopsy and skin biopsy as well. The highest sensitivity we are finding in nerve biopsy and FNAC sample, and in skin biopsy of the affected area is also giving the positivity about 50%.
Thank you.
And in FNAC and nerve biopsy samples, we are getting positivity about 90%.
Any more question? Thank you, Dr. Ritu.
Thank you so much.
Next speaker, Dr. Sesrun Nisa.
Hello, good afternoon, everyone.
Hello.
Myself.
Change the. Yes.
Good evening, everyone. Myself, Samronisa, and today I am going to present a sub-study of my of a trial. So, with the theme of Lepcon 2026, moving closer, with that theme in mind, it's high time that we dive into deeper issues of leprosy. So today my topic will be leprosy reactions at diagnosis in multiple bacillary patients, baseline data from WHO MB-MDT versus rifampicin, moxifloxacin and clarithromycin trial. So we all know that leprosy reactions, type 1 and type 2 reactions are immunological episodes triggered by Mycobacterium leprae, and the major cause, it's the major cause of nerve damage, disability and stigma. And leprosy often remains underdiagnosed. Burden reactions at the time of leprosy diagnosis represent an underdiagnosed burden to early detection with clinical and operational implications. Therefore, the aim of the study was to describe the clinical profile and severity of leprosy reactions among newly diagnosed patients presenting with reactions at diagnosis. So the objective was to describe the clinical profile of reactions among newly diagnosed leprosy patients, the demographics, nerve function impairment and severity of reactions calculated through validated clinical scoring tools. So as I said, it is a sub-study of the ongoing clinical trial. So the study cohort I had in this presentation was the patients suffering from leprosy reactions. So the data was collected from 4 TLM hospitals, and all the patients recruited in RMC trial with reactions at diagnosis were included in the analysis. And type 1 severity scale and NL severity scale was used. Descriptive statistics and was performed for statistical analysis. So out of 280 MB patients, we found that 104, that is 37% of the patients presented with type 1 reaction and 30% presented with type 2 reaction. We also found that the woman to man ratio in type 1 reaction was found to be 0.1:1%, and type 2 reaction was found to be 3:7%, indicating that men were suffering, the burden of type 2 reaction was more on men compared to women. And 42% of the patients with reactions belong to the productive age group, that is 15 to 34 years. Majority of the patients lived on daily wages with an average monthly household income of less than 10,000. The very fact that 42% of the patients belonging to the productive age group, where the livelihood depends mostly on daily wages, we can understand the burden of reactions in leprosy. More than 20% of type 1 reaction patients presented with nerve function impairment, and more than 50% of the type 2 reaction patients presented with NFI. 58% recorded moderate to severe type 1 reaction, and 27% recorded moderate to severe type 2 reaction, indicating that all these patients can go into disability, again highlighting the burden of reactions in leprosy. So in the present study, we found that 48% of the proportion of the patients presented with reactions at baseline, which suggests that many individuals were diagnosed at a very complicated stage of the disease. Newly diagnosed MB patients with reactions marks a significant delay in detection and diagnosis of leprosy. Therefore, the reactions at diagnosis are not merely clinical events, but markers of missed opportunities for early detection. 28% of the patients with grade 1 and grade 2 disability is highly alarming. Several studies from the endemic regions have shown that poor awareness of the early symptom stigma, reliance on traditional healers and misdiagnosis at primary care level contribute to these delays. Reactions should be diagnosed very early so that the patients do not, so that the reactions do not go under moderate to severe stage. Reaction-focused early case findings, active case findings, training of healthcare workers, and awareness campaigns are critical to early diagnosis of the reaction, preventing progression of disability and severity. Integration of screening tools at primary healthcare centers will facilitate early recognition of the reactions. Further research should quantify actual delay versus perceived delay and implement public health interventions to diagnose and managing reactions better. In conclusion, high frequency and severity of leprosy reactions at baseline in our cohort reflects delayed diagnosis and prolonged untreated disease and should be considered an indirect epidemiological indicator of case detection delay and a warning sign of persistent gaps in early leprosy control efforts. Severe reactions impact mental, social, and livelihood domains of a person. If intervened appropriately, quality of life and disease outcomes will definitely improve. Thank you.
Paper is open for discussion. Any question, please? From the audience, any question? If there is no question, thank you. Thank you, Dr.
Thank you, sir.
Next speaker is Shreyoshi Dorman.
Thank you, sir. Good evening, respected chairperson and audience. I am Shreyoshi Dorman from the Leprosy Mission Trust India, Purulia, West Bengal. I am going to present our study on impact on reaction and neuritis on mental well-being among female patients with leprosy. This study focused not only on physical complication but also on the psychological impact experienced by women. Leprosy reactions are acute inflammatory episodes that occur before, during, or even after completion of MDT. Type 1 reaction, also called reversal reaction, and type 2 reaction, known as ENL, are the most common forms. These reactions can cause severe nerve inflammation, intense pain, sensory loss, motor weakness, and sometimes permanent deformities. They are unpredictable and may recur multiple times. Because of this, many patients require prolonged corticosteroid therapy, which itself may cause side effects like weight gain, mood changes, and other systemic complications. Apart from physical suffering, patients experience long-term pain, visible deformities, social stigma, and discrimination. All these factors significantly reduce mental well-being and quality of life. Women are especially vulnerable. Due to gender equality, financial dependence, household responsibilities, and social expectations, their psychological burden becomes even greater. However, mental health among female patients with reaction and neuritis remains inadequately studied. This gap led us to conduct this study. The objective of this study was evaluate the impact of leprosy reaction and neuritis on mental well-being among female patients. Using Warwick-Edinburgh Mental Well-being Scale, which is validated tool for assessing positive mental health. This was a descriptive case series conducted over a period of 4 weeks. We included 10 female leprosy patients aged between 20 to 65 years. who were diagnosed with reaction and neuritis. Mental well-being was assessed using Warwick-Edinburgh Mental Well-being Scale, commonly known as WEM-WBS. The scale measures aspects such as optimism, positive feeling, energy, good relationship, relaxation, clear thinking, and ability to deal with problems. The results: the total sample size was 10 female patients with reaction and neuritis. The WEM-WBS scores ranged from 27 to 52, with total range of 25 points. The mean score was 36. When we analyzed the distribution, 9 participants, which is 90%, had moderate mental well-being. 1 participant, that is 10%, had low mental well-being. Importantly, none of the participants had high mental well-being scores. The mean score of 36 indicate that overall mental well-being was moderate. However, the absence of high well-being scores suggests that all participants experienced some degree of psychological impact. The presence of low well-being in 10% of participants indicates significant psychological distress in a subset of patients. From clinical perspective, moderate scores should not be considered normal or satisfactory. They indicate psychological vulnerability. Lower scores were associated with emotional distress, fear of disability, anxiety about future, and burden of chronic disease. These findings suggest that reaction and neuritis do not affect only nerves, they also affect emotional health. In conclusion, reaction and neuritis negatively impact the mental well-being of female leprosy patients. Psychological assessment and support should be integrated into routine leprosy care. Along with medical management, further large-scale community-based studies are needed to strengthen the evidence and guide policy decision. These are few references.
Paper is open for discussion.
Thank you for
Any
your
question?
kind attention.
Any question? If there is no question, thank you.
Thank you.
Dr. Sreyashi. Now here the session ends. I think this all from TLM with a mixed bag, and session ends here. Thank you very much for your patient hearing and all the speakers for speaking and keeping within the limit. Time limit is maintained. Okay, thank you very much.